Good morning, esteemed guest.
Distinguished faculty members and postgraduates.
Myself, Dr. KZ Jacob, second year postgraduate.
Myself, Dr. Yogeshwar Kalla, second year postgraduate.
We are delighted to have you join us today for our CME event focusing on neuropathology and salivary gland tumors, organized by the Department of Pathology at BLDE, deemed to be University, Shri Patil Medical College, Hospital and Research Center, Vijayapura.
On behalf of the Department of Pathology, we extend our heartfelt gratitude to all of you for being here with us. We are privileged to have eminent speakers and esteemed guests in our midst to share their immense knowledge and experience with us.
Let us not wait any longer and delve straight into today's feast of assorted scientific sessions. The first event to commence our CME is the plenary session on approach to diagnosis of salivary gland neoplasms by Dr. Shantvi Rupin, sir.
To chair the session, I would request Dr. P.J. Ernal, sir, Professor and Head, Department of Pathology, SNMC, Bagalkot, and Dr. M.B. Patil, sir, Vice Principal, Clinical, and Professor of Surgery, Shri B.M. Patil Medical College, Hospital and Research Center, Vijayapura, to occupy the seats on the dais.
Thank you, sir. I request the chairpersons to introduce our speaker for the session.
Good morning, all. Once again, as briefed by our residents, I welcome you all for this wonderful CME, which is being conducted by Department of Pathology of our esteemed medical college. I'll be delighted and privileged to introduce the first speaker, Dr. Shantvi Rupin. He is an esteemed pathologist, currently serving as Executive Registrar and Professor and Head in the Department of Pathology at NIMS, Hyderabad. He is alumni from MR Medical College and postgraduate at the same institution. He joined NIMS as SR and has taken on additional responsibility as in charge of stem cell facility and nodal officer for HMIs at NIMS. He has interest in surgical pathology and hematopathology with a focus on joint diseases, lung pathology and hemostatic diseases. He had his specialized training through prestigious fellowships, including Praful Desai UICC Fellowship in Oncopathology from TMH Mumbai and Geraldine Jeeler Scholarship for a visiting clinical program in pulmonary pathology at Mayo Clinic, Arizona. His contributions to the field have been recognized with numerous awards as Best Junior Faculty of NIMS, Nagalotimat Excellence Teaching Award, MR Pathsatri, and Dr. A.V. Ram Prasad Silver Plaque Award. And he's also a prolific author and presenter with 122 publications in national and international journals. I think big applaud for your contribution, sir. Thank you. And also contributions to textbook chapters, and has been invited guest faculty in various national and international conferences. He is also Secretary and Treasurer of the Indian Academy of Pathology and Organizing Secretary for major conferences such as APCON 2010 and ACME 2015. Here I welcome Dr. Shantvi Rupin to go ahead with his first lecture. Thank you, sir.
Good morning, everyone, and thank you for those kind words, sir. First of all, I would like to thank the faculty and the management of BLD for invite. And I'm always happy to be here. I have been coming here quite often. And when this invite came, I couldn't refuse. So I've been asked to speak on salivary gland tumors, though I am general surgicals as well as hematopathologist. So my areas of interest are usually bone and soft tissue tumors and lung pathology, but I do report surgical pathology. So I thought, let me discuss something not routine. So, but a disclaimer, I am not an expert in this area. So, so let me, I have kept it very basic because I thought the crowd will be mainly postgraduate students. So in salivary gland tumors, it is, you know that it is very extensive. A lot of entities are there. And some of those entities are so rare that you may not see one in your career. But the thing is, you should know the common things and how to approach these tumors, because that is very important, because head and neck tumors are quite common and most of the surgical pathologists come across these tumors, and cytopathology also, because it's a very accessible organ. So you have a lot of FNAs and various reporting systems. The current reporting system, Milan reporting system is there. I don't do cytology, so I'm not covering the cytology of it. I will be only stressing upon the histopathology, and that to a basic approach. How do you diagnose salivary gland tumors? So this may sound very, very basic, but let us start with, we know that there are three pairs of major salivary glands, which is parotid, submandibular, and sublingual glands. Apart from that, there are around 500 to 1,000 lobules of minor salivary glands within the submucosa of the oral cavity. This is only to tell you where all these lesions can occur, because if you know where these organs are situated and tissue is situated, and that could be the origin of these lesions, and you should suspect, especially if it occurs in a parotid region, you are sure that it's a site, but in oral cavity or respiratory tract or a nasal cavity, it may have differentials with other tumors which are not related to salivary gland tumors. So you should know that there is salivary gland type of tissue exists in these organs as well, like nasal cavity, larynx, bronchi. They don't produce saliva, but histologically they are similar to minor salivary glands. So similar type of lesions like a pleomorphic adenoma. Since I report a lot of lung tumors, in the lung, especially the central tumors, you do get a lot of salivary mucoepidermoids in lung. You get adenoid cystics in lungs, epithelial, myoepithelial carcinomas in lungs. So unless you are aware that these glands are situated in these sites as well, you will not be able to think of these entities when you are making a diagnosis. Okay. Coming to the, why it's not moving? Is it moving? Okay, sorry. Fine. So you should also know the structure, because it has certain elements, because some of these lesions are either show differentiation towards those structures within the normal salivary, acini, and ductal system. So it has, depending upon what type of salivary glands you are looking, like you have a secretory component, you have a ductal component, and secretory component involves serous component and the mucus cells, and in the duct which carries these secretions, you have intercalated ducts, striated ducts, and excreted ducts. So when you are looking at a tumor, first is whether it's salivary gland origin, then try to tell what differentiation it is going towards. Sometimes there is a combination of elements. Those things I'll come to later. And you also know there are certain glands, as like a parotid gland has a lot of serous component, hardly any mucus cells. Submandibular, it varies with the type, especially in sublingual, a lot of mucus cells will be there with a lesser component of the serous cells. Coming to the cell types, this is important when you are trying to use your immunohistochemical approach to categorize the tumor. Like you know, in the acini, the cells, you have a inner lining of acinar cells surrounded by a myoepithelial cell. So these are the two combinations you can see. And when it comes to intercollected ducts, again you have a cuboidal cells, but outside it is again a layer of myoepithelial cells. But the striated and the excreted ducts, you have inner epithelial cells and surrounded by basal cells. So each of these cell components have their immunophenotype. Now we do a lot of immunohistochemistries and all sometimes, because there is a lot of overlap, not only a morphological overlap, even IHC overlap in salivary gland tumors. You can sometimes IHC becomes more confusing when you are doing it, especially in a salivary glands where it doesn't have a typical morphology. That's why you should be aware of what component of an acini or a ductal system or a basal cells or a myoepithelial cells, and what is the immunophenotype of each of these cells, so that you can make a correct diagnosis. So just showing the normal histology where these components are situated. You have acini, mucus cells. I mean, acini cells are usually bluish in color, and because of the zymogen granules. And then you have intercalated ducts, which are very small ducts, which are seen adjacent to those acini. Then you have a striated duct which looks very eosinophilic, oncocytic. If you see a normal salivary tissue, there is striated ducts are very oncophilic cytoplasm is there, and then you have these interlobular ducts. So these are the morphology of different cell components which you see. Coming to the next part where you should understand is what marker is present in which component. That is why I'm taking you gradually, because you understand how a normal histology recapitulates its tumors or tumors recapitulate the histology. So coming to the SNR cells, they are usually amylase positive, and they are all pan cytokeratin positive. Ductal cells and the other cells in these are all main important components. These epithelial cell component is CK7 positive. That will help you to identify CK7 positive, EMA positive, and CEA positive are the cells which are the ductal or luminal component when you are seeing a salivary gland neoplasm. Then, whereas high molecular weight cytokeratin, vimentin, P63, and myoid markers are negative in this ductal component. The reverse is the true for myoepithelial and basal component. So when you are identifying a tumor of a salivary gland, you are trying to see whether there is an epithelial differentiation, or it is a myoid or a basal cell differentiation, or a combination of these. So this marker profile usually helps in categorizing whether it is a biphenotypic tumor having both the components, or it is having one type of cells which is predominantly only ductal component, or it is a myoepithelioma which is only myoepithelial component. So this will help you when you are morphologically not able to differentiate. You can use this IHC profile to identify each of these component and make a diagnosis. Okay. And the difference between a basal and myoepithelial is absence of myoid component, as well as S100 and GFAP will be negative in basal cell component, which is present in case of a myoepithelial component. So just a normal salivary tissue, how an IHC looks. If you do a IHC on a normal salivary tissue, I wanted to show you how the CK7 stains that ductal epithelial component. See this EMA and cytokeratin 7. Then CEA also luminal staining of this epithelial component. P63, if you see, outside dots, nuclear, but the P63 is a nuclear stain. So it is staining the myoepithelial cells around those serous acini. So to show you on the normal tissue, and this is again S100 staining those myoepithelial cells which are surrounding the ducts as well as the acina structures. And this is also colponin, again a myoid marker. You see the central cells, which are the acinar cells, are unstained, whereas the normal myoepithelials are stained. So this is a normal salivary gland tissue, how different components are stained with a routine stains, which we use for same things we use for IHC. Just want to show you how it looks like if you stain a normal salivary tissue with various markers. Coming to certain general features of salivary gland tumors, these are account for almost 0.3 to 13.5 cases per lakh population, slightly more common in females. And you have to remember this, 80 to 90% are epithelial tumors, not mesenchymal tumors are not common in salivary gland, and 75% of them are benign. And most common is the pleomorphic adenoma. So if you are sure, how do you identify a pleomorphic adenoma? Because pleomorphic adenoma can have varied morphology. I'll show you some of the examples. If you can identify a pleomorphic adenoma as such, in many a times you are correct. So because it constitutes the majority of the salivary gland tumors. So you have, but it has morphological variants. It can be epithelial rich, it can be stroma rich, and that makes a confusion, especially if the tissue is not sufficient, or if you don't have IHC, sometimes it may cause. Otherwise, routine diagnosis of pleomorphic adenoma, each and every postgraduate is aware of, and it is the simplest diagnosis to make. So, but one thing you have to remember, certain tumors have predilection for major salivary glands, certain tumors have predilection for minor salivary. So if you are aware, say I am having a oral cavity tumor, what are the things I should consider first? So either I will consider a polymorphous adenocarcinoma or an adenoid cystic carcinoma. So if it is a parotid tumor, okay, basal cell adenoma, basal cell carcinoma, pleomorphic adenoma. So you should know what are the sites where certain salivary gland tumors have predilection for. That also I'll touch upon. And these salivary gland tumors are rare in children, but those which occur in children are 50% malignant. Malignant tumors are more common in children compared to adults. Adults, if you say majority, I said 75% are benign. But the same salivary gland tumor, if it is in childhood, then you have to start suspect malignancy, especially mucoepidermoid carcinomas. We have seen quite a few in young patients. So that you should be aware of. Coming to the list, this is the latest WHO 2023 classification. There have been, I'll not go into the each and every entity because it's almost impossible to cover everything. I would just tell you some changes that have happened. The previous edition was 2017. So 2017 edition, they have made certain changes. One is the one which are highlighted in orange color, intercalated duct adenoma and striated duct adenoma has been added as an entity, and also the keratocystoma. These are new entities under benign epithelial tumors which have been added to this group. And the sclerosing polycystic adenoma is the entity which was there before, but the neoplastic nature was not categorized properly there. It was doubtful whether it is a lesion or it's a tumor. So now they consider that this is an neoplastic lesion and it is categorized under benign epithelial tumors. Coming to the malignant epithelial tumors, apart from the same tumors which are carried forward, there are two entities. One is microsecretory adenocarcinoma and the other one is sclerosing microcystic adenocarcinoma, which are added. So as postgraduates, you should know what are the changes that happen from a previous edition to the current edition. Okay. Coming to the other changes, certain important points which have been discussed in case of this 2023, I just want to update you on that. One is the terminology of intraductal papillary mucinous neoplasm, similar to IPMNs, which we use in pancreas. So similar entities are known to be happening in the salivary gland tumors, and these they think they are having a peculiar mutation, that is AKT1 mutation, which is this AKT1 mutation are also seen in mucinous adenocarcinomas of the parotid or salivary glands. And they say that these could be the precursor lesions for this mucinous adenocarcinoma. So this is considered as one of the discussions that is there in the current WHO 2023. And there is we used to have an oncocytic carcinoma. Still it is there in current WHO as an emerging entity, but they question whether this is a separate entity or most of these oncocytic carcinomas represent oncocytic change in other tumors like a mucoepidermal carcinoma with oncocytic change and all. So the existence of this entity as a separate category or a separate lesion is little questionable at present, but still it is grouped and is as a emerging entity in this new classification. And carcinosarcoma, which we have an epithelial malignant component plus a mesenchymal malignant component together in a salivary gland tumor, which we used to report. We in fact we have published also, but they say that whether that sarcomatous component is actually mesenchymal component or it is a epithelial mesenchymal transition of an epithelial component showing mesenchymal differentiation, that is a questionable entity. So, but still as such, a carcinosarcoma is now as a separate category in WHO, but they have a this query whether it represents a true carcinosarcoma or it is just the mesenchymal component being a transition from an epithelial component. So these are the changes that are there in our 2023 WHO. And the most important thing is, now molecular diagnosis is taking over everything in pathology, and most of the things, say CNS tumors is almost, you can't report CNS tumors without doing any molecular testing, and so happens with lymphomas to subcategorize and all, and soft tissue tumors. Some of the tumors are now defined by their molecular abnormality. So unless we are doing it, it becomes very difficult. And molecular alterations are included in the definition of some of these salivary gland tumors, which are I have highlighted. Mucoepidermal carcinoma has this mammal 2 rearrangement. So that is definitely included in the definition of the tumors. And same thing with adenoid cystic, which is either MIB or MIB-L1 or NPIB. These are the rearrangements which are seen in these tumors. Secretive carcinoma has a very specific ETV6 or red alterations. Polymorphous adenocarcinoma, hyalinizing clear cell carcinoma, mucinous adenocarcinoma I also already discussed, and then microsecretory adenoma. These have very specific alterations, and these alterations are included in the definition of these tumors. So that is another change that has happened in 2023. So you should be aware these changes happen, especially certain changes are very helpful. Say carcinoma X pleomorphic adenoma. The patient has a plaque gene abnormalities in pleomorphic adenoma. The same holds true for a patient who develops a carcinoma in a pleomorphic adenoma. So those things are helpful in such situations. Say, a salivary duct carcinoma, like morphology, develops in a carcinoma ex pleomorphic adenoma, but you want to know whether it's a primary tumor or it has arisen in the background of pleomorphic adenoma, apart from the history of recurrent tumors or a long-standing benign tumor becoming malignant. You can use this molecular alteration to see whether it has originated from a pre-existing pleomorphic adenoma. So these are now molecular diagnosis has become very important, and I must confess that we don't do these molecular testing in our setup. Most of the times we are doing IHCs for salivary tumors, but we do have molecular panel with us like FISH and PCR, which we use for other tumors, which we have not established for salivary tumors. So coming to the how to approach, I have already told you should know basic histology, cell of origin, their immunoprofile of the normal cell constituents of a salivary tissue. Then also which site is predominantly. So there are certain tumors which are predominantly seen in major salivary glands. So I have listed all these things. You can you should know which malignant, which benign tumors occur in a major salivary glands. And minor salivary glands, I said polymorphous low-grade adenocarcinoma or a hyalinizing clear cell carcinoma. They are more common in palate where the minor salivary glands are there. And certain benign tumors like duct papilloma or a canalicular adenoma, they are more common in those locations. So when you are looking at a tumor arising in a parotid or a submandibular gland, you should think of these possibilities. If you are seeing a lesion which is arising in the palate or a oral cavity, you should think of those entities. But always there are overlaps. There can be entities rarely occurring in these sites. And there are certain tumors which don't have this distinction. They occur in both major as well as minor salivary glands. I have listed them as separately at the bottom, that mucoepidermoid, adenoid cystic, salivary gland carcinoma not otherwise specified. They can occur everywhere, including myoepithelial carcinoma, and a pleomorphic adenoma, myoepithelioma, or a cystadenoma of salivary glands. These also can occur in both the sites. So you should know what are the tumors which are exclusive or more common in a major salivary gland, and the tumors which are more common in minor salivary glands, and the tumors which can occur in both the locations. So if you are aware of this, one step is cleared. So next you will approach the morphology. This is based on the location. Then you should know that which are sites where malignant tumor proportion is more and a benign tumor. So that thing you have to remember. And if you see the salivary tumors, the frequency, which organ is more commonly affected by these tumors, that is the second approach you have to see. Majority of the salivary tumors occur in parotid, 65%, submandibular 10%, sublingual 1%, and minor salivary glands overall, all the locations include 25%. One thing you have to remember is, as you go from a major salivary gland to these minor salivary glands, your risk of malignant tumor increases. So if you find a tumor in the parotid, your benign tumor is more likely. If the same tumor occurs in a minor salivary gland location, malignant tumors are more common. So those things you have to keep. And other locations, if you are seeing in, there are 50% chances of that tumor being a benign or a malignant. So if you have this approach in your mind, then it is easier before even looking at morphology of the tumor, you have some idea what I am maybe looking at and how I should approach this tumor. Okay. Coming to the why it is so difficult. So those salivary gland tumors are seen by everybody. It is very challenging because these are not so common as a routine, say, carcinomas of the GI or anything. So these are rare tumors and they have a broad morphology. If you see the list of entities, so many entities are there. So that makes life difficult. If you see the list of tumors in any of the WHOs, if you see soft tissue tumors is a big list. That is one area where it is very difficult. Lymphomas are such a huge classification. Even salivary gland tumors have a lot of list and different entities. They are not so, each one has its unique morphology and overlapping IHC profiles and all those things. So that is why it is complex, and they have a complex architecture. The same variant, same tumor, pleomorphic adenoma can look different in different compositions. So that makes it difficult. And they have as I mentioned, they have overlapping immunohistochemical profiles. They have, even if you do IHC, sometimes it is difficult to differentiate one from the other. And sampling may also be affected. So if you have a smaller biopsy, which is predominantly taking one area, which is not representative of the entire lesion, then it becomes a problem. So microscopic approach is first thing you have to look, because when we are looking at certain salivary gland tumors like a myoepithelioma versus a myoepithelial carcinoma, basal cell adenoma versus a basal cell carcinoma, the cell morphology is not so much variable. Just whether it is invasive or not makes a difference. So you have to see whether it's a invasive tumor or a not invasive tumor. Cellular components, what are the types of cells? I am seeing one type of cell or two types of cell, that or three types of cells. That is important. What is the architectural arrangement of the cell and individual cell components and the stroma, especially certain tumors like pleomorphic adenoma and all. You should look at the stroma, whether the stroma has this typical morphology, and apart from that, certain tumors have basement membrane like material and all those things. So those are all the identifying things which will help in narrowing your differentials. Coming to the features, each of these features, invasion, this is the most important feature, and most of the circumscribed lesions are benign. So that is one clue, is that every lesion which looks very well circumscribed is a benign lesion, and infiltrative lesions are obviously malignant tumors. But there are exceptions that you have to remember. Actinic cell carcinomas, carcinoma ex pleomorphic adenoma, they can have circumscribed orders. As at the same time, pleomorphic adenoma can have projections outside. So though it is a benign, it can have a nodules away from the main lesion. So there are exceptions, but you have to see the general rule, that is to be what these tumors follow. And pattern of infiltration is also important, whether it's a pushing type of infiltration or a irregular tongue-like infiltration. Certain tumors have this pushing type of infiltration, and I have listed them, and irregular tongue-like infiltrations are seen in the other carcinomas. Coming to the other important thing you should look for, especially very important hallmark for adenoid cystic carcinoma, it is always perineural invasion. So that is sometimes if you don't find and meticulously grasp, and if you have a differential between adenoid cystic carcinoma, say other tumor which is looking like adenoid cystic, if you have a perineural invasion, you are confident to call it as a adenoid cystic carcinoma. And those things you have to remember. And as I already mentioned, the different distinction between a myoepithelial or a basal cell adenoma versus a malignant tumors of these entities is mainly invasion. Morphology, the myoepithelial carcinoma may look as bland as a myoepithelioma, or an oncocytoma can, or versus an oncocytic carcinoma, they can look very, very similar. A basal cell adenoma versus a basal cell adenocarcinoma, similar looking. You can't make any difference. Then invasion becomes very important. Unless that is biopsied properly, you have given the sections from the margin of the tumor, properly adequately crossed, and those things are very important in making a diagnosis. That's why small biopsies, needle core biopsies and all becomes difficult if they have not taken the interface between the normal tissue and the lesion. And coming to the population of cells, I said we are monomorphous looking population versus a two types or a three type of cells. That is another approach. So I'm just telling you the basic approach where you will try to subcategorize the tumor and then go for morphology. And so I have listed down benign tumors with one type of cells, malignant tumors with one type of cells, or combination of cells. The other way of looking at is whether there is a myoepithelial cell participation in the tumor. Though that you can do when your IHC morphology, if it is not obvious, whether the tumor has a myoepithelial, apart from epithelial component, does it have a myoepithelial component? And if the myoepithelial component is present, is very obvious component, or it is only seen in small areas and all. So those are listed in this. These things I'll share with you people. You can, because it's difficult to just remember like that. So these are the things you should. What are the benign tumors and malignant tumors which have a myoepithelial component with and that? That is also very helpful in subcategorizing these tumors. Okay. Coming to the last part of it, the histological features, which we are thinking architectural. So there are tumors which have a predominant cribriform pattern. Which are the benign tumors which have that, and which are the ones which are yellowish, highlighted yellow are very typical of that tumor. Like adenoid cystic carcinoma of cribriform, if it comes to your mind, you first think of adenoid cystic, but you have to remember there are other entities which can have this cribriform pattern of growth. So the important ones only I have highlighted. Otherwise, you can have a tubular pattern both in adenoid cystic and other adenocarcinomas. You can have a fascicular pattern in a myoepithelial tumor and a papillary pattern in certain tumors, like especially Warthin's can have a papillary pattern in benign, and intraductal carcinomas can have papillary pattern in case of malignant. You can have a lattice-like pattern in myoepithelial carcinoma. The one which are in yellow are very important. They are very typical of those. Oncocytic cells, if you see in a salivary gland, you will think two entities first. One is Warthin's tumor and an oncocytoma. So those are very important. Though mucoepidermoid carcinoma can have an oncocytic variant. So these things you have to remember. And even a pleomorphic adenoma sometimes can show a prominent oncocytic component. So those things you have to remember. And coming to a squamous areas, obviously a keratocystoma will have Warthin's tumor, especially that has infarcted and has undergone squamous metaplasia, can have a lot of squamous epithelium in that. Obviously, squamous cell carcinoma will have it. Pleomorphic adenoma can show a squamous metaplasia, basal cell adenomas, and myoepitheliomas. So, if you find these components, start thinking of these entities. Basal cells, which are very usually dark staining cells with a scant cytoplasm. Basaloid cells, obviously, it will be a basal cell adenoma or a basal cell adenocarcinoma. But apart from that, other entities can have this basaloid morphology, especially if you look at an adenoid cystic carcinoma. Cells are solid variant. I'm not telling the cribriform variant. If it is a solid variant, again, it will look very basaloid, very dark staining nucleus with a scant cytoplasm. So those things come under a basaloid morphology. Spindle cell morphology you can have in a myoepithelial tumors and other pleomorphic adenoma with stroma-rich pleomorphic adenomas and all those things. So try to categorize whether it is invasive, non-invasive, circumscribed, non-circumscribed, architecture, one type of cells, multiple type of cells, what pattern, basic architectural, cribriform, tubular, fascicular, or a basaloid looking cells, or a clear looking cells, and eosinophilic, oncocytic looking cells. So all these things, if you try to put it together, you usually try to narrow down your differential diagnosis. If required, you do IHC and confirm it. Last resort is you can always go for, if they have a typical molecular signature, then you go for molecular testing to confirm those things. Clear cells can be there in certain tumors, especially myoepithelial tumors, that you should be aware of. Coming to this is a diagrammatic representation to just show you how these tumors fall into these groups. If you see sebaceous tumors, clear cell tumors, mucinous adenocarcinoma, these can have predominantly clear looking cells. Then the other side are the cells which have eosinophilic appearance, like a salivary duct carcinoma, so secretory carcinomas and all. The blue circle indicates the tumors which look very basaloid. And the center which are falling can have a combination of clear cells, eosinophilic cells, and a basaloid cells. This will tell you which spectrum these tumors, based on the morphology, you can categorize, and these tumors are falling into different areas based on the morphology of the cells. And coming to the stroma, I said the certain tumors have a stromal component, which can be either a hyaline basement membrane-like material, and this is usually seen in myoepithelial and basal cell differentiation tumors. And intraluminal ductal lumen may also contain some secretory material, and cartilage you can see in your pleomorphic adenomas and carcinosarcomas, and these are the various types of stroma that can be seen in these tumors. What I'll do is, since I have a slide seminar in the one of the sessions, so I'll not cover all the lesions now in this talk. I'll just show a few examples of a benign tumors. Some of the malignant tumors I'll cover in the slide seminar, so that it should not be repetitive and it gets boring. So coming to the commonest entity, the pleomorphic adenoma, we know that we have described that it is usually a circumscribed tumor, but it can have buds of tumor extending outside and even some nodules away from the capsule. And this is one of the tumor which has variable growth pattern. You may think that pleomorphic adenoma is a very easy diagnosis, but same thing which occurs in a nasal cavity or comes from a unusual location makes it difficult. So unless you are aware, especially not having a typical biphasic pattern of an epithelial and stromal component, that is easy. But if you have a predominant epithelial, predominantly stromal, it becomes difficult. So you have to be aware of, this is one of the commonest entity. Everybody should be aware how to make a diagnosis. So usually has a tubular structures. If you see very closely these tubular structures, you can make out this. Like these are ductal-like structures and which have some secretions, and there is a stroma adjacent to that which is there. And if you see closely, can I have a pointer here? This works? Yeah. See this if you see, there is a epithelial component which is pink in color, and outside cells are all having clear cytoplasm. So it has an epithelial component and a wrapping up of a myoepithelial component around these structures. If you see the IHC also, CK7 inside and myoepithelial marker outside. And what is peculiar about this is the myoepithelial component melts into the stroma. So almost there you can't make a distinction. In basal cell adenoma is different. In basal cell adenoma also you will have epithelial component and a myoepithelial component. But myoepithelial component is very, very distinct. It is almost like a line marked around it. Here, sometimes it becomes difficult where this myoepithelial lining is merging into the adjacent stroma. So that is an important clue for a diagnosis of pleomorphic adenoma. That you have to remember. Especially it happens problem when you are having a cellular pleomorphic adenoma versus a basal cell adenoma. People report this as that and this that as this. So that is one thing you have to remember. Okay. Why it is not moving? Yeah. So these components are there, and along with that you have that lot prominent stroma, and there can be areas of squamous differentiation with keratin. And one thing you have to remember is this keratin formation is more you can see only in pleomorphic adenoma. You don't see in a mucoepidermide. Keratin formation is not common in mucoepidermide. That you have to remember, though you have a squamous component there. So those are subtle things you should remember when you are seeing a squamous component. Okay, it is cellular area. Normally, you may not mistake a mucoepidermide with a say pleomorphic adenoma, but in certain situations, small tissues, you may have a different difficulty. If you have a keratin formation, that's more likely that is a metaplastic area than in a pleomorphic adenoma rather than a mucoepidermide carcinoma. So these are examples showing images of different areas. And the problem I told you, when it becomes problem is when such tumors are there, very difficult to identify the ductal component, then it becomes a difficult. Here, if you closely look at it, there are some ductal structures here. These are there. So other thing, all is myoepithelial, and this is myoepithelial rich, almost looking like a clear cell tumor down, which is there. It's almost like a myoepithelial cells can have epithelial morphology, spindle cell morphology, clear cell morphology, plasmacytoid, oncocytoid, everything is possible there. So those things here, you see those almost looking like a rhabdoid cells. Those are all myoepithelial cells. If you stain them for myoepithelial markers, and if these components predominant, again, if you don't identify the ductal component, you will call it as a myoepithelioma. That's what it happens. Like if the components are not properly identified, you start calling one tumor for the other tumor. And it can sometimes show even mature adipose tissue and all in pleomorphic adenoma. So these things you have to be remembering. This stroma which is there is a very defining component of a pleomorphic adenoma. So you have to try to look for this chondromyxoid stroma, which is very classical for this. Okay. Coming to the examples of a cellular pleomorphic adenoma, where you may have to look for several sections to identify a stromal component. This tumor was in the oral cavity, and oral cavity, you were looking at the epithelial component, start thinking that it is an epithelial tumor. Unless you search and several sections and focal areas, you start identifying a stromal component. So that can be a problem. See, this is the another tumor. This is entirely stroma. Hardly these entrapped islands of epithelial elements are there. Such cases again become a default. You can think it as a mesenchymal tumor or chondroid neoplasm or something. So only those cells are epithelial component which are seen in a predominantly stromal background. If you do a cytokeratin, highlight those epithelial cells, and you can identify that this is not a mesenchymal tumor, but a biphasic tumor has an epithelial and mesenchymal component. So these are the examples. I have shown you some IHCs also. for you to see that CK7 EMA staining the epithelial component and calponin and P63 staining the myoepithelial component. Not required in a routine pleomorphic adenoma, but for teaching purpose, I thought I should show you how the epithelial component is highlighted by the CK7, EMA, and CEA you use for the ductal or a epithelial component, and calponin, SMA, S100, and all these things, P63, P40, you can use for myoepithelial component. So these are salivary gland tumors are peculiar in that they can show GFAP. GFAP where we use CNS tumors. So that will be also positive in salivary gland tumors. That can also be used. Okay. I have already mentioned that now certain molecular alterations are seen in these entities, and one of the important molecular alteration for a pleomorphic adenoma is PLAG1. So this IHC is also available. We don't have this. So instead of molecular testing by PCR or the other thing, you can use this antibody. This is the nuclear positivity will be seen. Other is HMGA2 that is also seen. So various differential diagnosis depending upon what predominant component you are looking at, either if it's a epithelial predominant, again a basal cell adenoma, or if it is a myoepithelial predominant, myoepithelioma, various differentials enter into this entity depending upon what component you are looking at. Coming to the basal cell adenoma, I was telling you, again a benign entity which has this epithelial as well as myoepithelial, but stroma is not very prominent here compared to pleomorphic adenoma. Say if you pleomorphic adenoma minus a stroma is basal cell adenoma. That's how you should consider that as. But there are variants which can have a little bit of stroma and some spindle cell stroma. That I'll show you an example of that also. And this, as I mentioned, has a epithelial cells inside and luminal cells which are paler, and you can identify them as a cuboidal cells with pale nuclei, and outside you have myoepithelial cells which will be showing palisading. The palisading is an important clue for basal cell adenoma. Usually you don't see that palisading in case of pleomorphic adenoma, and this is an example of a basal cell adenoma with a myoepithelial derived stroma. This can be confused with pleomorphic adenoma, the upper one I am telling. So, but only thing is here the clue is it has a lot of palisading. You can make out the palisade. That is the clue that, and there is a cellular stroma there. So that is nothing but a basal cell adenoma with myoepithelium derived stroma. And at the same time, those myoepithelial cells at the periphery are not merging into the stroma. That is another clue that it is a basal cell adenoma with stroma rather than a pleomorphic adenoma. And this is variants which can have hyaline globule-like thing. This is called membranous basal cell adenoma. I'm just showing you examples. All these things are available in the textbooks. The only thing is you just have to see some cases, then you start identifying those entities. Basal cell adenomas are known to have beta-catenin mutations, and this as well as LEF1 can be used for differentiating these entity from other tumors which have a mimics like adenoid cystic carcinomas and all. And differentials I have already mentioned. Basal cell adenocarcinoma and adenoma is only by invasion. Coming to the next is myoepithelial tumor. Predominantly it consists of myoepithelial cells, and I have said myoepithelial cells can look from epithelioid to spindle cell to clear cell. So depending upon that, the morphology of myoepithelium also varies. You can have a spindle cell looking tumor or a clear cell looking tumor, oncocytic looking tumor, epithelioid looking tumor. So these are all possible. So this is one of that example. This is which had a vesicular, almost spindle cell mesenchymal tumor like morphology of a myoepithelium. But if you do a cytokeratin, these are positive. Mesenchymal tumors will not show cytokeratin positivity. So that will help. Clear cell looking tumor can be, this is the lower one is a clear cell variant of myoepithelial tumor. Just to simplify, whenever you're looking at a tumor which has both ductal component and myoepithelial component, you have to see which is predominant. Ductal is predominant or myoepithelial tumor. So if it is predominant ductal with little myoepithelial, then it is a ductal epithelium rich pleomorphic adenoma. Classical pleomorphic adenoma has both component almost in equal proportions with the chondroid or other changes. If it is stroma is predominant with lesser epithelial component, then it is stroma rich pleomorphic adenoma. And if it is predominantly myoepithelial cells with a little ductal component, then it is myoepithelium rich pleomorphic adenoma. And if it is only myoepithelium, then it is no ductal component, then it is myoepithelium. Just you remember this, depending upon the combination of a ductal and myoepithelial component, you can make these considerations. So the basal cell adenocarcinoma can also have this spectrum. So pleomorphic adenoma minus stroma simplified basal cell adenoma. That's what you have to think, because it has both components. And basal cell adenoma minus ductal cell is a myoepithelium. Okay. So coming to the other entity, which is a benign entity, oncocytoma, as the name suggests, it consists of oncocytic cells, well circumscribed tumor. All benign tumors are well circumscribed, abundant eosinophilic cytoplasm, and sometimes they can have a clear cytoplasm, which is a clear cell variant. And this is the morphology. If you see, very obvious, the cells are either in nests, lobules, nests, or sometimes you can have a ductal structures also lined by this abundant eosinophilic granular cytoplasm. That will help in identifying. These are all various magnifications showing this morphology of an oncocytoma. There is another entity is oncocytosis, which is just a normal salivary tissue has an oncocytic hyperplasia. How to differentiate an oncocytoma from an oncocytic hyperplasia is there the lobular shape is maintained in the case of oncocytosis. Here you will have a nodule, tumor-like nodule in cases of a oncocytoma. It may have capsule also. That will also help in identifying this entity. This is an example of one of the cases of if you see normal lobules are there also, fat is there, and there is one lobule has become oncocytic. That is oncocytosis. It's not an oncocytoma. This is closer view of that. Again, some of these lobules showing oncocytosis. Sorry. So, how do you assess a malignant in certain tumors of the salivary gland? If especially this is very important in a myoepithelial tumor, basal cell tumor, and oncocytic neoplasm. I have already mentioned this. They look very similar. Both benign and malignant tumors look similar. And what you have to do in such cases is whether it is invasive or not. That is the first question you have to think of. If it is invasive, then it is obviously malignant. If there is no invasion, then look for other features. First, look for invasion is present or not. If there is a cellular atypia, necrosis, and readily identifiable mitotic figures, then it is malignant. None of the above, benign. If there is a focal capsular invasion or mild cellular atypia with occasional mitotic figures, then you call it as uncertain malignant potential. So this is what we approach if we are looking at a tumors which look very basaloid, oncocytic, or myoepithelial-like tumors, because sometimes it's very difficult. We may say that it is a myoepithelioma, later on it may turn out to be myoepithelial carcinomas, especially the ones which are bland. If they are showing obviously a lot of mitotic activity, areas of necrosis, pleomorphism, then we are okay. But they can look very blind. Even the malignant tumors can look blind. So this is the obvious, every resident knows this entity. This is Wadin's tumor having a, if you see those papillary or a cystic papillary tumor, which has this bilayered oncocytic epithelium with a lymphoid stroma. Everybody knows this, and then this is a typical morphology. I don't have to explain this entity at all. And this has a luminal and as well as the outer layer of cells, which are all both eosinophilic. What is important is sometimes it can have extensive squamous metaplasia, even areas of mucous metaplasia, which are seen in that case. That becomes a difficulty. Lymphoepithelial cyst or some other, or you can sometimes you also call it as a mucoepidermoid carcinoma. This is possible. This, especially in cytology and all, if you have these squamous epithelials, mucous cells, then you start thinking that it is a mucoepidermoid carcinoma. So you have to remember they can undergo squamous metaplasia as well as mucinous metaplasia. This is one of the cases which were. This is a case of inverted papilloma, which was diagnosed, and this has this transition like epithelium showing typical. This is another case of a benign tumor, sebaceous adenoma. You have central sebaceous cells, peripheral basaloid cells. So these are all different type of salivary gland tumors. I end this talk here only so that I'll discuss the malignant tumors in the slide seminar. I just wanted to give brief outline of how to go about it, because this is a complex thing and you can't cover every entity in a short talk. Okay. Any questions?
Now open for discussion. Any questions?
Okay.
Is there possible
Hmm.
salivary gland tumors in cricopharynx? I recently got an endoscopic biopsy.
You can get salivary gland type of tumors in the pharyngeal areas because their minor salivary glands are distributed there also. You can get.
But in net, I searched that I'm not getting it.
No, some of these glands are distributed. We think that they are distributed in only in these areas, but they can go down also and they can be seen in the lower areas also. I think I have seen even in one in esophagus also, I think. So lower down also we can find. So there is nothing stops from these type of tumors having in the lower down on the aerodigestive tract, and trachea and all are the common. You get a lot of time. I mean, almost when a central tumor comes to us, first thing our differential is, apart from routine adenocarcinoma, squamous and small cell, we always think of salivary gland tumors as one of the, apart from the carcinoids, of course. So we do find all these things. Only thing is they are not so common. Oral cavity, nasal cavity, quite a few things, and lower down comes down, but we can see there is nothing stops it from having there.
Thank you.
Mimics, but they think that these are all having the similar. That's what I was telling you, the sentence. They're salivary gland like tumors, they are called, because they have a similar thing. They don't secrete saliva, but they can have a similar components, whatever, like certain skin adnexal tumors and a breast tumors which have similar things. So they have a typical components of myoepithelials and epithelial components, so they can be called like that.
So,
No, I have not seen so many. I must say that I must confess that I don't see cystadenomas. We have seen they can have a cribriform patterns and other patterns also. They can have those things, but I have not seen most of the art tumors which we have come across. The problem probably for NIMS is we are a tertiary care center. Most of the salivary gland tumors, which are routine ones, get operated outside. We may be getting only the ones which are not managed in the periphery. So we may get a complicated ones and recurrent ones, or a malignant transformation. Patient had a long-standing tumor, and so that's why if you see our salivary gland numbers are not so high because they are all treated. Like we don't get routine. I am telling the gynec may even cervix, CS cervix or an appendix is a very difficult thing for us to get. So we do get. It's not that we don't get, but it's not in the numbers which we see. That's what it is.
Is it a must that you include INC for all the salivary?
No, we don't use. Most of the times we don't use salivary. Actually, I have shown you that don't take it that every case we use. It's pleomorphic adenomas and routine things we don't. But especially in malignant things, adenoid cystics and all, we just confirm, like we are not missing a polymorphous looking like an adenoid cystic, and those things we always do markers. But routine tumors we don't do, like a routine straightforward tumors like a pleomorphic or a basal cell adenoma. We don't do ISCs. We just Warden say there's nothing is there to make a diagnosis on that. But difficult ones like those things we just sometimes oral cavity tumor, small biopsies they do. We don't know, sometimes an epithelial tumor which is infiltrating, or it's a salivary gland tumor which is ulcerating the mucosa. Those are the ones, especially on the biopsies. Before excision, what they do a biopsy, that makes us difficult. Then definitely we do in such situation in case of a biopsy from a oral cavity, where we have to differentiate squamous carcinoma versus a salivary type of tumor and all. It is a variant of basal cell adenoma. The morphology is little different, but the components are same. It has the only thing which is the way it looks is little different, and it has a location is typical for a canalicular adenoma. It has those bilayered epithelium like things, no? So that canalicular adenoma is now is a variant of basal cell adenoma only. Yeah. You can see that also in that. But here it is more trabecular lattice-like pattern in case of a routine basal cell adenoma. If you see a canalicular adenoma, it has a different morphology. But the component, cell component is same. Like you have an epithelial component and a epithelial component. Anything else?
Thank you very much, sir, for extensive discussion on approach. I just have one question. Where do you expect, I'm a surgeon, where do you expect us to do a biopsy? In which patients of salivary gland tumors? Because a majority of the times you can diagnose.
Actually, most of the time salivary gland tumors, because they're very superficial, they are all FNAC done properly. And if they have a difficulty, then you have to go for a biopsy. If most of the times in our setup also, FNAC is the first thing to be done. Though I don't look at routine FNA, long time I have left cytology. But most of the times FNA is enough. But if they have an issue and if you clinically think what they are telling on a cytology is not matching with your clinical or imaging profile, better to get a biopsy and confirm and those things. And usually helpful if you are having a biopsy to do IHC. But nowadays cell blocks can be prepared and you can do a IHC on cell block also.
Thank you, sir. Thank you very much.
Thank you.
Thank the organizers for giving this opportunity. Thank you.
Thank you. We thank Dr. Shantwe, sir, for the comprehensive insights and expertise for illuminating the complexities of salivary gland neoplasms.
We thank Dr. Yarnal, sir, and Dr. M.B. Patil, sir, for chairing the session. I would request the chairpersons to present Dr. Shantvi Rupin, sir, with a certificate and a token of appreciation.
Thank you, sir. Now I request Dr. Vijayalakshmi Patil, ma'am, to present the certificate and a token of gratitude to our chairpersons.
Thank you, sir. Thank you, ma'am. Moving on to the next plenary session, it is on Understanding WHO CNS Tumors 5th edition, a case-based approach by Dr. Megha Upin, ma'am.
To chair the session, I would now request Dr. Rajashri Ingin, ma'am, Professor and Head, Department of Pathology, Gulbarga Institute of Medical Science, Kalburgi, and Dr. Mallappa Huggi, sir, Neurosurgeon and Assistant Professor, Department of Surgery, Shri B.M. Patil Medical College, Hospital and Research Center, Vijayapura.
I request our chairpersons to introduce the speaker for the session.
Thank you very much. It's my great privilege to introduce Dr. Megha S. Upin, Additional Professor in the Department of Pathology at Nizam's Institute of Medical Sciences, Hyderabad. Dr. Megha is a distinguished expert in surgical pathology, neuropathology, medical renal pathology, and molecular pathology with specialized training from the prestigious Mayo Clinic, Rochester, USA. Her academic and research contributions are extensive, with over 200 publications in international and national index journals and 7 book chapters. She has also served as guest editor for a special issue on neuropathology published in IAPM Journal in May 2022, and also co-edited the 3rd edition of Essentials of Diagnostic Surgical Neuropathology. Dr. Megha's excellence in her field has been recognized with numerous awards, including the ICMR Young Scientist Award, Best Junior Faculty at NIMS, and the Telangana State Best Teacher Award. She is a life member of several esteemed professional bodies such as Indian Association of Pathologists and Microbiologists, the Indian Society of Renal and Transplantation Pathology, the Neuropath Society of India, and the Hyderabad Academy of Pathologists. It is an honor to welcome Dr. Megha Upin among us. Her expertise in neuropathology and steadfast dedication to the study of neurological disorders continue to inspire and elevate our understanding. Dr. Megha Upin.
Thank you very much, Madam, for that kind introduction. And so I'm basically going to talk on understanding of WHO CNS 5. So all of you as residents of pathology would know that the last edition of the WHO Blue Book for CNS tumors came in December 2021. It's been already 1.5 years since the edition came. For the practicing neuropathologists like us also, it took a while to understand the changes which were going on. There were some complex changes, and I'm just simplifying those changes for you to understand how to report the common brain tumors. Yeah, it is there now. It's still not in the slideshow mode, no? It's coming now. Okay. So I think we now have blue books for all the systems. We also understand that we are very fast moving from morphology to molecular genetics. Molecular pathology has become a very essential component of all the classification schema, and we need to understand why we need to understand or read these blue books. And that is, there are reasons for the classification schema to be present in the practice of pathology. The most important of which is that it creates a single platform or a single structure for uniform reporting. It determines the incidence and prevalence of a particular neoplasm, and most importantly, the diagnosis or the molecular diagnosis that you give to a tumor is what is going to decide how this patient will be treated further. So these are very important aspects of learning WHO classification schemas and understanding the diagnostic part of it. So I'm going to talk about the principles of changes which have happened in the WHO CNS classification with the help of certain cases. And we have to remember that WHO classification is always a work in progress. There is no single edition, and that is why many editions keep on coming. There are updates, and we have to keep ourselves updated with the changes to remain valid in the current diagnostic practice. So in 2016, I think you all have heard of these preliminary molecular genetics, which was spoken about in CNS tumors. We all knew about IDH mutations, which is a standard of care in diagnosis of gliomas, ATRX. We have heard of histone mutations. The late reporting had already started as given by the Harlem Consensus Diagnostic System. And the grading was still for a long time based on morphologic appearances, and adult and pediatric gliomas were starting to get separated, but they were not completely defined in the 2016 system. So after the 2016 book, a lot of publications came through this group, which is called as C-Impact. It was called as a consortium for informing molecular and practical approaches in CNS tumor taxonomy. So this group was comprised of the bigwigs of CNS tumor pathology, who actually form the editorial board of CNS Blue Book on tumors. And they have published 7 articles which talked about changes in molecular spectrum of these tumors. It was called as now, that is not officially WHO, but the same publications were incorporated in the updated 2021 classification of the CNS tumors, which is the current Blue Book that we follow. So these are only, to get you familiar with the people who are involved in making these classification changes. And these are a group of people who come from mostly from US, Europe, some from Asia, who get together, talk about tumors and make the changes. And if you happen to wonder, I mean, if you people don't really know, is there a pointer here? Yeah. So this is Dr. David Louis. Um, mm, I'm not able to show this. The top one, na? The pointer is not working, I think. He is Dr. David Louis. He is the main person, the editor of the CNS classification. Dr. David Ellison, Dr. Katerina. She's from Mayo Clinic. I worked under her. And there are many others from the Europe and the US counterpart. If you're working, where do we stand in this classification schema? Then there are neuropathologists in India who have contributed very important chapters in this Blue Book. You all would have heard of Dr. Chitra Sarkar, Dr. Vani Santosh from NIMHANS, and others who have majorly contributed. So there is a big Indian contribution also to the current WHO edition of the CNS tumors. Now, if you go through the first chapter of this Blue Book, then these are the entities that you will see. So there are about 14 chapters which deal with various CNS neoplasms, and it would be beyond the scope of today's lecture to take you through all these tumors. So what I have chosen to do is I'm going to cover the most frequent ones which we report in the surgical neuropathology practice and talk about them in a case-based approach. So one thing which you will understand in the classification of gliomas is now the classification consists of circumscribed gliomas and diffuse gliomas. So that understanding is firstly more very important, that how to define a circumscribed glioma and a diffuse glioma. And because this is a radiology connotation, we have to try to read at least the MRI description of these tumors to know whether we are looking at a circumscribed tumor or a diffuse tumor. In many of the cases wherein this information is not given to us, then we can define the circumscription with the help of neurofilament stain. So this stain basically highlights the axons. So if you see in the right side, you can see those axons running through the tumor. That means the tumor is infiltrating the normal brain parenchyma, in its diffuse in nature. Whereas in the left side picture, you are not able to see those axons. That means the tumor is circumscribed. There are other features on morphology, particularly called as perineuronal satellitosis, in which the tumor cells try and almost encircle the normal neurons, which is again a feature of a diffuse nature of the tumor. So first thing is you have to define whether you are looking at a diffuse or a circumscribed tumor. So to begin with adult diffuse gliomas, you all know the grading pattern. One thing which demarcates CNS tumors from the rest of the systemic body tumors is in CNS tumor, there is no staging. There is no TNM staging. There are no radical resections. There is no metastasis. So these are the tumors which are localized to the brain and they are aggressive because of their location. They compress on certain vital structures and that is what results in the morbidity and the mortality of these tumors. So what is ubiquitously followed in reporting of CNS tumor is its grading. So every primary brain tumor is defined by its grade, and that is the most important diagnostic as well as a clinical clue which you give to the neurosurgeon or the neuro-oncologist is define the tumor by its appropriate grade. Now, when you talk about adult diffuse gliomas, you know that there are three grades at least, the grade 2, grade 3 and grade 4. And we have to understand that this grading still to a large extent depends on morphology. So if the tumor shows only pleomorphism and atypia in absence of mitotic activity, it is grade 2. Once there is mitotic activity, it is grade 3. And if in addition to that, there is necrosis and or microvascular proliferation, it is grade 4. So this is depicted by a mnemonic Cottel's Amen, and these criteria are still valid when you are looking at an HND stain. So we begin with a simple example of a 34-year-old male. You can see a tumor in the parieto-occipital region. It's a big tumor. It's squashing the ventricles. That means there is a mass effect on the adjacent brain. And this is the morphology on a HND stain. You can understand that it looks astrocytic. There is fibrillary background. Here on the right side, you can see an atypical mitotic activity also. So there is pleomorphism. There is atypia. On HND, you have decided that it looks like a grade 3 tumor. Now, whenever you come across a glioma, now the panel which includes basic panel, which is a part of immunohistochemistry, includes IDH1, R132H, ATRX, P53, and of course Ki67. Now, what do you see in this? I mean, if anybody wish to talk, it will become easy for me. What does the IDH show? It's positive. What does the ATRX show? It is actually positive only in the normal structures. If you see the tumor cells, they are negative. So IDH mutations on immunohistochemistry is defined by its cytoplasmic positivity, whereas ATRX mutations are defined on immunohistochemistry by its nuclear negativity. So interpretation of immunohistochemistry is also important, and you can see majority of the tumor cell nuclei show P53 expression. An astrocytic tumor, which is showing mitosis, which is IDH mutant, it is also ATRX and P53 mutant, is a very characteristic example of an astrocytic neoplasm. So if it was 2016, between 16 to 21, you would have labeled it as an astrocytoma, IDH mutant, WHO grade 3. The same tumor after 2021 classification, you will see the changes. The changes are the anaplastic terminology has been removed from the tumors. Now the tumor will only be defined by its cell of lineage, which is astrocytoma. The Roman numericals are converted into Arabic numericals. And now, according to the alt classification schema, every tumor is defined by its essential and desirable diagnostic criteria. These criteria is a part of every blue book systemic tumor classification. So whether you are dealing with a thyroid tumor or a renal tumor or a bladder tumor, you will invariably see that there are criteria which are called as essential and desirable. Essential criteria need to be fulfilled before you give a WHO diagnosis to a tumor. Desirable criteria are not necessary. If they are there, that strengthens the diagnosis of the WHO classification. Now, IDH mutations were thought to be very important markers of good prognosis in astrocytomas in oligodendrogliomas. So that was thought to be a single most predictive as well as prognostic biomarker for adult diffuse gliomas. But what was found later on in the studies on these IDH mutant tumors is there is another molecular abnormality which was in the form of CDKN2AB homozygous deletion. If it was identified in the astrocytic tumors, then the survival of those patients were much lesser in comparison to the patients who did not identify that abnormality. So now the IDH mutant astrocytomas were further classified with the help of CDKN2A2B homozygous deletion, and this testing can be done with fluorescence in situ hybridization, which we do in our department. And that stratifies the IDH mutant astrocytomas into 3 categories. So because this tumor was showing homozygous deletion, which is a very important marker for an aggressive behavior in an astrocytoma, the final diagnosis in this case will be astrocytoma IDH mutant CNS WHO grade 4. So that is the diagnosis that we give. But along with every diagnosis, you have to give a layered pattern of reporting. So the layers of that diagnosis first include an integrated diagnosis. Then you have to talk about histologic diagnosis, whether it is an astrocytoma, glioblastoma, or an oligodendroglioma. You have to define the CNS WHO grade. And you have to write what is the molecular information or the molecular techniques which have been done in this case. So we have done immunohistochemistry to prove the IDH, the ATRX, and the P53 mutations. And we have done FISH for the CDKN2A2B homozygous deletion. So once anybody, whether it's a second pathologist or a neurosurgeon or a neuro-oncologist, looks at your report, everything is clear to that person as to what all you have done on this tissue and how you have reached the diagnosis. One more thing I would like to stress is unless you do the molecular studies, the WHO classification does not allow you to give a WHO grade to the tumor. So suppose you people don't have the molecular techniques in your institute, you don't even have immunohistochemistry. In such cases, you have to give only histologic diagnosis saying it's an astrocytoma histologic grade 3 and CNS tumor diagnosis cannot be given. And you can refer the same case to a tertiary care center wherever the molecular diagnosis is available to give a final CNS WHO grade. That is the importance of doing molecular techniques in CNS tumors. So this is called as a combined histomolecular grading. And this is about IDH mutant astrocytomas. As I said, the amine grading remains. That is, there is atypia, mitosis, necrosis, and MVP. But if suppose there is a grade 2 or a grade 3 tumor, which does not have necrosis or microvascular proliferation, so long as it shows CDKN2A2B homozygous deletion, it will still be called as a grade 4 tumor. So that is the importance of doing all the molecular techniques in astrocytic tumors of the brain. Again, an elderly patient, this is more common in our practice. These are the tumors which we invariably see almost every second day in surgical neuropathology practice. An elderly patient, big mass and SOL in the brain, very marked perilesional edema, mass effect, contrast enhancement, and on MRI, everybody is certain that you are looking at a high-grade glioma. So on HND also, this tumor is very cellular. You can see the cellularity, even the ATP at this magnification. As you go higher, you look at the pleomorphism, the giant cells, atypical mitosis, and then you see the foci of ischemic as well as palisading necrosis. So what are we looking at? Of course, we are looking at a glioblastoma, a dominant tumor in any neuropathology practice. We run the same 4 markers. We do IDH, we do ATRX, P53, and Ki67. What is the IDH in this case? It's only background actually. The tumor cytoplasm should be positive, so it's negative. ATRX is showing bright nuclear retention in all the tumor cells, and P53 is negative. So this was in 63-year-old male, histologically glioblastoma, IDH on immunohistochemistry is negative, and in patients who are more than 55 years of age, immunohistochemistry is enough to say that it's a wild-type tumor, and this will be classified as glioblastoma, IDH wild-type, CNS WHO grade 4. So the understanding of glioblastoma is glioblastoma now only is an IDH wild-type tumor. If a tumor looks like a glioblastoma but shows IDH mutations, it will be called as astrocytoma, CNS WHO grade 4. If it is a wild type tumor, only it will be labeled as glioblastoma. So the only IDH wild type diffuse glioma in the CNS WHO classification system is glioblastoma IDH wild type. There are no low-grade astrocytomas which are IDH wild type, and if the tumor is IDH mutant, looks like a glioblastoma, it should be called as astrocytoma grade 4. In patients who are more than 55 years of age, immunohistochemistry with IDH1R132H is enough to say that the tumor is wild type. If the tumor looks like a GBM, but the patient is younger than 55 years of age, the immunohistochemistry is negative, then you have to do additional techniques to rule out IDH mutations like a PCR or a Sanger sequencing or NGS. Anything you can do to look for IDH mutations. If they are negative, then you will call it as a wild type tumor. There are additional molecular abnormalities which define glioblastomas in the form of third promoter mutations, EGFR amplifications, addition of chromosome 7 and deletion of chromosome 10. So these are three important molecular abnormalities in IDH wild type tumors. If they are there, then only you can label the tumor as glioblastoma IDH wild type CNS WHO grade 4. So this understanding is very important between the differences between astrocytoma and glioblastoma. Coming to the next case, elderly or a middle-aged patient, 45-year-old male who presented with seizures, hemiparesis, and there was a lesion in the frontal region. Now you look at the morphology of the tumor. I think this is a very familiar morphology. What does it look like? Very good. So you see the perinuclear clearing, the chicken wire capillary pattern, calcifications are not there. It looks on this image, it looks low grade, but you go to the other sections and you see foci of microvascular proliferation. There is focal necrosis. And if you look at the adjacent brain, you see the perineuronal satellitosis. Is this enough? This is enough to give a histologic type of oligodendroglioma to the tumor. But if you have to define the same tumor molecularly, because it is a part of adult diffuse glioma, again you do IDH. So IDH is very brightly positive. IDH positivity will be defined as positive if it shows cytoplasmic positivity. There can be combined cytoplasmic and nuclear expression also. Unlike astrocytomas, oligodendrogliomas do not express ATRX mutations. So ATRX is retained. It doesn't even have P53 mutations. So P53 is negative. Ki67 is high. One more molecular technique that you need to do in oligodendrogliomas to give it a CNS WHO grade is FISH for 1p19q co-deletion. So there is complete deletion of the 1p and the 19q to define oligodendroglioma. So this is one of the image of FISH. So 1p and 19q is defined by an orange dot. So if there are two green and one red dot in more than 70% of the nuclei of the tumor, that is defined as 1p19q co-deletion. Only after doing this can you label this tumor as oligodendroglioma IDH mutant 1p19q co-deleted CNS WHO grade 3. So the grade 3 has come from the presence of mitosis, necrosis, and MVP, and the oligodendroglioma has been defined by presence of IDH mutant and 1p19q co-deletion. So this is very important before you give a WHO diagnosis. There are certain other molecular immunohistochemical surrogates which are coming if you don't have FISH analysis in your institute, and they say that H3K27Me3 loss is a good predictor of 1p19q deletion. So if you have a tumor which looks like oligo, it is IDH mutant, ATRX retained, P53 negative, then you can do H3K27Me3. If it is lost, it's equal to 1p19q co-deletion, and you can give a CNS WHO grade to that tumor. So that is about, so there are only 3 entities under the category of adult diffuse gliomas, that is astrocytoma, oligodendroglioma, and glioblastoma. Both astrocytomas and oligos are IDH mutant. Astrocytomas are defined by additional ATRX mutations, whereas oligodendrogliomas are defined by 1p19q co-deletion. The only wild type tumor in the CNS classification is glioblastoma. Now you go ahead with pediatric tumors. This is for the first time in the 2021 classification that the adult and the pediatric tumors are completely separated with the help of their molecular genetics. So if you have a glioblastoma in the child, it's obviously looking like its adult counterpart. It will have atypia, mitosis, necrosis, MVP. But genetically, the pediatric glioblastomas are entirely different from adult glioblastomas, and this understanding has been given by the CNS WHO 5. So the IDH mutations, which are the defining mutations of adult diffuse gliomas, are not seen in pediatric tumors. The prevalence of IDH mutations in pediatric tumors is about 2 to 4%, very less. So on the other hand, the pediatric tumors are defined by histone modifications and MAP kinase pathway mutations. I think you all need to hear these terminologies at least for you to understand what is broadly going on in the CNS classification. So the pediatric type of gliomas are divided into low grade and the high grade. Grading again is very important because the low grade tumors are less aggressive and the high grade tumors are more aggressive, because again they show morphologic features of high grade in the form of mitosis, necrosis, and MVP. One important thing which separates adult diffuse gliomas from pediatric diffuse gliomas is low-grade pediatric diffuse gliomas do not progress to high-grade tumors, which is not the case with adult tumors. So if you have an adult grade 2 astrocytoma, during the course in life, it will invariably progress to grade 3 and grade 4. This does not happen with pediatric tumors. So the pediatric low-grade and high-grade tumors are separated by their morphology as well as molecular genetics. So what are the pediatric high-grade gliomas or the mutations identified in these tumors? We will look at them with certain examples. This was a child who presented with headache, and you can see a large tumor mass which is sitting in the midline. It is involving the bilateral thalami. Again, it looks like a huge tumor. It has perilesional edema and other changes of aggressiveness on the imaging. And on morphology, again, it looks like a glioma. It's very cellular. It has fibrillary background. It's pleomorphic. It shows atypical mitosis. And instead of doing an IDH ATRX in these tumors, we will begin with studies on histone. So this is the first IHC which is done in these tumors. It's called H3K27Me3. It depicts the trimethylation in the histone protein. And in this case, the control for H3K27Me3 is the vessels or the endothelial cells lining the vessels. So you can see the nuclear expression in the endothelial cells, but the tumor cells are completely negative, which means the Me3 expression is lost in this tumor. If we can do K27M type of mutations, again with the help of a monoclonal antibody, which shows bright tumor nuclear expression in the tumor cells. These tumors can also show ATRX mutations and which is defined by ATRX loss. So these are what are referred to as diffuse midline gliomas, which show histone mutations, or they show histone H3K27 alterations in the form of H3K27M mutations, and uniformly these are labeled as CNS-WHO grade 4 tumors. So what do you mean by midline tumors? Any tumor which occurs in the thalamus, in the brainstem, cerebellum, or spinal cord, which are the midline locations, will be defined by these kind of mutations. So irrespective of the age, because when you define a pediatric type, you have to remember that they use an adjective of an adult type glioma and a pediatric type glioma. So that means the alterations in the tumor are adult type or pediatric type. That does not mean all pediatric type gliomas are seen in children and all adult type gliomas are seen in adults. So there can be pediatric type tumors in adults and adult type tumors in children also. So the pediatric type of mutations, the most important is histone alterations. Other than histone alteration, two other type of mutations are also described in midline gliomas, which are called as EZIP mutations and EGFR mutations. EGFR mutations are seen in children who are less than 1 year of age, and these tumors are bithalamic, and EZIP mutations form about 10% of the diffuse midline gliomas. So all these can be done with the help of immunohistochemistry. Now it has been thought that these tumors are very aggressive. Resection does not really help because the median survival time for these tumors is less than 10 months. And if they see a midline location, now the standard of choice is to do a biopsy, to do these immunohistochemistry to prove that these are diffuse midline gliomas. Because it is a biopsy, it need not always show features of atypia, MVP, or necrosis, but you still do the immunohistochemistry. So long as immunohistochemistry is positive, irrespective of morphology, you have to give a CNS-WHO grade 4 grading to these tumors. And this is a good example of where molecular biology trumps histopathology. Histopathology is not important. That tumor can look like a grade 2, grade 3, grade 4 tumor. Sometimes it looks like a pleomorphic xanthoastrocytoma also. What is most important is, do you do molecular studies? And this is called as pure molecular grading, where histopathology is not at all important. Now that was about midline tumors. The same hold true about pediatric hemispheric tumors also. These are also defined by histone mutations, but a different type of histone mutations. They can look like a glioblastoma. They can even look like a round cell tumors, which were earlier called as PNETs. They show giant cells. They will be IDH negative, and they will show a histone abnormality called as H3G34R or H3G34V. So again, monoclonal antibodies are available for these alterations also. We do the immunohistochemistry, look at the nuclear expression, and then only define the tumor by its WHO grade. Now, so far we have looked at adult diffuse gliomas and pediatric diffuse gliomas. Now we will look at circumscribed gliomas. I think all of you are familiar with these terminologies of pilocytic astrocytoma, pleomorphic xanthoastrocytoma, SEGAs, astroblastomas. So pilocytic actually are the commonest tumors. We identify them with a biphasic pattern. Everybody knows the importance of eosinophilic granular bodies and Rosenthal fibers, which are very important morphologic clues for the diagnosis of pilocytic. You can see a giant cell with a peculiar pennies on plate appearance, and sometimes a pilocytic can also show microvascular proliferation and necrosis. It is not a feature of aggressiveness on pilocytic. Even if you see these features, it will still be called as grade 1 tumor. And so these are the tumors which are defined by its histopathology. So though we are fast progressing to molecular biology, these are the group of tumors for which the essential criteria in the WHO are still morphologic criteria. So if you want to diagnose a pilocytic astrocytoma, you don't really have to do any hi-fi molecular studies. You look at the EGBs, the Rosenthal fibers, the location, the pediatric age group, and you can easily give a CNS WHO grade to these tumors. Same as pilocytic pleomorphic xanthoastrocytomas are also more common in children, superficial cortex. And because they are called as pleomorphic, there will be a lot of pleomorphism in the cells, bizarre cells. Xanthoma cells will also be present. These tumors are typically CD34 positive, express BRAF V600E. If you see a mitosis of more than 4 per 10 hyporphyll, then you upgrade the same tumor into WHO grade 3 category. SEGAs are lateral ventricular tumor which arise in the background of tuberous sclerosis. They show large giant cells, very circumscribed tumors. Chordoid gliomas again are seen in third ventricle because of the chordoid matrix which is seen. And unlike the pediatric and the diffuse adult type of gliomas, these are the tumors which are mediated by MAP kinase pathway. So you need to understand these terminologies, and the markers of MAP kinase pathway are in the form of BRAF abnormalities. So the BRAF abnormalities can be in the form of fusion or it can be V600E. And the prevalence of these abnormality changes according to the location of the tumor. And why we need to do these analysis, because now targeted treatments are coming up. The BRAF tumors are particularly being treated with anti-BRAF inhibitors, and these treatments are showing a very good improvement or a long-term survival in these patients, and that is why we need to do these molecular studies on the tissue. So for circumscribed astrocytic gliomas, morphology is very characteristic and molecular pathology will only be used in rare settings. Now coming to another type of aggressive tumors in the brain, and they are called as embryonal tumors. Now you all are very familiar with the terminology called as primitive neuroectodermal embryonal tumor or PNETs, and now that terminology is completely obsolete. There are no PNETs in the central nervous system, and this has been done to rule out the confusion from the systemic tumors. So now uniformly all these tumors are called as embryonal tumors, and that is the list of the tumors which is defined in the WHO classification. And the columns will tell you that now for embryonal tumors also molecular pathology is very important. All these tumors are uniformly CNS WHO grade 4 and they are very aggressive tumors. So we will take one example of such case, a pediatric patient. And you see a big tumor in the cerebellum. Any guesses what this will be? We are talking about embryonal tumor, an aggressive tumor in the cerebellar vermis, pediatric age group, small blue round cell tumor. Very good. So this is an example of a medulloblastoma, blue cells. You can see the Homer-right type of pseudo-rosettes. There is a neuropil in the center and peripheral arrangement of the tumor cells. If you go to other sections, you can see a bit of pleomorphism. You can see what is called as nuclear, what is described as cell cannibalism or the nuclear wrapping. That means the nucleus of one cell is wrapping around the nucleus of the other cell. This on histopathology is a marker of highest degree of anaplasia. So if medulloblastomas are neuronal tumors and they will be uniformly synaptophysin positive, not GFAP positive. We don't wait at that because now molecular stratification is important and we have immunohistochemical markers for this stratification. So we do a GAP1 and a YAP1 which are very beautifully cytoplasmic positive. The tumor is showing diffuse expression of P53, the INI1 is retained, and this will be defined as medulloblastoma SHH activated and P53 mutant CNS WHO grade 4. So we have to understand, of course, the histopathology of medulloblastomas, but we also have to know molecular typing. Histopathologically, medulloblastomas are classic type if they show diffuse small round cells with Homer-right type of rosettes. If there is nodularity, which can be picked up by reticulin stain, they are called as desmoplastic nodular. If the nodularity is very extensive and there are hardly any internodular zones, then it is medulloblastoma with extensive nodularity. And the example that I showed you, that if there is high degree of anaplasia with cell-to-cell wrapping, then it is called as large cell anaplastic medulloblastoma. These are the 4 molecular subgroups of medulloblastoma, that is WNT, SHH, group 3 and group 4. And it is very important to divide these medulloblastomas into these groups because that is what is required for risk stratification of medulloblastomas into low risk and high risk. So if the tumor is an SHH or an MBEN, then it is a low risk, versus if the tumor is group 3 or group 4 or a classic P53 mutant, then it is an high risk tumor. And this stratification is important for further management of these patients. The dose of chemotherapy and radiotherapy will change depending on what is the molecular subgroup of medulloblastoma, and that is why we need to do. How to do it? I have already shown you the immunohistochemical markers. So we use these 4 IHC markers, which is called as beta-catenin, which if there is a nuclear expression will define WNT medulloblastomas. SHH medulloblastomas will be positive for GAB1 and or YAP1. Whereas if all the immunohistochemical markers are negative, then it will be defined as a non-WNT, non-SHH, which can be a group 3 or a group 4. So this is our study wherein we have tried to define these medulloblastomas, and it has a very good correlation with molecular classification. If you want to further stratify or divide it into group 3 or group 4, you can use FISH or sequencing analysis for monosomy 6 and TP53. Now, this what I have told you is the immunohistochemical correlation for molecular typing. I have shown you examples where we use FISH and PCR for molecular typing, but you keep on hearing this one word in CNS classification, which is called as DNA methylation. So if you see majority of the desirable criteria for CNS, primary CNS tumor include DNA methylation studies. So far, they are still out of reach of routine diagnostic practice in India, at least. If you have to do one tumor, run DNA methylation on one tumor, then the cost of that ranges from 50 to 70,000 rupees. And that obviously is beyond the reach of our patients. And that is why WHO does not really insist on one molecular technique for molecular analysis. So what is important is you have to study the molecular genetic abnormalities, but it is not that you have to do DNA methylation studies. So the ways by which you can do the molecular analysis is you use monoclonal immunohistochemical surrogates. We can do FISH. It's very easy to standardize FISH. We have standardized it in our lab, and now we are doing for many CNS and other systemic tumors. We can do RT-PCR, we can do NGS, and of course, for certain tumors, we will need methylation studies. If you don't have these molecular studies, the WHO still encourages to use NOS terminology. So if you don't have even immunohistochemistry or other techniques, you give a histologic diagnosis, call it an NOS grade tumor, send it to a referral center for better diagnosis and a CNS WHO grade. So we have seen that there is an hybrid approach to CNS grading in the new classification. There are certain tumors which are defined by histologic criteria. There are certain tumors which are defined by histologic plus molecular criteria, and a group of tumors which are defined completely by molecular criteria. This is what you need to understand. Molecular criteria are being used for treatment of these patients because targeted treatments need to come through. Invasive means is not the only means of treating these patients. So these are the highlights of WHO CNS 5. I hope I have got across at least certain important points to you in terms of understanding common tumors of the brain. And if I have done that, then I think I have done my job for today. Thank you very much. If there are any questions, I would be willing to take them.
If there are any questions. Yes.
Yes, sir.
It was a very nice presentation, madam.
Thank
I
you.
got two questions. One is, when maybe around 10 years back, we used to hear that the specimen has to be sent part in formalin and part in normal saline.
Correct.
What is the scenario of, because everything has been molecular, has been shifted to ISC now, most of them, what I came to know. This is one question. What is the instructions to be given for a neurosurgeon, how to send the specimen? The second question is, what is the logic behind of grading change of from Roman to numericals?
Yeah, very good question, sir. I'm so happy you asked these questions. So now we are talking about molecular diagnosis, and I have told you the various techniques. One thing about, immunohistochemistry works very well when the sample is sent in buffered formalin. That is a very ideal fixative for running immunohistochemical studies. When you go more than immunohistochemistry, suppose you have to do PCR or you have to run NGS, or for that matter, even for methylation studies, you need DNA extraction from the tumor. Now, what has been shown is the quality of the DNA which is extracted from a fixed sample is not very good as you extract the DNA from a fresh tissue. So now they are saying, earlier there was a notion that whatever tumor the neurosurgeon removes, it should be put in buffered formalin as soon as it is removed out of the body. And then you do a tissue block, you look at the HNE, you do IHC, then you decide what molecular panel you need, and then extract the DNA from that block. But now that even we are doing these studies, we are finding that there are false negatives because the quality of the DNA is not good in a fixed sample. So now what the people have started thinking is, you divide at least 10% of the tissue, you snap freeze the tissue immediately. So you put it in minus 80 degrees. And in that minus 80, it can remain for a very long time. And the quality of the DNA which is extracted from that will be very good, will be optimally used for the molecular studies like PCR, NGS, and methylation. So that is the notion now. What remains in our mind is, how do you know that the 10% which you have divided is tumor or not? What if it contains only necrosis or hemorrhage or even normal brain? Then we are not serving that purpose. So what the labs are doing is, if it is a glioblastoma, you separate the 10%, you take a part of that tissue, you spread a smear, you confirm that that tissue is tumor, and then you keep that tissue aside. Whereas the rest of the tissue you use for IHC, you can use it for fish also. So that is the concept, how it is changing now. I hope I have answered your
Yes,
question.
very much.
So and again, I want to tell you that this for the neurosurgeon to do is difficult. So you send the sample to us in normal saline, transport it immediately. Actually, you can send it in a fresh state if the OT and the lab is close by, and then leave it for us to divide the sample. Don't divide the sample yourself. If you don't have molecular analysis, put the whole tissue into neutral buffered formalin. That's good enough. That still saves the DNA in the tissue. We can still do the molecular analysis. About your second question of changing the Roman and the Arabic numericals. Now, those are lines. 2 is 2 lines, 3 is 3 lines. So, everybody like neuropathologists who regularly report, there can be typographic errors. So sometimes, I go back to certain of my tumors because somebody has asked for a review. The tumor looks like grade 2. I have signed out the tumor as grade 2, but my typist has released it as grade 3. And that's very, very difficult for us to understand. So to remove those typographic errors, now it is better to use Arabic numericals.
Typographical error is worldwide.
Is worldwide, huh? Of course it is worldwide, yeah. But for us, there are medical legal issues and we are always under a stress. And grade is the defining criteria for CNS tumors. So that is why.
Thank you. We can
Madam,
conclude. Yeah.
I have few queries.
Yes, yes, sir.
First thing is this regarding pineal gland. You have extensively covered other topics.
Ah,
Pituitary,
yeah.
I think
Yeah.
not much changes. As I went through the report, there are not much changes.
Pituitary actually, sir, is not treated as a part of CNS classification. Pituitary is a part of endocrine WHO classification. So pituitary also has completely changed. There is no similarity to the old classification because now we are using transcription factors in classification. Subtyping had changed, but it is not a part of WHO CNS classification. It is a part of WHO endocrine organ. For that matter, pituitary is not considered as a CNS structure. It's a cellular structure.
Yes, but
So
for us-
that's why there is a different classification scheme.
And regarding pineal gland tumors, madam.
Pineal. So primary pineal tumors, actually I wanted to cover that in my slide seminar. There is one case. So pineal gland tumors are divided into primary pineal and the other tumors. In the primary pineal category, there are pineocytomas. There is pineal parenchymal tumor of intermediate differentiation, which is grade 2 and 3. There are papillary tumors of pineal region and pineoblastomas. I am so happy you are asking about pineal tumors. I understand that neurosurgeons do not really go in that area. Posterior third ventricle, a very difficult approach. And if you are there, then that's one criteria to
No, no,
call that you are an excellent neurosurgeon. So
No,
if you're talking about
I am on
pineal
that process,
tumors,
but
yeah.
I was trained under Dr. Manas Panigiri sir. as the
Ah,
nurse.
yes,
So
yes.
he definitely, it is for him, it's a cake. Also.
Yes, yes.
Even pineal
So
gland
there are molecular abnormalities in
Yes.
pineal tumors also, but that's the grade.
No, why I raised this question is though it's a midline tumor.
Yeah, it's
Some
not.
Yeah, pinealoblastoma, they are
Correct,
benign.
correct.
And certain vermine tumors are also they can be low grade also, madam. And like it's not
Correct.
that though it's midline.
Yes,
it
yes.
need not be
So
low grade,
the circumscribed tumor that I showed you,
Yes,
pilocytic astrocytomas,
Yes, ma'am.
gangliogliomas,
they are
they can be
and which have very good
brainstem or
prognosis.
vermian and
Yes.
they can have very good
And
prognosis.
when I was going through the report, what I saw is that they have done very good changes, madam. And
Yeah.
still there is a scope for improvement.
Yes.
Because once it's grade 4, it's very clear that the patient has to undergo radiotherapy and chemotherapy.
Right.
Once
right.
it's grade 1 tumor, we are very clear that we have done a safe maximal resection
Correct.
and we have to just keep a follow-up. The problem comes in grade 2 and grade 3 tumors.
Right.
What we have to do, whether this patient has to be subjected for further radiotherapy, he does need chemotherapy, or it's just we have to stop it
Right.
at that.
Yes, sir.
So
So that is a very good point that you brought about is we are talking about these molecular genetics. They are used as prognostic and predictive parameters. But if you read one sentence in WHO or any other book for any of the primary brain tumors, then they say gross total resection of the tumor is the most important prognostic parameters. After you do a GTR, the molecular genetics plays.
yeah, but
So, and so long as there is no GTR, whatever is the molecular profile of the tumor, there is always a chance of recurrence.
But with the problem with the gross total resection in our setup is it is extremely unacceptable for our patients, madam. They feel that we got operated here and we have developed a morbidity. And
That is always
that's
a
very much
problem.
unacceptable.
Yes,
But
yes.
still we go for maximal safe resection, madam.
Yes, sir.
And
So if that GTR is not achievable or it's not possible because of any reason, then the molecular criteria are very important for treatment as well as prognosis of
yes,
these
ma'am.
patients.
What we do is whenever we are close to some vital structures, we tend to leave a part of it.
Correct, correct.
which,
Yes,
uh,
yes,
which is
obviously,
yes.
yes. To avoid
So
morbidity.
such
and
if they
mortality.
turn out to be grade 3, then we have to subject it for
Exactly,
radiotherapy.
exactly. Sir.
And molecular, clinical, molecular, and histopathological reports would help us to give first thing is prognosis to the patient.
Yes, yes.
I mean, after how many years he's
Predictive
going to have
also.
recurrence.
Yes.
And because we see that after once it's grade 2 in the beginning, when it recurs, it becomes grade 3 or even higher grade.
Yes, sir. Yes.
And some of these tumors we subject for bevacizumab
Yes.
in certain cases. But
Yes,
these molecules are very costly when we
Yeah,
give it as a
yeah, the
chemotherapy. Right now we are dependent only on temozolomide as a postoperative chemotherapy.
Correct, sir. Correct.
So I think molecular
Genetics.
genetics which have been included in this
Yeah.
2021
Actually,
classification.
about the diffuse midline gliomas, there is a hospital in Toronto, Sick Kids, and they are really working on midline gliomas. And recently, they have published some articles on these tyrosine kinase inhibitors being very good treatment for midline gliomas, and certain children have been cured. So we keep on, we have to keep on doing the molecular genetics. Without that, the patients cannot be enrolled in clinical trials. And then we can't have answers or the non-invasive managements for these patients.
I think we are just begun. We have a long way to go.
Yeah, of course.
Yes.
But one thing about the clinical and the pathologic is pathologic updates are always ahead of the clinical updates. And unless we keep ourselves ahead, the management cannot change or it cannot go on. So that's our, duty to incorporate these changes in our reporting.
Okay, thank you.
Thank you.
We thank Dr. Megha ma'am for a detailed and insightful presentation. It has provided us with a deeper understanding on the topic and enriched our knowledge base. Thank you, ma'am.
We thank Dr. Rajashri ma'am and Dr. Mallappa sir for chairing the session. I would request the chairpersons to present Dr. Megha ma'am with a certificate and a token of appreciation. Thank you, ma'am. Thank you, sir.
Now I request Dr. Prakash Patil sir to present certificate and token of gratitude to the chairpersons. Thank you, ma'am. Thank you, sir. Now we will be commencing the inauguration ceremony shortly. Good morning, esteemed guests, distinguished faculty members, and our postgraduates.
We are delighted to have you join us today for the inauguration of our CME event on neuropathology and salivary gland tumors, organized by the Department of Pathology at BLD deemed to be University, Shri Patil Medical College, Hospital and Research Center, Vijayapura.
On behalf of the Department of Pathology, we extend our heartfelt gratitude for all of you for being here. We are privileged to have many eminent speakers and distinguished guests amidst us to grace this event.
Now, I request our organizing chairperson, Dr. Surega Hipargi ma'am, and organizing secretary, Dr. Sneha Jawalkar ma'am, to escort our chief guest, Dr. Tejaswini Vallabha ma'am, and our KMC observer, Dr. Mahesh Karigowda sir, to occupy the seats on the dais. Thank you, ma'am. Thank you, sir.
I kindly request Dr. Upasana Sandilya and team to serenade the occasion with an invocation song, bringing a melodious start to the event. Asatoma Sadgamaya, Tamasoma Jyotirgamaya, which means lead us from ignorance to knowledge, lead us from darkness to light. With that, I would request the respected dignitaries to inaugurate today's program by lighting the ceremonial lamp.
आरोग्यं धनसम्पदं सुखं कुरुध्वं कल्याणम् आरोग्यं धनसम्पदं शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनम् दीपज्योतिर्परब्रह्म दीपज्योतिर्जनम् दीपो भरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं योगिशां प्रभुराज्ञः ओ दीपब्रह्मरूपस्त्वं योगिशां प्रभुराज्ञः आरोग्यं देहि पुत्रांश पतिं स्वच्छामि मे सदा रवेरस्तं समायत्य यावत् सूर्योदयः रवेरस्तं समायत्य यावत् सूर्योदयः यस्य दृष्टिं गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुध्वं कर्म.
Now, I would like to request our organizing chairperson, Dr. Surekha Ippargi ma'am, Professor and HOD, Department of Pathology, Shri Patil Medical College, Hospital and Research Center, Vijayapura, to extend a warm welcome to all present and introduce today's program.
ಎಲ್ಲರಿಗೂ ಈ ಶುಭ ಮುಂಜಾನೆಯ ವಂದನೆಗಳು. Good morning to all of you. On behalf of our Department of Pathology and Organizing Committee, it is my privilege to extend a warm welcome to each one of you for today's CME program. We are delighted to see such an esteemed group of medical professionals gathered here, all dedicated to advancing their knowledge and skills. We are honored by the presence of our chief guest, Dr. Tejaswini Vallabha, Dean Faculty of Medicine, whose insights and leadership in the medical field inspire us all. Your support and encouragement mean a great deal to us. Welcome, madam. To our KMC observer, Dr. Mahesh Karigodar, a close friend to all of us and pathologist. Sir, I welcome to the CME and look forward to enriching our discussion with your expertise. I warmly welcome today's speakers, Dr. Shantvir Uppin, Dr. Mega Uppin, Dr. Nandish BN, and Dr. Yogesh Ostwal. And these persons are experts in their respective domains. We are privileged to have them share their knowledge and experience with us. Your dedication to advancing medical knowledge is commendable, and we eagerly anticipate your presentation today. And of course, to our delegates, faculty and postgraduates from different medical colleges, SM Medical College Bagalkot, JIMS Kalburgi, MRMC Kalburgi, JNMC Belgavi, Ashwini Medical College Sholapur Pune, and ESIC Kalburgi, Malareddy Hyderabad, and one of the BSc student also we have got from the Indian Institute of Science and Education and Research, Tirupati, who have taken the time to participate in this program. Your active engagement throughout today's session will significantly contribute to our program success. Our cordial welcome to you all. I'm glad to welcome our fellow faculties and Medical Director Super Specialty Dr. Vijayapura Kalayanapkur, our Senior Professor Kushal Das sir. Sir, welcome you all. As you know, today's theme of the CME is neuropathology and salivary gland tumors. Today we explore the pivotal role of neuropathology in clinical diagnostic and patient care. As already Madam has spoken about the neuropathology tumors, it is neuropathology is essential deciphering the intricate mechanisms underlying the neurological disorders. It including tumors, guiding the treatment decisions and advancing the therapeutic approaches. And salivary gland tumors, already sir has spoken about it, represent a diverse group of neoplasms with varied clinical presentation and management challenges. Understanding their histopathology, molecular characteristic, and diagnostic is crucial for accurate diagnosis and treatment planning. Moreover, beyond the academic aspect, as you all know, collaboration is at the heart of medical progress. And if we aim to catalyze future collaboration and partnership today, I hope that participants will gain a deeper understanding of these topics by the end of the session. Best wishes for a productive and fulfilling day ahead. Once again, a warm welcome to each one of you. Thank you very much.
Thank you, ma'am.
I would like to request Dr. Sureka Rakiri ma'am to present our chief guest, Dr. Tejuswini Vallabha ma'am, with a bouquet. Thank you, ma'am.
I would like to request Dr. Satish Arakiri sir to present our KMC observer Dr. Mahesh Karigoda sir with a bouquet. Thank you, sir.
I would like to request Dr. Savitri Nerune ma'am to present our organizing chairperson, Dr. Surega Hipargi ma'am, with a bouquet. Thank you, ma'am.
Now I would like to request Dr. Sai Kulkarni ma'am to present our organizing secretary, Dr. Sneha Javalkar ma'am, with a bouquet. Thank you, ma'am. I now request Dr. Vijayalakshmi Patil ma'am to introduce our chief guest, Dr. Tejaswini Vallabha ma'am.
Good morning, everyone, and welcome to our event. It gives me immense pleasure to introduce our chief guest, Dr. Tejaswini Vallabh, Dean, Faculty of Medicine, who has warmly accepted our invitation to join us today. Dr. Tejaswini Vallabh is a highly accomplished individual in the field of surgery and medical education. She has completed her early education in Kalburgi, MBBS from MRMC, Gulbarga in 1986, and MS General Surgery from WIMS Ballari in 1990. She joined BLDE Shri Patil Medical College in the year 1990 as lecturer and has served almost for 34 years now. She has worked in various sections of the university. She was the first controller of examination of BLD University from 2008 to 2010. She has served as HOD of surgery, HOD of medical education, vice principal, and as chairperson of Skills Lab, Curriculum Committee, Women Empowerment Committee, Member Planning and Monitoring Board, Academic Council, and Dean of Allied Health Sciences. She has been trained in GI endoscopies and laparoscopic surgeries and has performed more than 7,000 upper GI endoscopies and colonoscopies. Apart from this, she has also completed her fellowship in medical education, that is ACME. She is an active member of ASI, Served Association of Surgeons of India, in various capacities. She has organized more than 50 workshops and CME programs related to advances in surgery and medical education at various levels, that is state level, national level, as well as the regional levels. She is one among the panel of experts in surgery for UPSC Government of India and KPSC, that is Government of Karnataka. She is also a member board editorial board of Indian Journal of Surgery for 2022 to 27. She has served as peer reviewer for various Scopus Index journals. She has been awarded Dr. S.S. Narsangi Traveling Fellowship in 1998, Fellow of Association of Surgeons of India in 2015, prestigious Professor SSC Narsangi Oration by KSC ASI in 2016, and has delivered Professor MP Pai Oration in 2024. Apart from this, she has various publications and presentations. We are very grateful to Dr. Tejaswini Vallabh ma'am for accepting our invitation and making a presence here. Here I present Dr. Tejaswini Vallabh. Thank you.
Thank you, ma'am.
I would now request our chief guest, Dr. Tejaswini Vallabh ma'am, to please address the gathering.
Good morning, everyone. It's a homecoming for me, and the elaborate introduction was really not needed. I'm part and parcel of the department and institute because surgery is nothing without pathology. You people are the backbone and brain also at times, directing us, supporting us, and at times if you are diverting, you people pull us back. It's always a pleasure listening to the academic activities of the department. And I was really happy to see that Dr. Upin and Mrs. Upin, who were regular contributors to the department, have come back again. Nice to listen to you. I remember listening to you people during when Dr. Elkar used to conduct, and it's always a significant contribution from both of you to the department has greatly helped them, that I know. And at the same time, it's a privilege to listen to the neuropathologist, Dr. Yogesh and Dr. Nandish, who are definitely going to bring significant insights because our department especially more of has now good young energetic neurosurgeons who are venturing into a lot of good things, good surgeries, and they definitely need support from you people, interaction and directions, which always helps. I really do not want to be in between the speakers and the listeners. So I really sincerely thank all of you and especially Dr. Surekha and team to be asking me to be here. That's a privilege. It's not that something I did. I love to come back to the department for any reason. At the same time, I'm happy to see that Professor Das and Dr. Vijayapura are here like me to enjoy the whole thing, which definitely adds color to the whole session. Again, I thank all of you for calling me here and have a good time, good learning and a wonderful session. I have a request to Dr. Surekha. If you can make arrangement for recording with their permissions of their speeches and put it on the YouTube. A lazy person like me can listen sometimes later on at our convenience. And I wish that you people get maximum out of these people. That is the whole crux of the conducting CME. Specifically, when I spoke to university officials yesterday, Honorable Pro-Chancellor specifically told that, ma'am, please convey our congratulations and all the best on behalf of Dr. M.B. Patil, our President, Pro-Chancellor Dr. Jairaj, our Honorable Vice-Chancellor Dr. R.S. Mudhol, our Honorable Pro-Vice-Chancellor Dr. Inamdar, our Principal and Registrar. Everybody wishes a real success to all of you. I represent them here to be with you and I congratulate again all of you. I hope you have a good day. Thank you.
Thank you, ma'am.
Thank you, ma'am. I would like to request Dr. Surekha Hippargi, ma'am, to present Dr. Tejaswini Vallabha, ma'am, with a token of gratitude. Thank you, ma'am.
Now, I would like to request Dr. Sneha Jawalkar, ma'am, to graciously step forward and deliver the vote of thanks.
Good morning, everyone. As quoted by David Rest, it is not joy that makes us grateful, but it is the gratitude that makes us joyful. So I'm delighted to have been given the pleasant duty of delivering vote of thanks. I'm grateful to our patrons and advisors, Honorable Pro-Chancellor Dr. Y.M. Jairaj, Honorable Vice-Chancellor Dr. R.S. Mudhor, Honorable Pro-Vice-Chancellor Dr. Arun C. Inamdar, and respected Registrar Dr. R.V. Kulkarni for their generous support and guidance which made this event happen. I express my heartfelt gratitude to our beloved Principal Dr. Arvind Patil for his constant encouragement and guidance. I'm extending my sincere gratitude to our esteemed Chief Guest, Dean Faculty of Medicine, Dr. Tejaswini Vallabha, for gracing this event and being an inspiration to all of us. Thank you, ma'am. I would like to take this opportunity to convey my thankfulness to Vice Principal Clinical Dr. M.B. Patil, Vice Principal Paraclinical Dr. Sumangala Patil, Medical Superintendent Dr. R.M. Hondodki sir, Medical Director Dr. Vijayapura sir for their generous support. Thank you, sir. I would be failing in my duty if I don't acknowledge the distinguished speakers of this event. I'm immensely grateful to all the speakers, Dr. Shantavir Uppin, Dr. Megha Uppin, Dr. Nandesh, Dr. Yogesh Ostwal, who have traveled all the way from far off places to make it to here and to enlighten us with their knowledge. Thank you, sirs. Thank you, ma'am. I'm also glad and grateful to have all our enthusiastic delegates and chairpersons from various colleges in North Karnataka and Solapur. Thank you all for coming here and for your active participation. I'm sure you all will have a fruitful day. I also thank all the heads of the departments present over here, head of the Department of Surgery, Geriatrics, Emeritus Professor of Physiology, Dr. Kushal Kedas, for coming here and gracing this occasion. Thank you, everyone. No event can take a shape without hardworking leader, a dedicated and an enthusiastic team. So I take this opportunity to extend my deepest gratitude to our beloved head of the department, Dr. Surekha Hippargi ma'am, and all the faculty members of our department, postgraduates of the department, who have been working hard since last couple of days to make this event a successful one. A big thanks to all of you. Thank you.
Thank you, ma'am.
I'm also grateful to our very efficient IT team, photography team, a very talented social media person, Mr. Anup, who designed this beautiful brochure. I thank you, all of you. I also thank the non-teaching and technical staff for their support. Once again, thank you one and all.
Thank you, ma'am. That marks the end of the inauguration ceremony. We will now take a short break for tea and reconvene after 10 minutes.
different kind of response. And you know, brain is so so active metabolically, it needs oxygen supply continuously. So if you take up the overall percentage of body weight constituted by brain, is only 2% of the body weight. But any moment, the requirement of blood supply would be 20% of the body blood supply. So that only reflects the degree of metabolic activity it is having and the degree of dependency it is having. So that is the first organ to die if you cut off the oxygen with just sustenance of 5 to 6 minutes only. So with that introduction, I am starting with this name, pseudo tumor. So in our life, of course, as we progress, we come to know a lot of pseudo things in our life. So many things are virtual, unreal, but still we believe and get attracted. In the same way, these are the things which will really challenge us or practice. As the name indicates, these are unreal tumors, unreal lesions which mimic tumor. So should we call it as really tumors? They're actually lesions or disorders, but definitely they are given as tumors because you need to be careful not to diagnose tumor. Many times it so happens that if you do a mistake within the tumor, it's kind of acceptable. Like for example, you wrongly call an adenocarcinoma with a squamous cell carcinoma or another thing, still it is okay. But calling a tumor to a, non-tumor to a tumor would be very devastating. That is the reason why you need to be very much aware of it. So any non-neoplastic enlargement, which can be due to various reasons, which can form a mass-like effect or mass-like lesion with effect on the surrounding tissue can be called as a pseudoneoplasms. And remember, pseudoneoplasm definition starts right from the way clinically it is evaluated. Anything which comes with a mass lesion, with a bulb, with a bump or whatever you call lump or bump, whatever, irrespectively, if the first thing which will be considered would be obviously tumor. So clinicians will definitely mistake that the definition of pseudoneoplasm or the list of pseudoneoplasms becomes very high, a big innumerable list for a clinician. Then to some extent comes down at a radiological level. Anything which forms a lesion which is occupying space, especially in the brain, anything which occupies space will have a mass effect because it is within this closed, let's take this is a calvaria skull. You cannot accommodate any extra thing. Okay, so many seats are there, any extra seats you can accommodate here and there and somehow manage. Little more, people have to stand and all those cause effects on that, discomfort. In the same way, anything which occupies space will act as a mass lesion. Radiologically, anything can mimic. Just to give one example here itself. You must have heard about ring enhancing lesion. Ring enhancing lesion happens in the when you give contrast on radiology. Central area will be non-vascular, generally due to a necrotic tissue or something which is unhealthy or collection. Peripherally, you will have a vascular response, vascular reaction that gives a ring-like enhancement. So the concept is inside unhealthy or non-vascular area, dead tissue, contents or collection, whatever you call, peripherally a vascular rim. So the differential diagnosis on radiology will start like this: pyogenic abscess and abscess in general, tubercular abscess, parasitic abscess, fungal abscess. All abscess comes because central area necrotic, peripheral rim. Then comes vascular lesions like hemorrhagic stroke or hematoma, and again organization at the periphery. Then you have immunological causes, demyelination. That can also cause, we call it as tumor factory demyelination, that is tumor-like demyelination. Then you have infarct, organizing infarct also gives rise to that ring-like enhancement. Then if you go to neoplasm, right from primary to metastasis, like right from glioblastoma to metastasis, it can give like a lymphoma also, they can give ring enhancement. So all this can cause difficulties. Now coming down to pathologists, many of the things can be, see, for example, just a hematoma here, it's easy for a pathologist. It will not cause problem. But a proliferative lesion, let's take a granulation issue, let's take a fracture. A fracture can mimic fracture response, can mimic an osteosarcoma. All of you agree with me, right? Because I'm dealing with this thing. So many reactions happens, which if you take up can actually cause a lot of disturbance. Though the list comes from once you come to a pathological level, but still they can trouble innumerously. And so whatever I'm talking to you in terms of CNS, you can apply to any other organ, but few things are there which is unique to CNS, because they told you the location, anatomical organization, and the location and the nature of it. And another thing what happens here is there are a lot of perilesional changes which happens that will also complicate and create issues. The reason why I'm talking is this is the era where, you know that the size of the tissue is coming down because the way of taking the sample has become extremely sophisticated by using special instrument to cause least discomfort in invasion to the patient. scopes are used. So obviously sophisticated scopes, they target and take very small tissue, but the number of testing you saw, the number of immunohistochemistry, the number of genetic test, molecular testing requirement by WHO has become more. So the size of the tissue is coming down, but the expectation of information to be derived from the tissue is becoming more and more. So it becomes very important that even the target is properly reached. So many times, because the percolation changes, you don't know exactly whether the scope has reached the entire, like you take core biopsies, stereotactic biopsies, whether it has reached the epicenter of the lesion. Sometimes they're so successful and reach the epicenter, but you get only necrotic tissue. So it's a challenge. You cannot blame anybody. That is the day-to-day challenges of the profession. So to be more careful, they want to go to the peripheral solid area, but if it just tangentially touches the perilesional area, you will have challenges. You will see reactive zone, but the actually pathology representation is in the adjacent area. You may have to recognize just by the reaction also what may be the exact thing. So these are the reasons why you should know, but basic theme is that a lot of risk of diagnostic error. Okay, and you know, as Madam mentioned, the chief guest, Madam, that you are like a director of the or a script maker of the movie. So if you don't direct it, now obviously there's going to be danger. So this is just an attempt to create an awareness among it. It's more like a revision. I don't say that I'm speaking out of a lot of experience of this, just a mutual learning, and whatever I've understood, I'm just sharing this with you. I told you in CNS it is more unique because of its uniqueness in its functional and structure. So any lesion which occupies space in the brain will create a mass-like effect. And another thing I told you, here the brain is so active, whichever has stroma, a lot of stromal contents, lot of supporting cells, they are the one which tends to respond first. It's like this, before you meet the most important person, it is the bodyguards, they respond. It's exactly like that. The extensive tissue response you get in all those metabolically active organs like liver and all soft tissues and bone, all those things, extremely vascular, and brain also like that. Told you already about the importance of radiology, and some more histopathologically obvious. I will not showing those things. Like for example, what I told you as a different diagnosis for ring enhancing lesions, different diagnosis for ring enhancing. You obviously pathologically, if you see abscess is easy, and fungal abscess, all those things are very easy for you. And so I'm not dealing with that. Some of the straightforward case tumors also I'm not dealing with that. So those which are in the gray zones only, those I'll be touching upon. But nevertheless, as I mentioned to you, though they are obvious in its pathology, but the tissue received may not be representative, then also you may have to apply those things. All of you agree with that? Agree with this, the last line, that each lab is its own unique set of artifacts. The artifact starts right from the time a surgeon starts operating on the operating table, and then the way it is taken out, placed in the container, transported, and the moment we receive it, the way we gross it, every step artifacts are prone. And artifacts are such that nobody can write a textbook on that, because what textbook you write will be unique to your lab. Okay, the another lab, it is so unique. So nobody deals with artifacts, but actually artifacts makes a major bulk of our education, I would say. And nobody formally teaches about artifacts. You have to learn on your own. So this is, if it is another, that creates more problem. All of you will agree, all those small blue round cell tumors, you'll see that streaming effect, nuclear clumps, all those things. And you wonder whether it's a reactive lymphoid proliferation or a malignant lymphoid proliferation. So that is a simple example for this. And that will complicate whether you are really dealing with a neoplasm or a pseudoneoplasm. So because of all these reasons, we will go to this. Now, these are the terms you should remember. All these are all way you have explained. Of course, pathologists like food, so they have compared many findings with food. At the same time, pathologists are very good nomenclature taxonomists, I would say. They give such a variety of names to complicate already complicated pathology. Okay, so all these things. All these things are different way of expressing that there are true neoplasms, but their content are explained here and indicating that they are not true neoplasms. And in what is the pathogenesis? Pathogenesis, if you go on explaining each lesion as its own, but in simple terms, if you want to mention that in one statement, that in exaggerated response of the native tissue elements there. Okay, that's all. It's just a reaction. But what triggers the reaction is variety of influences, multiple factors, the disease itself, the host response, everything put together comes in. So basically, it's an inappropriate or a dysfunctional response to some kind of trigger, known or unknown. And you can give various kind of examples for these reactions, which gets deviated. Simple, it starts right from hyperplasias. Many of the hyperplasias can mimic tumors, like simple endocrine hyperplasia, epithelial hyperplasia. All those things can mimic. Papillomas becomes papillomas, then becomes dysplastic, all those things. All these are examples of way we are described. Okay. So now we'll go to the actual classification. Now, see, if I go on, say plenary session, go on discussing the information. So of course, all of you had a fresh tea, but definitely the session is pre-lunch. If I go on discussing the theoretical aspect of like a plenary session, definitely more than 90% will go for sleep. Okay. So what I've done is that at every level after the initial classification introduction, I'll go with the case examples. I will be dealing with each of these things. Of course, pathology, you need to have these colorful photographs, otherwise it is difficult. So, and that's the reason why radiologists also have started becoming colorful by adding that contrast and kind of putting that, otherwise it would have been gray white. So now I will give you the overall picture of it. This table is very important. After that, it's just case examples. So exactly after 45 minutes, because plenary session 45 minutes was given, I will stop at that level because there are many cases, maybe it may touch around 15 or so. So around 7-8 cases I will stop. After that, we'll continue in the slide session also. Around 8 cases I had sent as image based thing. So some are included in that and other things I will be covering it. Now, how to classify it? There is no formal way of classifying these lesions. It's like asking how do you classify artifacts? Very difficult, no? So what can is say, the same organ, if one particular pseudoneoplasm or a response is there, that may be different in a different situation. Like you have observed post-surgical spindle cell nodule, simple example of a soft tissue response, or a nodular fasciitis you take. 10 nodular fasciitis or proliferative myositis, or each of them is different because it's not a tumor or it's not a condition where you can limit by certain rules. The way its response, the way it proliferates is different. So they will have mimicking is also different. So that's the reason why you don't have a formal classification. What I have simplified it, I should not say it will be like boasting. What I have understood, I have put it across. Okay, so you won't, so yeah, I say this to my residents when whatever few residents are there in our institute, is that it's these CMEs are very unique. The thing is that you get all the raw materials in the textbook in the form of textbook literature. But the raw materials, it's like eating, it's very difficult to eat. It's like this vegetables, carrot, all those things. So CMEs are like that, where it's a dish is prepared and given to you. So you can do in that way. So that's the importance of that. You may ask, there are so many YouTube, so many kind of educational channels are there, but still CME has its own glamour and requirement. So this is the importance of it. Everything you get in a nutshell. For example, this particular topic you see, we have attempted to organize it in this way so that things will be very easy for you. Okay. So I also referred initially when I want this is my area of interest, because whatever troubles we have to answer those things. These are the most troublesome, and these are the ones which can bring down our what do you call I should not say popularity, our kind of eye thinking also. For example, these are things which will make you err, and once you err after a certain level, it's very costly. Okay, mistakes after certain level of cadre will be extremely heavy and expensive. That's the reason why. So this is my one area of interest. So this has been organized in this way. Same principles you apply for any organ. Okay, what are the causes? Pseudoneoplasms you can classify based on the etiology. One is developmental. I'll give you examples as case examples. I'll give you to that. Another is immunological. Developmental, if something is not properly developed, may look like a mass. Okay, basically these are all malformations. Second thing is immunological. Of course, anybody will explain this is a very common cause. Immunological exaggerated or deviated immunological response, okay, or inflammatory response. Next is idiopathic. Of course, this is a very popular and very safe word. Is it not anything which we cannot address it? We will say idiopathic. That doesn't mean that without any cause, without any smoke or anything, there cannot be fire. Just because we didn't detect that, that doesn't mean that there was no cause. Just that it is telling that we don't know. That's all. Okay. In a sophisticated terminology, we are telling idiopathic. Another thing is, of course, infections. Variety of infections can mimic tumors. Iatrogenic. We are very popular in causing so many changes intervention. Simple iatrogenic procedures can give rise to a lot of things. Best example is post-operative spindle cell nodule in a soft tissue, not here. Another thing is post-traumatic or vascular or idiopathic. You can put everything under one category. Otherwise, if you go on giving a single examples, it will become a big list. So you club all other non-major categories into this miscellaneous. So what is the basic theme? Basically, it's a reactive change which is mimicking a neoplasm, or something will fill the area. You know that you call a tumor based on the participating cells. Tumor, the native cells or a foreign cells will participate there. They are filling it up, so you call a neoplasm. But here it is the infiltrates generally which may be native or which may be brought out. And they cause some kind of architectural or cytological change which mimics a neoplasm. That's the basic theme of it. And in general, stroma is the one which participate. It's a major one that creates the problem here. And in simple words, you can tell it as an unexpected or a deviated regenerative or reparative response. And that is giving rise to a clinical or radiological deviation, okay, or mimicker of a neoplasm. Now let's start with this example. This, if you take up the one which within the bracket, no, it's called as case slide seminar. Okay, that is the for whatever slides are provided online for you for madam. That is the symbol given. Otherwise, this is the examples which are used for the lecture. These are the ones which was provided on a soft copy of it. So this one is a classical history. So classical history are given for the sake of understanding. Unfortunately, classical histories will not get over that. Even though history is there, it will not be provided to us for various reasons. Okay, and so this is one. Jelastic seizures means something which is like a kind of seizure, but patient becomes very inappropriate, peculiar behavior with a lot of laughter. That is what. And there is early onset of puberty and weird problem. Anybody with this history will think that involvement of hypothalamus. Okay, hypothalamus involvement, but it's a benign category, so it is not causing major issues. And there was a lesion in relation to hypothalamus. Hypothalamus means there will be a suspicion. Mass means they suspect hypothalamic glioma, which is generally pilocytic. Fortunately, the region of hypothalamus has got low-grade gliomas only, low-grade tumors, not a problem. Or sometimes the adjacent lesion can impinge on that and give rise to problems. Craniopharyngioma like that. This is the slide given online also. You can just have a look at it later. So you can see that normally the stroma, if you take up, the slides, if you take up in the brain, unless it is gray matter of cerebellum or cerebrum, elsewhere it's all very, very hypocellular. It looks just pink because white matter runs, myelin is there, very few cells. So, but here you can see that there is some activity, cell density has increased, but the cell size is small and few are there little larger. So intermediate sized and small size cells are filling it up. Some you may call it as low grade glioma, is it not? I'm not going to full details of it because I'm sure you will be tired with so many information given from morning, but extremely very good lectures. I enjoyed. But this one you can just relax and watch like a movie. Okay, don't put too much of mind in that. Just observe for concept based. Later on you can introspect and study this. Okay, so again a little more images, various images of it, medium, small. Carefully, if you see those which are a little large, I've got a nucleoli here. I don't know whether you can see this. This very good thing that this is a TV screen. If it was this LED projector, then it would have got pixelated and it would have. But you can make it small nuclear. Nuclear in the brain, you will appreciate that they belong to neurons. Okay, neuronal category. Except few cells, most of the cells are looking very small. Is it not? You agree? But yeah. So you get a feeling that whether these are oligodendrocyte cells and these are some neuron-like cells. Here you see the activity. So you feel that it's a low-grade glioma. Without, of course, in all these complicated ones, you need IHCs. Straightforward ones, you don't need IHCs. But this is an era where you need evidences, evidence-based medicine. So people expect that you provide evidences. And thanks to the greatest teacher of the era, that is Google. So patients read that Google, they come out that so many IHCs are required. They also ask, how have you confirmed? Do you have evidence, all those things? So you have to do for their sake. Even the clinicians are very well informed. They also ask, see, many times this atypical meningioma, we grade based on the most important is mitosis, 4 to 19 mitosis, about 20 grade 3. So sometimes it will be crossing 10. So confidently we give it as atypical meningioma, but still they call up and ask, you have not done case 67 on this. How sure are you? Mitosis is fulfilling that. No, still please do like that. So it becomes, I don't know the reason why, whether they really trust the eyes of a pathologist or they want one more. Okay, but still they have been asking. So this is what happens. Okay, so I'm sure you will agree. Now this is to cut short. This is a nuclear stain. So very few nuclear stain in pathology, not to complicate. Of course, in breast or any other ovary, you would have considered ERPR, but we don't bring ERPR in the brain. So here it would be either K67 or P53 something, but I will cut short, not take extra time. This is a new neuronal stain. You can see that everything has stained except few cells. So they need, other than native cells, most of the cells are taken. More than the neurons, small intermediate cells, there were a lot of blue cells, is it not? I told you. So this is a neuronal aggregation there. Neuronal aggregation can be neoplastic or developmental or malformative. The only few tumors which are neuronal in nature is either grade 4 or the grade. The grade 4 tumors which are neuronal are medulloblastoma, all primitive neurocrital tumors. They are neuroblastic in nature. So that is not, you don't consider this as malignant round cell tumor. The other one is very low grade tumors, though they are low grade, but they are not as low cellular as this. The other matured neuronal tumor is a neurocytoma, which occurs within the ventricle. That is not, there are gangliocytoma. They are all looking different. I'm not going to the details of that. So once you have NeuN, means this is a neuronal thing. The lesion which occurs in a young age in hypothalamus would be an hypothalamic hamartoma. Okay, so I told you the example here that this is the triad, they say, that I had mentioned there, diastolic seizures with developmental delay and precocious puberty. And this can get confused with many other lesions, especially if the pathologist is not informed or well informed or the history is not typical or atypical, you get that. So basically, this is an example of developmental. I told you that table in the examples classification of pseudoneoplasms. It is that. So another example, this is a patient who is having long-term seizures, okay, and it is expanding the gyrus, and you can see that again some kind of disorganization cells. I told you one good thing about normal brain is that it is extremely hypocellular, but any reaction, any insult on the brain causes reactive proliferation of it. So that can confuse us. But what is peculiar is this also neuron, right? You agree, based on the nucleoli, but this is looking like a gametocyte because of cytoplasm, and there is another adjacent one, another neuron. So some amount of disorganized neurons are there, some glial cells are also there, but these kind of peculiar cells are there. Based on that size and variation, you feel that it is a anosognucleosis or anisocytosis and start suspecting whether it is a low-grade glioma, all those things. Okay, but neurons are evident, whether you start thinking whether it's a ganglioglioma or a ganglioid tumor or like that. But you know, vimentin is this is directly I'm coming to that. Vimentin is a mesenchymal intermediate marker. It comes positive in all the mesenchymal markers. But here, neuron is not derived from mesenchyme. It is derived from the neuroectoderm. But that doesn't mean that it is staying cytokeratin, being ectoderm, but it is a unique one, okay, which doesn't stain. Vimentin doesn't stain cytokeratin, but it got the intermediate filament gets modified to form GFAP, glial fibular acidic protein. That's the intermediate protein. So here the neurons are staining vimentin. That is the uniqueness. Otherwise, vimentin stains very faintly the glial cells. GFAP stains also glial cells. Even if you do a GFAP stain, it will be staining like this only. That means neurons have acquired that. Neurons are staining with GFAP glial proteins. Neurons are staining with vimentin. It was NeuN positive also. I'm just telling you the highlights of it. So this is a disordered proliferation of neurons, disordered formation of neurons, which we call it as dysplasia, not the dysplasia from a oncology point of view, it's a dysplasia. Or the other name is a disorganized growth, it's a tuber. It's a cortical tuber. You know, cortical tubers are associated with tuberous sclerosis. They are disorganized, basically they are malformative, epilepsy associated. They're all dysmorphic, dystrophic neurons. They are generally accompanied by gliosis, calcification. So that can confuse a person with, if they are not aware of it, with gangliogliomas, all those things. This is the normal cortical lamination is lost, seizures will be there, and all this thing. And again, triad, everywhere there will be triad, but very rarely we come across a triad. So it's a combination of clinical and clinical presentation and occurrence. Case 3 is somewhat similar. Again, long-standing refractory seizure, not responding to anti-epileptic drugs. And here you'll see some things like tuber only, right? A lot of cells here, almost mimicking like a ganglioglioma here. These are also disorganized, dysmorphic neurons. You can see these are all neurons. I hope you can see the nucleoli, everything. And again, more developed. These are referred to as balloon neurons, okay, which are abnormal. And I told you they are staining. Neurofilament is another stain. Vimentin, I told you, it will only stain the glial fibrils, but here they are staining the neurons. GFAP is staining. Now again, another important thing, see, you can make out the neurons, this by the shape also you can make out. Neurofilament, phosphorylated neurofilament is a specialized neurofilament which stains the axons. In the morning, Dr. Megha mentioned about neurofilament when she was talking about circumscription versus infiltration. So that means which disturbs the axons, nerve fibers. You can use this as a good stain. This phosphorylated neurofilament should stain only the nerve fibers or the axons, axonal proteins, but here they are all accumulated within the neurons, so they are staining it. So this is an abnormal dystrophic neurons. So they refer to as cortical dysplasia, not the dysplasia from a growth point of view. It's an abnormal organization of it. It's a malformation, developmental malformation, a migration defect of these neurons. They get arrested at a different level and acquires new characters. And these are various way of classifying it, too much of information. Don't worry if we classify in this way based on the recognition of how it is organized, how it is staining, and how it is associated with other lesions like trauma, vascular malformation, tumor, like that. So it's called as focal cortical dysplasia, and these are known for genetic epileptic conditions. They are generally some of them respond medically, but in due course they become medically resistant. Then it has to be operated and removed. So if somebody who is not aware of it may mistake it for ganglioglioma, all those things, and generally they are accompanied by a lot of gliosis that can also confuse us. So these are the differential diagnosis. You can definitely make out these are the differences where mass effect will be caused by a tumor. They will have its own characters. Then of course, because of the gliosis, sometimes a person may mistake it for a infiltrating glioma also. So basically we cover developmental, right? Among the various examples which I gave, we covered the developmental one. So I will cover the next category and then we can end the session. Sir, Madam Shantri sir is taking before, yeah. Okay, then I will just cover the next category and then we'll continue in the afternoon. So that means that we have part 1 and part 2, like many of the movies which are coming, Bahubali, all those things, that makes you compulsory that you stay for part, you see part 2 also. In the same way, people who have planned for going, you don't have to change the plan, but since you have seen, part 1 you have attended, try attending part 2 also, okay? Yeah. So this is the next way. Okay, one slide I should have brought it there. Basically, in this developmental thing, another group comes, what is known as choristroma heterotopias. You know that pancreatic, stromal, all those heterotopias comes. That also may be mistaken. You get glial heterotopia coming in the nose, all those things. Encephaloceles, that can be mistaken. Actually, this slide should have come before that. So some mistake happened, sorry for that. But this is applicable. The principle of this choristroma and heterotopias are applicable to any organ that you can apply there. And to complicate that, these heterotopias create many other changes locally. For example, you take gastric heterotopias in other organs, the gastric secretions creates damage and you get a lot of stromal response that will create more mass effect and other problems. So that also happens. So let's come to this example now. This is a middle-aged lady with some kind of localizing signs. In brain, one problem what happens here is something which is even low grade or benign, whatever you call, if it is blocking a ventricular pathway, CSF pathway, and it can cause global signs and symptoms. It can be very devastating. That's why more popular name given to brain tumors is grade 1 rather than benign, because benign tumors also can be symptomatic. So you don't use the word innocent. Benign means innocent, but they are not that innocent. So better to call grade 1 because they are benign, but they may be symptomatic also. Grading is mainly based on proliferative potential. So grade 1 means they don't have much proliferative potential at all. So this also patient presented with some visual disturbance and seizures and some vague global signs and symptoms. So there was a lesion in the right parietal lobe and it was impinging on the right lateral ventricle, some kind of mass effect there, and ring pattern of enhancement. Again, I told you about the reason for ring enhancement, all those things. And you know the differential diagnosis for any ring enhancement is anything which has got, there is a big list, infective versus vascular to immunological to tumorous, all the things comes. Let's take this, this is also a case provided online. I had given this soft copy. You can see this is again a stereotypic biopsy. That's why it's all in fragmented, see, small fragments only. It's a low power, medium it comes. But you can see the difference in the color, right? Here it's more pink, here it is some kind of tissue breakdown is there, softening, gradual rarefaction is a better word. And this is the next, I am focused the image only of this area, okay, because this looks more or less normal, not much of change here. So the change here is, sorry. So this is the area which we'll study, okay? And now this area you can make out that there is a lot of rarefaction, lot of activity you can see, because I told you normal brain will have a lot of pink, very few cells. But here you can see cells are filling it up. At the same time, there are all empty looking areas within that. Okay. Go a little higher. Some perivascular lymphocytes here, perivascular lymphocytes, rarefied stroma, microvesiculation you can call. Actually, if you see in the eye power, they are all foamy histiocytes. Foamy histiocytes is very common to see in the brain because lipid rich. Whenever any insult is there which damages the myelin or the cell, the myelin is released. Somebody has to come and remove it. So macrophages come, they engulf and they become foamy. So these are all foamy histiocytes. Foamy histiocytes, when they are there, it indicates either demyelination or some kind of lipid has been released either because of infarct or hemorrhage, like that. But here there is no infarction or necrosis. Only these cells are there. So probably demyelination. And whenever you see demyelination, you will see cells, foamy histiocytes, which are distributed perivascular and other things. In case of demyelination, you will see a special cell like this. Can you see? This cell has got small nuclear granules, nuclear fragments, and an enlarged cell. This is called as a reactive glial cell, which has got a granular mitosis-like multinucleation. It's not a true nucleation. It's not a true mitosis. It's in between. Again, a pseudo cell. It's called as Creutzfeldt cell. Okay, it's a reactive cell which is common to be seen in demyelinating conditions. So another case which is much better, that is not provided online. That's why I'm showing you this. Same thing you can see. Anybody will confuse this for a cellular activity. And here you can see much more cellular activity here. And if you go through this, you will see a lot of foamy histiocytes, which I mentioned, perivascular lymphocytes, perivascular foamy cells, and again, perivascular lymphocyte, perivascular foamy cells. And here you are seeing reactive glial cells here. So this combination of foamy cells, reactive glial cells, lymphocytes, perivascular and diffuse, perivascular and diffuse foamy histiocytes, all these things will indicate, it will indicate demyelination. Very good. And this is Luxol fast blue stained for myelin, central myelin. And you can see that these myelin is broken down. Then normally it will stain blue in the white matter, but here the blue is gone, it's pink. And the C cells have, these cells, foamy histiocytes have engulfed the blue granules, indicating that the degraded myelin has been engulfed. And to confirm that these are histiocytes, you can do CD68, CD163, and it is confirming that. And the most important danger which in the brain we'll suspect would be lymphoma whenever lymphocytes are there, because there are no native lymphocytes in the brain. Only when there is an insult, especially immunological or infective insult, these lymphocytes come. So you have to differentiate or pick up lymphoma or any lymphoproliferative disease. One good thing about primary CNS lymphomas are that more than 90% of the cases are primary diffuse large B-cell lymphoma. So only a small percentage is there. So CD20 we rely on. Most of the reactive conditions, infective, inflammatory, are all CD3 positive, that is T cell rich. One problem is whenever lymphoma, primary brain lymphoma, if it is exposed to steroids, they tend to have lymphocytolytic effect, then T cells will rise. So that is one problem where that we also have demyelination. All lymphomas will have demyelination, or that if steroid is exposed to that, that will also cause demyelination, complicate the situation. It will look like this. So you have to differentiate a demyelinating condition most closely from a lymphoma which is exposed to steroids. So that's the reason why we do that. And to pick up the reactive glial cells, we do GFAP, and these are the reactive glial cells. Neurofilament, I told you, this is done to differentiate between a demyelination from infarct. Infarct means the entire tissue is broken down. So even the axons are broken down. So neurofilament stain won't be there. If it is a demyelination, the parenchyma will be intact, axons will be intact, only the myelin is stripped off. So you can see the neurofilamental fibrils, which is representing the nerve fibers or axons here. So basically we are dealing with a demyelination condition. These being the findings. Okay, perivascular and diffuse histiocytes, which are basically foamy in nature. Lymphocytes also perivascular and diffuse because they are immunological condition. To accompany this, there is a lot of tissue response, stromal response in the form of reactive glial cells, but no destruction of the axons. The axons can get destroyed in the late phase. No necrotic areas, indicating that it's not an infarction. Putting all together, this is a demyelinating pathology which is having mass effect. In the history, I told you it was localized and it was impinging on the ventricle. So mass effect. So this mass effect is called as tumor-like demyelination. So tumefactive means tumor-like effect caused by a demyelinating condition called as tumefactive demyelination, which occurs due to many reasons. As doctor mentioned, it could be one of the variant of multiple sclerosis, a localized variant, or there are other conditions which can cause localized or diffuse demyelination. All this put together, the basic theme is it is a immunological response, and these are the some of the literature about this. I think this you don't have to concentrate. You can read on your own. But definitely a diagnostic challenge, not easy at all. It could be. So the problem what happened is I told you about the stereotypic biopsies. Whenever you get small biopsies, you get this. Suppose the biopsy needle has gone at the adjacent region, peripheral region, you get glasses. So you don't know whether it's an adjacent or the more representative area or epicenter of the lesion. Then sometimes if you get only foamy-histiocytes, foamy-histiocytes comes whenever there is hemorrhage, infarct, demyelination. So you don't know whether it is adjacent to a more different pathology. That's what happens. And reactive glial changes can be florid in some conditions. That can also complicate. I already mentioned about the problem with lymphoma steroid effect. Fortunately, for such challenges, you may have to very carefully look at picking up atypical lymphoid cells because few cells will be somehow surviving. Not that all the cells are destroyed. So some cells will be still there. An angiocentric pattern will be there in lymphomas. You may have to pick up apoptosis, sclerosis, necrosis, mitosis. These are all general principles. How many of these parameters will be there available in the biopsy? That depends. You have to take all these examples. Now, another example where middle-aged again with some kind of visual defects and a headache. Then there was cranial nerve palsy. That means to say there is, cranial nerves are all there at the base of the brain. So that means a lesion in the base of the brain that is causing this problem. You can see this is in the anterior cranial fossa, involving both anterior cranial fossa and middle cranial fossa. You can see a lot of cell infiltrate, right? Fibrosis. I'm stopping in 2-3 minutes and after this. I'll continue in the second part. So you can see a lot of stromal proliferation infiltrates. We'll go and any idea about what are the cells which is infiltrating here? Lymphocytes and plasma cells, and you can see some kind of concentricity of the fibrosis around the blood vessels, dense, and you can see a lot of plasma cells. This may not be visible here. I'll show you. And this is IgG, this is IgG, IgG4. And another case I'll show you. You can see the infiltrate here, lot of proliferation, lot of stromal response. You can see the fibrosis here. And here you can appreciate plasma cells better, I feel. Okay. And going further, this is the concentric angiocentric fibrosis, which you can see. Again, concentric endarteritis. And this is ionized blood vessels, plasma cells everywhere. I think you are sure, already got the hint what I'm dealing with once I use the word IgG, IgG4, all those things. And here the plasma cells. So this one clinically, radiologically will look like a mass tumor. Sometimes the plasma cells are so dense, you get a feeling that whether we are dealing with a plasmacytoma, all those things, or whether it's a neoplasm, like that. So here you are dealing with a lesion which has dense lymphoplasmacytes, stromal fibrosis there, vascular sclerosis. Lymphocytes not much, no granulomas. This patient had an elevated IgG4. That's an important clue. And this is the ratio which I showed you in the previous slide also, more than 50. So this belongs to the category of IgG4 related sclerosing disease, a popular disease these days coming up in retroperitoneum, mediastinum, and of course peripancreatic area and in the skull base. And this is the features which you will see. This is the summary of the findings in this and in general. Most important is the IgG4 level serum. And this is the spectrum which it's available from the textbook. Don't have to worry too much. Everywhere, every organ. That's why I told you, whatever you study for this organ is applicable to every other organ also with the same principle. But since I'm using that, very important that you fit to this criteria. It's the 2020 revision on the criteria for this. 3 things are important. One is clinical, another one is biochemical, and then comes biochemical or serological, whatever it is. Criteria 3 is what histopathologists have to do. So you need to have either, if you have all the 3 criteria, it's full, definite. If you have 1 and 3, that is histopathological and clinical, then it's probable. Then possible, only 1 and 2. So histopathology plays a major role, okay, in defining that. So criteria 1 is clinical, where you will see the lesion presentation, which can be very commonly suspected. That's why many conditions are suspected, but we don't fulfill the criteria because it fails either in criteria 2 or criteria 3. Criteria 2 is also there, but criteria 3 is most of the times not fulfilled. Then also it become very less definite that is possible. So what is criteria 3? Histopathologically, 2 out of 3 should be filled. One is whatever I showed you histologically, dense plasma cell infiltrate lymphoma with fibrosis. In that, IgG4 should be more than 40% of the ratio, or in one hyper field, it should be more than 10. And of course, this is typical that storiform is very important, oblative phlebitis. So 2 out of 3 is very important. So serum and Histopathology may plays a major role because every other case clinicians will suspect, but it is not. This is one just one example. This is one recent case which came, which was suspected to be meningioma. Okay, in the lower spinal. This was the lesion. Sorry. This is I got confused. This one just a misleader prolapsed into a disc. There was a lesion in the middle cranial fossa, very unique, which supposed to be second in the literature. Second case in the literature. I'll tell you why. Because this troubled us a lot. They suspected meningioma. It was not fitting with anything. It had nice angiocentric fibrosis here, nice gliosis. Plasma cells were minimal. It was not fitting with that. See the gliosis here, fibrosis around the blood vessels, and lot of eosinophils, lots and lots of eosinophils, large mass. So we are worried what name to give. It was not fitting with anything. I'm just showing a very brief hint of it. In the exam only we will be comfortable because they're all straightforward. But in practice, every second case will be too complicated. You have to invariably refer. So this case was not fitting with anything. So we spent what I was searching literature, and the one which fulfilled was this. It's an uncommon benign lesion which are involved in all these regions. Our cranial fossa means anything which is there in the sinus, all those things can reflect on that because of the close proximity. So anything which is there within the compound or adjacent can affect us, right? Exactly like that. So this belongs to the IgG4 related spectrum disease, belonging to the category of allergic or exaggerated immune response, and very challenging. Supposed to be second or third. They have given this name, eosinophilic angiocentric fibrosis. Again, the spectrum of same exaggerated response. Okay. So I have requested our resident to work on that and publish it. Let's see. And this is another example of it. This is the one which was a cellular mass with, this is important case which I have to discuss. A challenging case. Again, middle cranial fossa involving the cellular region. They thought it is a cellular mass, a tumor. Nothing was contributing. The only thing what was there that is prolactin was elevated, all else normal. They thought it is a pituitary adenoma, no doubt of it. And anything which compresses on the stalk decreases the inhibition of the prolactin, and prolactin elevates. So that is a natural response. So this was the differential given. You can appreciate that this is the pituitary glands which is shrunken. This is slide given actually online. You can see a lot of lymphocytes are there. A granuloma over here with giant cells. So granulomatous, what you will call hypophysitis. A very important differential. After awareness by our clinicians, they started anything which is peculiar on radiology and on peroperative, then they were giving differential. But till one level, any case of cellular lesion, the only differential was pituitary adenoma. Okay. After awareness, they are giving that also as differential. This is a granulomatous hypophysitis. Of course, in India, you should always rule out TB, no doubt about it. But abroad, they will consider directly immunological, any of those things. But this is a condition which is immunological in nature, generally, but you have to rule that your decision should come only after you have ruled out TB. So this granulomatous hypophysitis, the full spectrum. I'm not going to the details. It's an immunological disorder where you can get either a lymphocytic hypophysitis or granulomatous or xanthogranulomatous. All these are exaggerated or deviated dysfunctional immunological response. So these are the examples for it. Primary are the one which is immunological. Secondary would be due to infective conditions like that. And these are the different groups. Again, belonging to the spectrum of IgG4 sclerosing disease is one category of hypophysitis. Necrotizing one comes. These are the various examples. Let's not spend time on this. You can read on your own. So what did we cover now? Immunological and inflammatory. So two categories are over. So I will end at this level. I think I wanted to show, I think I will end this level. Part 2, we will see later. Till that time, suspense. Okay. Yeah. Thank you.
And just I will mention here only few words. As you said that previously, because nowadays samples are very less and they need more extensive investigations. Because nowadays patients also very intelligent. They want prognosis.
Yes.
If you come with a scan in OPD, they'll first expect me that what is my survival rate, whether it is tumor, SOL, whatever it is. And we also have some criteria to when to operate, when not to operate. And if what they will expect me if you operate. Those lesions, any lesions are there which is expecting to grow further because it is a closed cavity in the cranium, we'll worry about the site and size and prognosis. In that, what is now recently what we are planning is safe maximal resection. I want my patient to walk independently, even whatever the lesion is. Few days is enough for me. If a patient survives for more than 10 years bedridden, I don't want that.
Correct.
That is what recent criteria is there. So obviously, I want diagnosis, definitely, because I have to explain to the patients, I want to explain the prognosis, everything. Very excellent topic you have covered. It's a very difficult topic, definitely, because I will also not end in anywhere. And if I tell create probably is a glioma means, you will expect and they know that they will also, that also they'll Google it. Glioma means I will survive this much only.
Yeah.
They will not ask me.
Correct.
If they say that is a benign lesion, again, they how long I can survive? What is the again criteria is there like that only? Very excellent topic. Anything is there? Any doubts? Please open topic.
Sure that the clinician is still with the radiologist still there, it is a mass present there, and it is the HMB showing gliosis, then how can you very surely rule out that it is low grade glioma?
Yeah.
Any marker, because markers also are not very helpul because GFAP and neurofilament will be positive in both the cases.
Yeah. See, I agree with you. As long as we are in the two different rooms, this kind of discussion will be happening. So this is the need for a multidisciplinary MDT programs. So fortunate that we will have every alternate week sessions like this with neurology, radiology, and neurosurgery. So that is the time where we get a chance to explain the difficulty. These are the things, and they will tell the reason. Then they will try to correlate. Of course, there will be always some cases, there will be differences where it is not acceptable to them. We have hit the lesion, like that will come. But when you show this is the thing, we cannot go beyond. That is the. Now, I would say even pathologists are like advocates in the court of disease law of diseases. Until an evidences, they are telling that they are claiming. It's like the culprit and the victim type of thing. You are the advocate. Until you have evidences, you cannot tell. You can tell that. So there are lesion, but this there. But this convincing capacity comes when you are in the same roof, same hall, under the same table. So that is the need for multidisciplinary MDT program, multidisciplinary programs thing. So that is very important. For every oncology case, it becomes a must. So at least the difficult ones you can choose. If not every case, the difficult ones can be chosen. And that kind of unsatisfaction will be there from that side. But one thing I realized, now you have to add 4 blocks. Let's take if this is the room, if you divide into 4 quarters. One quarter is clinician, usually clinicians takes a major quarter. So it spills onto the other one. Then comes radiology. Then nowadays is coming other ancillary tests, including genetic, molecular, all those things. And last comes this. Invariably, they depend on us. That's the reason an argument comes, and that is the most weighing and the last word of it. Suppose if a pathologist is telling that this thing, either something is outlier, they have to go back to that. And the outlier most of the times would be either genetic, because clinician will be the center, he will know. Outlier will be either the radiology or the molecular one. So you have to be careful that you can communicate. If they go back and reevaluate, there will be something odd, something not fitting with that and all those things. But that challenge, it's a professional challenge, I would say. Thank you. Madam, can I? Sure, madam. Thank you.
And I often get asked about the etiology of it.
Yes.
Because when you talk about non-tumorous lesions in the sella, now we have granulomatous hypophysitis and IgG4 coming as a big
Yes.
way. IgG4 is treated with steroids. And so even if you see necrotizing granulomas, the tissue yield of AFB is always poor. I remember like doing lot of tuberculosis autopsies in KEM.
Yes.
We used to do almost 4,000 autopsies per year, and many of them used to have tuberculosis. But we have hardly seen sella being involved in those cases. Even in disseminated cases of TB, we don't really get pituitary involvement.
Yes.
So what to do about these cases? Because when the clinician sees these reports, not that there are too many, there are few patients, they invariably tend to start ATT.
Yes,
So
yes.
I honestly want your experience
Definitely.
about granulomatous hypophysitis.
Very well said. That's a practical issue. I will share my discussion with our infection specialist neurologist. The thing is that tuberculosis, 2 organs are relatively spared. I would say only relatively spared. It tends to still involve. Muscle is one because it continuously pumps, never allows the tuberculosis to stay. But we have come across tubercular abscess in a immunocompromised state. Of course, when it comes to cellular, pure cellular is extremely rare. Extremely rare, pure cellular tuberculosis. Most of the times it is tubercular osteomyelitis in the base area, or something which has filled the base of the brain somewhere else, then extension only. So when you discuss, when you communicate, we don't know what exactly is the site of biopsy, everything, or what is the other thing. So far, only one case, they very strongly suspected TB. In all other cases, their differential was mainly vaginal granulomatous, one of those immunological conditions only. But since we have given granulomatous, that time in the initial stages, they were also not aware because of the general dictum of granulomatous, they thought it is TB. But once I mentioned that this is mainly immunological thing, you have to correlate. They also referred and they saw that pure cellular involvement is extremely rare, either associated with adjacent lesions or extensions. Somewhere else you will have lesion intracranially or very close proximity. So at least the infection space, but they may go purely by the word of granulomatous. This thing, that may be the confusion. Otherwise, most of the times it is this thing. But what the neurologist mentioned is they've come across some of the literature, at least in African and some of those Southeast Asian countries also, few involvement of pituitary region, it seems. Not pituitary gland as such, but adjacent area like an extension of the exudate or somewhat. Because of that reason only they are concerned, because steroid should not flare up the thing, and that is the only reason. But even if they give ATT, they said they will add up steroid and try to back it up. Thank you.
We thank Dr. Nandish sir for enriching our understanding and stimulating further discussion on the topic.
We thank Dr. Anita ma'am and Dr. Basuraj sir for chairing the session.
I would request the chairpersons. Okay. I would request Dr. Mamta ma'am to give the certificate. I request Dr. Mamta ma'am to present certificate and token of gratitude to the chairpersons. Thank you, ma'am. Thank you, sir.
Our next event is a slide seminar on salivary gland tumors. I would like to request Dr. Shantvi Rupin sir to engage us.
Okay. ಅದು ಹಚ್ಚಬೇಕಾಗತ್ತೆ ಅದಕ್ಕೆ I know it is a very difficult time, no? I am between your lunch and so I think it is difficult to get your attention. I'll try to be as interactive as possible so that yeah. Better than a talk, usually. Where is that? I think we'll finish the. Yeah, I'll wait. So finish the.
Yes, sir. I request Dr. Nandish sir to come up to the dais. And I request our chairpersons for the previous session to Dr. Anita ma'am. And Dr. Basavaraj sir, to present the certificate and token of appreciation to Dr. Nangesh sir. Thank you, sir. Thank you, ma'am.
Shall we start? Okay, we'll start with the first case. I'll try to make it fast. If there is a lot of theory, I'll cut it down. You can read from the books. Let us discuss the case. This is a 64 years female who presented with Zika symptoms. A patient had a 20 kg weight loss, and HRUS neck was suggestive of inflammation of the salivary gland, the sialadenitis. Patient also had a pancreatitis, and her lab investigations had revealed increased serum creatinine as well as calcium levels. This is what, and the patient also had a PET scan done, and it showed an uptake in both the salivary glands. That's what the nuclear scan was suggestive of, and these are the other images. And their clinical suspicion was whether Nandish was discussing about IgG4, several sites it can involve, and this was also suspected clinically as IgG4 disease, but her serum IgG4 levels were normal, and the parotid gland biopsy was sent for histopathology. It's a simple, straightforward case. Probably, I thought you might have not seen one case like this, so I thought I'll share this case. So what you are seeing, it's scanner diagnosis. No, what normal parotid tissue. Okay, what are these? Giant cells and granulomas. So it is a normally you might have seen granulomas everywhere, but not a parotid granulomas. Let us go. What are these for postgraduates? What is that? The arrow mark? Asteroid bodies. Where do you say asteroid bodies? Huh? Yeah. What else you will see? Schaumann body also. So it's a granuloma, non-necrotic granulomas. Very compact looking granulomas comprised of epithelioid cells. You have giant cells showing these asteroid bodies as well as calcific bodies surrounding inflammation of lymphoplasmacytic infiltrate. With this, only thing is the patient presented with dryness of the mouth and all those things. This is very, means we don't get a parotid biopsy for sarcoid. You diagnose in a skin biopsy, or you have lung biopsies, sometimes lymph node mediastinal biopsies, not the routine tissue. And this patient was a case of sarcoidosis, and it was managed, and this was given as granulomatous inflammation. We favored sarcoid in this because non-necrotic granuloma, and tuberculosis involving the salivary glands is very unusual. So putting it that and morphology of this granulomas, and we suggested this, and patient was treated and recovered. We'll move on to the next case. This is a very simple case. I have already shown an example of that in the morning. 59 years male presented with right parotid swelling. Parotidectomy, I want diagnosis on this because it's a pretty straightforward case. Yeah. Wadin's tumor. You see normal parotid tissue here, and you have this cystic and solid lesion and this eosinophilic fluid like thing, and you have this lymphoid stroma. And if you have a closer look, you have those typical bilayered oncocytic looking epithelium. So these are areas which were showing squamous metaplasia. When this becomes predominant, that time you may have a morning also I stressed upon that. There may be areas of squamous metaplasia in some cases. So that, and some areas of mucinous epithelium also. If entire lesion is this, then the differential is mucoepidermoid carcinoma may be mistaken for that. Or you can have an oncocytic variant of mucoepidermoid, then again it is a problem. But lymphoid stroma is important, but you can have lymphoid tissue within the mucoepidermoid tumors also. That's what it is. So it's a simple, pretty straightforward case. One thing about this, you know that these are typical histological. This is more usually salivary gland tumors are more common in females, but this is one tumor which, and another entity I'll come across, which is more common in males and has some association with cigarette smoking. Okay, that is what you have to remember. No IHC is required. It's because its morphology is very typical. And what I want you to remember is infarcted or especially if the infarction is spontaneous or following your FNA, then it can undergo extensive squamous metaplasia. That time it becomes difficult. That is the only situation where you are worried about. Otherwise, Warden's tumor is a pretty simple, straightforward diagnosis for most of us. So that's one thing you have to remember. Whenever there is a squamous metaplasia or a mucinous metaplasia, which is either spontaneous or following an FNA, then you can have problems. And I have already touched upon that. Warden-like mucoepidermoid carcinoma is the one different, but their mucoepidermoid carcinomas have mammal2 rearrangements. So that is very important in such situation where you have a differential between these two entities, and surgical excision is curative. We'll move on to the third case. This is a 59 years male again. I said one entity which was more common in male. This is the second one which I am showing you. The patient presented with right parotid swelling, and this is these are sections from the parotid gland. What you are seeing is a normal tissue at the periphery here, and the tumor which is infiltrating. Okay, it's pushing but infiltrating here, and you have a predominantly solid interconnecting trabeculae and islands of pink-looking cells. Whenever you are looking at tumor, you have to see at a lower magnification whether it's a blue tumor or a pink looking, because that will give you some clue whether it's a basaloid or more epithelioid looking or epithelial looking tumor, and not much stroma. If you see, there is a fibrous stroma, not a typical myxoid or a hyaline or a chondromyxoid stroma as such. You have some areas where it is some glandular differentiation is there. Okay, this is what we can see at a this magnification. And this patient has these glandular structures and solid areas. What you are seeing, these glandular structures are lined by, I don't know, this pointer is moving here. Yes. These are mucous cells, okay? And around that you have intermediate or very early squamoid looking cells. So it is a very typical, I am showing you typical cases, nothing that you have not seen, just to discuss these cases. And this has a combination of mucus and squamous cells, same thing. And some areas, they look immature squamous, what we call as the intermediate. This is more intermediate looking cells, no, in the down images. So there it is difficult, almost like a squamous metaplastic cells. So that is area. The other areas you have fully developed squamous cells, and these are the areas where there is a clear cell pattern. Sometimes mucoepidermoid carcinomas have oncocytic, purely oncocytic, some clear cell areas. So they, depending upon the component, you can mistake it for other. Like if it's a predominantly clear, either a myoepithelial tumor or a clear cell tumor, those are the differentials when it comes. Or if there is predominant mucin, you may not find a squamous component also. So this is a mucoepidermoid carcinoma. And one thing you have to remember about mucoepidermoid is now mammal2 rearrangements are very classical for this entity. And this usually seen in majority in more than 50% are in major salivary glands. I have shown the incidence that parotid is more common, followed by submandibular and sublingual, but it can occur in, this is one of the tumors which occurs both in minor and major salivary gland. So there are, morning I have shown you a slide, there are where the grading is required for certain tumors. Not all salivary glands tumors you grade, and one of the tumors which you grade is the mucoepidermoid, low grade, intermediate grade, and high grade, depending upon the component of the type of cells, whether it is circumscribed or not, increased mitotic activity, perineural invasion, lymphovascular invasion, and bone invasion. So you classify the grade that whatever, not only you say that it's mucoepidermoid, you have to also grade whether you are looking at a low grade, intermediate grade, or a high grade tumor. Okay. And these are the mutations which you see typically, and the most common one is the first one, CRTC1 and mammal2. So if you have a mammal2, you can diagnose most of the things. The last one is very unusual. Okay. So sometimes you may have to use IHC, otherwise you don't require IHC for a typical case of mucoepidermoid carcinoma. Sometimes you use P40 and 63 and all those things to help differentiate from other, that should be positive in case of mucoepidermoid. Coming to the next case, 48 years male, presented with difficulty in breathing. It was a tracheal mass. I am presenting as a tracheal mass because it was a salivary gland tumor that is given away because this is a so typical morphology I was telling you. classical adenoid cystic carcinoma. All typical cases only I am presenting, but just to show you some IHCs and what needs to be done. So you have those lobules and nests of cells. Within that, you have a cribriform pattern. And in that, if you go closer, you will have some true luminous and some pseudo luminous. What is true luminous are lined by the epithelial cells. Pseudo luminous are nothing but they are spaces which contain this basement membrane like material but surrounded by myoepithelial cells. I'll show you IHC how it brings out these two types of cells very well. Okay, this is a closer view of that. See this IHC. What is this? CK7. CK7 is staining some of those spaces. Those are the true luminous where it is surrounded by the epithelial cells. There are some spaces which are not even surrounded by those CK7 positive cells. Those are pseudoluminous which are surrounded by the myoepithelial cells. I'll show you the next photograph. This is a colponin. Colponin is a myoepithelial. If you see, it is staining everywhere because adenoid cystic carcinoma has predominant myoepithelial component. Okay, I'll show you one. This is P63. You see where so beautifully it is making out. There are some blue cells within that that side. No, those are epithelial cells which are unstained. Those are the true luminous. The other areas, if the empty space is immediately surrounded by the these P63 positive cells, those are the pseudoluminous. So if you do IHC, your morphology becomes very, very obvious. Then you can identify which component you are looking at. Okay, fine. So this is CD117, which we use for GIST, is also positive in adenoid cystic. It stains the epithelial component. It's not specific. It can be seen in sometimes in polymorphous adenocarcinoma also. There we again use additional marker, like one of the close differential, especially when it occurs in the oral cavity, is polymorphous adenocarcinoma, especially the cribriform pattern if it is there, or some, it can be confused for, because there also cells are very monomorphic. There we use either we can use a P40 versus P63. Usually in P40 is negative in polymorphous adenocarcinomas. So that will help. Apart from, of course, now there is, if you have a molecular setup, this have MIB rearrangements, these adenoid cystic carcinomas that can be used, and IHCs are also available, but we don't have MIB IHC. Okay. This is an adenoid cystic carcinoma. I'll not go into the theory part because I think it is very close to your lunch time. And important things only I'll highlight, that this tumor has both epithelial and myoepithelial neoplastic cells, and this can have different morphology. The classical we know is the cribriform type. We can have a tubular, or we can have a solid. Those are the ones which may sometimes cause problem in identifying the entity. And I mentioned this MIB and MIB-L1. These are the typical rearrangements found in patients with adenoid cystic carcinoma, and this will help in diagnosis but may not be necessary in all the cases. Coming to the other things we have to remember is Perineural invasion is very hallmark of this entity, but can be seen in other tumors as well. So adenoid cystic carcinoma is one of the tumor typically where you want to demonstrate a perineural invasion. So that is one thing you have to remember. And second thing you have to remember, some of the adenoids, recently, just I think 1 week back, I saw a patient who had a adenoid cystic carcinoma 2-3 times resected, now presented with a recurrence. And that was showing a high-grade transformation. So high-grade transformation is known in adenoid cystic carcinoma. The cells become very atypical and lose the myoepithelial nature. So there it becomes difficult. But this patient had a history. We considered it as an high-grade transformation. Either it should be a poorly differentiated carcinoma or an anaplastic-like carcinoma which develops there. And myoepithelial cell component is lost. So if you do IHC also, there will be not hardly any myoepithelial component, and proliferation index also increases. So that can happen. This is one of the tumors where high-grade transformation can occur. So in salivary gland tumors, you have to remember there are peculiar features, like you have to know certain tumors which look bland only on invasive properties. They can be called as malignant. Like I was mentioning oncocytic tumors, myoepithelial tumors, and basal cell adenomas. So there atypia may not be present, still they can be malignant based on their invasive properties. And there are certain tumors where initially they are a typical carcinomas, but they undergo high-grade transformation. This is adenoid cystic carcinoma, can undergo high-grade transformation. One other entity, polymorphous adenocarcinoma, earlier we used to call it as polymorphous low-grade adenocarcinoma. The terminology of low-grade is removed because they also can have high-grade areas. So these are the things which you need to remember. And you see the ductal and myepithelial component based on the IHCs. So usually ductal components morning also I stressed in this adenoid cystic CK7 and c-KIT I showed the example, and myepithelial component you can use SMA, Calponin, P63, P40. MIB IHC is available. Now one more thing good about molecular diagnostics in present era is many of the markers, if you don't have a facility for say a FISH or a PCR or an NGS, some of these molecular abnormalities, surrogate markers are available. So they are mutant specific proteins. And that if you have a IHC facility, you can do. We do a lot of mutant specific, not for salivary gland tumors. We do have, Dr. Megha was showing you morning, all these IDH mutant proteins, ATRX and all. In bone, we do use a lot of like histone G34W for a GCT. We use K36M for a chondroblastoma. These are very mutant specific. You don't have to do a molecular testing if you have those IHCs. So mutant specific antibodies are available. Even for plaque morning, I was telling you that is available for pleomorphic adenoma, and this MIB is available. So if mutant proteins are available, if you have a IHC setup, you can procure and start doing it. You don't have to have a PCR or a NGS and all. So that has become very easy because it can be interpreted by your routine light microscopy. You don't need a fluorescence microscope for doing a fish studies and all. But I think that is changing, and everyday specific ones are coming. We have synovial sarcomas. We used to always do SS18 FRISH. Now we have a marker SS18, which is a mutant protein IHC. So you can do that. So you don't have to have a fish study for doing these things. So IHC surrogates of molecular abnormalities can be routinely employed wherever you have a IHC facility. Only thing is which numbers, because these antibodies are little costly, you should have sufficient numbers to order them. Otherwise, you will not be able to justify the cost. That is the only problem. So we almost now we have majority of these mutant surrogates in our department. So we do, so because we have a referral, ours is a referral center, we get samples from all over different parts of country as well, actually, as far as Assam sample we receive. So we do have sufficient critical numbers to do this test. So if you don't have, you can send it for testing these things. Coming to the next case, this is 52 years male presented with a swelling in the parotid gland, and parotidectomy specimen was done. So any diagnosis on this scanner? It's a very pretty solid looking tumor, is it? Anything? Solid lobules surrounded by this hypocellular collagenous stroma, many monomorphic looking, not much atypical cells. Okay, any differentials? Polymorphous adenocarcinoma, parotidectomy, very unusual. Polymorphous adenocarcinoma, I said majority are oral cavity lesions. You don't diagnose it. So that's why don't go to the morphology. First, always take history, then, so it is less like parotid tumors. Possible. Okay, the acinic cell. This is an acinic cell. This has a focal glandular areas can be there. Okay, this has that bluish tinge to the cytoplasm. Okay, so these are follicular-like areas which can be present. So this was showing perineural invasion and lymphovascular invasion as well. So those perineural invasion you can make out. Yeah. So pass diastase showing positivity. We did dog1. Dog1 will be positive in this. SOX10 is also positive. SOX10 is a nuclear stain. So staining all these cells, and dog1 was positive. Dog1 again we use in this. Dog1 stands for discovered on GIST. So dog1 is discovered on GIST. So dog1 can be used here. Usually this will be negative for mammoglobin. We use this for differentiating for secretory carcinomas. Their mammoglobin will be positive. Okay. So this was an acinic cell tumor, parotid. 90 to 95% occur in parotid gland. So that's why that site is very important. It consists of serous acinar cells. It can have variable pattern. I said solid, the majority of this tumor had solid areas. It can have microcystic or a follicular pattern, or sometimes a papillary cystic pattern. That you have to remember. Coming to the next slide, this also can undergo another tumor which can undergo high grade areas. That's why conventional should be there plus high grade carcinoma. This another tumor I told you, no, you have to remember adenoid cystic can undergo high grade transformation. This also can undergo high grade transformation. So you remember this, especially when the patient had a recurrent tumor and comes up with and sometimes the recurrent tumor may be entirely high grade tumor, and you may not even identify that there was a actinic cell tumor in the past. So those things you have to remember. And markers I have already said, and this also has a specific rearrangement, NR4A3 rearrangement that is seen in these tumors, and almost so it is almost seen in 98% of the cases times it is that. So that is example of a actinic cell tumor. This was a 46 years male presented with right parotid swelling. On examination, there was a mass measuring 4:3. Superficial parotidectomy was done. What is prominent in this tumor is these are all big nerve figs, no, which are all showing perineural invasion. So it is definitely obviously malignant tumor. What is the morphology of this tumor? If you look at this tumor, it resembles something else. Huh? IDC, breast. So what salivary gland tumor looks like IDC? Salivary duct carcinoma. Simple, very simple, no? Yeah, these have these irregular things. It those eosinophilic looking cells, epithelial looking cells, and a lot of fibrous stroma is there. You see the cells, they'll have eosinophilic cytoplasm, vesicular nucleus, distinct nucleoli, mitotic activity will be there. So, and cellular stroma is there. There are areas showing highly noised nodule. Whenever you find a highly noised nodule, that may be indicative of a previous pleomorphic adenoma. Especially salivary duct carcinomas can arise in the background of as a carcinoma ex pleomorphic adenoma. You can have duct carcinomas also. But usually they say that either one, you do a plaque and test that was a plaque positive, or you can have a highly noised nodules which is a residual of a pleomorphic adenoma. So this I was not aware whether this patient had a prior pleomorphic adenoma, and it can also show these cleft-like spaces surrounding these nests of cells. So this is a closer view of perineural invasion. So what marker we do here? Androgen receptor. So androgen receptor is a positive here, nuclear positivity. What else you do for salivary duct? HER2/neu. That is another tumor which is HER2/neu positive, no? Not aware? Yeah. So this was HER2, not very intense, but there are areas of HER2 positivity. So this is P63. Okay. P63, why we did? So what we just wanted, sometimes it can have an in situ component also. So that will highlight some of these nests, most of it is lost P63. Some of those nests have a peripheral rim of this P63. Those are in situ areas. So what you see in a breast also in situ tumor will have a myoepithelial still preserved with those areas just for a academic interest. But anyway, this is now a very infiltrated tumor. So, and KI67 was done. This is salivary duct carcinoma. I'll not go into the theory because this is another tumor which is common in males. One thing you have to remember. And usually old age patients, and I have already mentioned, it can occur as a component in a carcinoma ex pleomorphic adenoma, can be a salivary duct carcinoma. Otherwise, it can be de novo salivary duct carcinoma as well. So the markers I have already mentioned: androgen receptor, HER2 in 33%, CK7 will be positive because it's epithelial component, ascendant and SOX10 are negative in these tumors, and P63 can identify that intraductal, what I was showing, that portion it can identify. Coming to the next case, this was a 55 years, I think 9 cases I will be discussing. So this is the 7th one. So 55 years male presented swelling on the left cheek. This actually came to us as it was reported something else outside and came to us for second opinion. And this was predominantly solid and cystic lesion. So this is morphology. If you see normal parotid tissue, and then you have a lesion which has a microcystic appearance, nests of thing, almost like a microcystic appearance. These are the closer view, having those microcystic pattern. Some areas, they look like this papillary-like structures. So this has secretions within, okay? So cholesterol clefts, areas of secretions and all. So this was S100 and mammoglobin positive. What I said was, yeah, some areas of GCDFP protein and also peripheral areas of DOG1, not the entire lesion. So this is a EMA and P63. And this we sent it because we suspected secretory carcinoma. It has a specific molecular abnormality. So we say, I don't have that time we didn't have a PCR setup in ours. So I sent it to Dr. Jay from Mumbai. So we did this and it came to be showing that ETV a rearrangement. So this was a secretory carcinoma. Earlier we used to call it as mammary analog secretory carcinoma. It is similar to the secretory carcinomas occurring in the breast. So now the mammary analog is removed, only secretory carcinoma. So this is a secretory carcinoma which has a specific molecular abnormality, and this was, I think we published some time back. So this has that ETV6 NTRK3 rearrangement or ETV6 RET rearrangement. So that can be used. Apart from that, IHC and molecular morphology, we should suspect it, and then we can make a diagnosis of this entity. Coming to the case number 8, I think this should be the last one. 6 months old female child. Again, this was sent for opinion to us. It was reported as a round cell tumor, right-sided parotid swelling when child was 1.5 months old. So what do you see? Normal tissue, and there is a lesion here. Okay. Any diagnosis on this? One and a half months से शुरू हुआ है child, that was the tumor. So what you are seeing is the lesion is infiltrating in between the normal tissue. There are ductal structures, atrophic acini in most of the areas, but the lesion is infiltrating in between so it was called as a round cell tumor, possibly rhabdomyosarcoma. Do you agree with this? Because head and neck, child. Okay. Can we see this next slide? It is not coming. See this. Can you make out here? It is a vessels. Those are all actually, if you see the round cells, solid areas are also endothelial cells only, but the lumen has not formed. And there are areas where the vessels are showing up. So this was like a vascular tumor which is infiltrating into the salivary tissue. What is the problem? ಯಾಕೋ ಮೂವ್ ಆಗ್ತಾ ಇಲ್ಲ. Just see. 1 minute. Battery problem. Can we connect? So this was a. Can we connect this one? This was a juvenile hemangioma, which is very cellular. They can be cellular and look like round cell tumors. And one more interesting thing I just want to show you, because you might have not seen. This we did a IHC and confirmed that it is a sorry for the problem. Okay, this here you can make out vessels. So sometimes, especially the hemangiomas in other locations also, in infants, you may have very cellular looking tumor. You have to be very careful. The lumen are not formed very well, and it may look like a round cell tumor unless you see it properly. And usually there will not be much ATPI and all, but they look very cellular tumor. So this is a hemangioma involving the salivary gland. And this patient also had this finding. What is that? Anybody? They can get chocolates from the organizers. Only for resident what? No, these are the ductal cells, adjacent ductal cells. Lot of inflammation. I'll show you closer magnification. What is this? That is an owl eye. That was a cytomegalovirus also there infection. So these are the nuclear inclusion and these are cytoplasmic inclusions which are granular. So this patient also had a adjacent salivary tissue showing cytomegalovirus. See, can you make out that the other one outside that? So intranuclear as well as cytoplasmic, the other one. So that had so many ducts are involving where epithelial cells are showing this. So this has a combination of juvenile hemangioma plus CME. We did confirm by doing IHC, that is CME antibody we have used. IHC is positive, and those small capillary vessels are all endothelial marker positive, CD31 and 34. Agreed? Okay. Thank you so much.
We extend our sincere thanks to Dr. Shantwir sir for his engaging and informative presentation.
I request Dr. Aparna Sajjan ma'am to present Dr. Shantwir sir with a certificate and a bouquet.
Already I have got one.
Thank you, sir. Thank you, ma'am.
We'll now have a lunch break and we'll be back with our next session in half an hour.
Okay, ma'am. Welcome back, everyone. I hope you all had a lip-smacking lunch. To squash our postprandial sleep, I would like to request Dr. Megha Upin ma'am to engage us in a slide seminar on CNS squash cytology.
Good afternoon. So we are going to have this slide seminar on squash cytology. I hope everybody's awake, at least the people who are inside. What I'm going to do is I'm going to give you a brief overview of the purpose of the squash and how the squash is done. And then I have circulated some cases through the PowerPoint. We'll try to discuss them. So basically, I hope you understand the concept of squash cytology. Everybody knows that giving an intraoperative consultation is a very important job of pathologists. So we keep reporting frozen sections for many systemic reasons, like it is a malignancy, to know what is the primary lesion, sometimes margins, lymph node metastasis. Those are the various reasons for which we do frozen section analysis. The counterpart of intraoperative consultation in CNS lesion pathology is called as squash cytology. So the basically it is to know the nature of the lesion. Of course, the most important thing in brain is if you understand that there are a lot of tumors which are which, as I said in first lecture, which remain localized to the brain. And it is very difficult for the neurosurgeon to find a boundary between the tumor and the normal tissue. So it's not like a systemic tumor which forms forms a mass or a growth, and a surgeon gets a definite plane of dissection. That is not very easy in brain tumors, And the main purpose of squash cytology for the neurosurgeon is to know that he has reached the tumor. That is a very important information that a pathologist gives the neurosurgeon, that what he is resecting is actually a tumor. And then through the cases, we will see the other aspects of why squash cytology is so important. So in the morning, through the CNS tumor classification that I have covered, I have given an overview that the number of techniques we need to do on the tissue. So first we do histology, the processing, then we do immunohistochemistry. There are a lot of molecular techniques. And the brain tumor sample is not as big as a tumor sample that you will get in the rest of the body. So it is our first primary aim to conserve the tissue and to use the tissue to its maximum utility. We don't want to waste the tissue for any reason, because we need to reach the final step of molecular diagnosis before you give a definite diagnosis. And that is why we have to use the tissue for squash cytology very, very judiciously. We have to pick up the right kind of tissue and spread it on smear. And that is why it is very important to identify, like whenever you get a brain tumor, you always get it in multiple fragments. And then you have to decide by gross inspection which of that fragment you are going to pick up and spread. So here in that small cap, you can see fragments, and you can see the lower down fragments look sort of a normal brain. So normal brain majorly on gross inspection has two colors, right? It's a white and a gray. So anything which looks apart from this, something which is necrotic or hemorrhagic, more brownish, is where you are going to identify the pathology. So don't randomly spread the squash smears without looking at the gross morphology of those fragments. And that gross morphology will give you a clue as to which fragment you are going to pick up. So you are going to pick up a very small bit of that an abnormal looking area. You just spread the smear on a slide. You quickly fix it in alcohol, and we usually do a rapid HND stain. Some years back, we also used to do toluidine blue stain, but rapid HND is very fast, and the slide just gets over in 2 minutes. And we don't really use any technical assistance for doing the squash. All the squash preparations are done by our own residents. So there is no technician who is paid for doing the squash smear. That is another advantage of doing a squash over a frozen section. So by looking at the smear, you can understand, looking at the quality of the smear. Usually the gliomas spread very well on the smear. It's easy to stain the smears, but the tissues which are tough to spread are the tissues which are rich in mesenchyme. So a meningioma or a schwannoma or a granuloma or a metastasis may not spread as well as a glioma or perhaps a necrotic material spreads. So why do we use squash cytology and why don't we do frozen section? Of course, that is a preference of the institute. There are certain institutes which prefer to do frozen section analysis, whereas certain will prefer to do smear analysis. We prefer to do smears because we use very little material. The material which we use for frozen section, what happens is creates lot of artifacts, and we will not be able to use it optimally for immunohistochemistry and other techniques. So it's like kind of waste of a material. So you use a little material and spread it in a smear. So the preservation of cellular details are very good on a smear. It's like reporting any other FNSE or a cytology slide. You can look at the nucleus and the cytoplasm very clearly. You can see the background that gives more information. But in any case where the tissue is not spreading properly, it's tough to spread, then we convert the squash cytology to frozen section. So there are a number of times where we have done frozen section also. How do we report? See, the whole thing of accepting the sample, spreading the smear, or doing the frozen section and release of reports happens within a matter of 5 to 7 minutes, because the surgeon is waiting on the other end to know what he needs to do the next. So there are no typed reports that are released. Majority of the time, the report is conveyed through a telephonic call, or if the resident is available, they are told directly. So there is 3 formatting of reporting. One is you give a definite diagnosis. That means you know whether it's a tumor or an infection. Sometimes another important thing is you are not required to give an exact grading of the tumor on squash. That is never a purpose of squash. So you cannot call a tumor as CNS WHO grade 2, 3, 4 or anything else on squash. That's not the purpose. At the most, what we can do is you can hint at the grade of the tumor by looking at the cellularity or the atypia, which can be obvious on the smear, and call it low grade or high grade. Sometimes because of lack of clinical information or because the tissue is hard or tissue is bony, a bone you cannot spread or you cannot freeze. In such cases, you can defer to do squash or frozen section analysis, but that is only a rarity. But you have to remember that it's not mandatory to give an exact report in squash analysis. Now, anything that we report, whether it's a biopsy or a resection, always has to be associated with minimal clinical information. Usually in CNS squash cytology, or for that matter histopathology reporting, the basic information that we need to know is what is the age and the location of the tumor. More or less, if you know these 2 things, then the algorithm of CNS lesion diagnosis is almost like a mathematics, because these are set types of tumors which occur in given locations at given age. So suppose if you are told that this is a 5-year-old male and the lesion is in the 4th ventricle, then you have 2 or 3 differential diagnoses. You know that it's either going to be a pilocytic astrocytoma, medulloblastoma, or an ependymoma. So the differentials have already run through your mind before you actually see the smears. And that is why the analysis of the age group and the location of these tumors is very important. And that is in front of you. And the same holds true for the spinal cord tumors also. So the spinal cord compartment is divided into extradural and intradural compartment. The intradural is again divided into intramedullary and extramedullary. So intramedullary means you are going to look at a glial tumor, mostly ependymoma or an astrocytoma. If it's an extradural, then you will have a meningioma, schwannoma, neurofibroma, plasmacytoma, metastasis. Intradurally, again, you can have similar kind of meningeal based lesions. So that analysis or those differentials also, it's very important to run in your mind before you see the smear. So the actual interpretation of the smear is you have to evaluate the slide with respect to its background as well as the cells. The normal brain is little difficult to spread, but it will have very thin capillary sized vessels, and you can see those normal neurons as well as glia in the background. This is the normal cerebellum. You are seeing the granular layer. You can see a Purkinje cell also. Blood vessel gives a lot of information. If it's normal brain, the capillaries are very thin walled, versus that in gliomas, as the grade of the glioma increases, the vascular architecture also becomes very complex. So we heard of microvascular proliferation in glioblastoma. So if you get very complex anastomosing capillary channels, then you know you are looking at a high-grade glioma. Usually in gliomas, metastasis, in nerve sheath tumors, even in meningiomas, the cells are very cohesively arranged. Whereas if you are looking at a hemopoietic malignancy like a lymphoma, or in neuroendocrine tumors like pituitary adenoma, then the cells are separate. In fact, that is a standard teaching about hemopoietic neoplasms, that the cells do not form any pattern. They are always discrete and they just stick to each other without forming any pattern. And that's a clue to a hemopoietic malignancy. We can have certain definite pattern analysis, like in the form of rosettes, which is a very important hallmark of ependymomas. Papilla, we can see in papillary type of metastasis. If there is an EGB, which are very easily seen, by the way, the EGBs and the rosenthal fibers on the smears will automatically give you a clue that you are looking at a pilocytic astrocytoma. When it comes to gliomas, again, as I was saying, you don't have to give an exact grading. You call it low grade or high grade. On squash smear, in that much of time, you don't really have time to go and analyze if atypical mitosis or not there or not. So overall cellularity of the smear and little bit of pleomorphism will give you an idea as to whether you are looking at a low grade or a high grade tumor. Sometimes in glioblastomas, you get only necrosis on the smears. In such cases, you should not hurry up to call it as glioblastoma. Necrosis can be seen in metastasis, it can be seen in glioblastomas, it can be part of tuberculosis, of other infections. And the neurosurgeon has written on the form that the imaging is like glioblastoma. Do not fall prey to that information and call it glioblastoma only if you are looking at necrosis. Say it is only necrotic material and ask for more material. So there are many a times we tell the neurosurgeon that whatever has been sent is not sufficient. Please send us more material, and they very well do. Background is important as well. You can see the myxoid background or a chondromyxoid stroma in chordomas. Lymphoglandular bodies is a very easy assessment in lymphomas. Nuclear features, if they are round, they are more seen in neuroendocrine tumors, neurocytomas, lymphomas, whereas ependymomas, gliomas, meningiomas, nerve sheath tumor have elongated or spindle cells. Stipple chromatin can also be easily identified in cases of pituitary adenomas or paragangliomas. Pseudo-inclusions is an important squash feature for meningiomas. Elongated cytoplasmic processes again in pilocytic astrocytoma, schwannoma, whereas if it is clearing, it's more chordoma or a clear cell metastasis or a germ cell tumor. Infections also need to be differentiated. There are many a times elderly patients come with either a single or multiple mass lesions in the brain, and somehow anything which occurs in the brain is always thought to be high grade glioma, and all these material is sent with that preliminary clinical diagnosis, and in many times they turn out to be tuberculomas or fungal granulomas or even brain abscesses. So in such cases also you have to look at the infiltrate, whether it is neutrophilic in cases of brain abscess. Granulomas, of course, we all identify because we are tuned to looking at a lot of tuberculosis on FNSE. So this was only the background of how squash cytology runs, what are the measures that you need to take, how you communicate the report, and what is the general analysis of the smears. So with that, I'm sure that PPT was shared with the students, and this was the first case that I had sent. And let me tell you, no matter how much we communicate with the neurosurgeons, as pathologists, we do not get more information than this. So whatever I have given you as a history is the actual history that I received while I was reporting the squash. But you still have to utilize the information that is given to you to its best. So in the morning, you have already heard about CNS tumors. And if you recapitulate that information and apply it to this case, reporting this case will not be very difficult. So this was a 12-year-old boy, and he has a lesion in the thalamus, which was called as query glioma. So in the morning, we have spoken about the midline tumors. Thalamus is a midline location and pediatric age group. So we are perhaps looking at a midline glioma. Now, other than that, we do not get really a very big list of infective or other non-neoplastic lesions in the thalamus. So that is what runs in your mind while you are reading the history and while the smear is getting ready. So this was the first squash which was sent for this lesion. So what does this show? I mean, I would like some answers from you people. I have given the low magnification. This is the entire smear on the low magnification. You can see it has spread considerably well. You can see the background and the details. So what is this? Rosenthal fibers. Huh? Rosenthal fibers have a very classic, very dark pink architecture, na? And they're very stout. They are like rod-like, very dark pink structured. These are very thin filamentous structures, no? And in the background also, you are able to see some normal cells now, which are very big. They have considerable amount of cytoplasm. So what are you looking at? And then if you look at the capillaries also, see, you can see a capillary, very thin wall. Lot of fibrils in the background. In fact, you know, this is the capillaries, and you can see the normal cells. Na? These are all normal oligodendroglial or neurons, and the big ones are the neurons, the ones which. So this was actually a normal brain. So this is poor cellular. It is showing the normal architecture of the brain in the form of the thin vessels, the neuropil, the normal glial cells, as well as the neurons. You're not seeing any increased cellularity. The fibrillary network will become sparse from normal brain to glioma. Now, this is a very important information which is given to the neurosurgeon, that what we are looking at is a normal brain. Why is it important? Because if you remember the anatomy, the cut surface of the brain, then thalamus is a very midline deep structure. Huh? So this is an inner nucleus in the white matter. The normal arrangement of the brain is gray matter and white matter. And within the white matter, we have nuclei in the form of basal ganglia and thalamus. So now if you recollect that information, then you can imagine how much of cortex and white matter that the neurosurgeon has to pass through to reach thalamus. He doesn't have any clue because he's working on a microscope. For him, there are only two colors. Something looks white, something looks gray. The tumor also doesn't look very different. So he is removing the tissue and sending it to you to know whether he has reached the tumor or not. So through the first squash, we have told him, no, it's only normal brain. You still need to dig down and reach the tumor to give us a material which can be used for diagnosis. So that was normal brain. And then after that, we received more tissue. Now you can very well compare the last smear to this smear. Look at the cellularity. See that the fibrillary network has more opened up. The cells are more, the pleomorphism is there. We can call it as glioma, possibly high grade. So long as you even call it as a glioma, it's more than enough for the neurosurgeon. You don't have to give the grade, because they know that it's perhaps a midline CNS grade 4 glioma, for which you are going to anyway do the routine histopathology, and that is what it was. So it was a H3K27M mutant CNS WHO grade 4 tumor on histopathology. So the purpose you have understood through first case: assist the neurosurgeon in the surgery. Tell him that he has reached the tumor. He will remove the tumor and give you the tumor in your hand for you to give a definite diagnosis. You are not required to give the grade or a definite diagnosis on squash. So that was the first case. Then a 25-year-old adult male, a mass in the lateral ventricle. So when a lateral ventricle or a ventricular tumor come across to your mind, what would you think of? Very good. Neurocytoma, ependymoma, subependymal giant cell astrocytomas, choroid plexus tumors. You have your list ready. You know that it's going to be one of these 4 or 5 entities. So now you spread the lesion. So that's the spreading. The cells are very cohesively packed, no? Not much neuropil in the background. Then you go a little higher and you can see they look very monomorphic, na? Very monomorphic. Every cell looks like the other cells. There is no pleomorphism. You are not able to appreciate any atypia. You go little higher. Again, the same monomorphism, no atypia, no necrosis, no neuropil on the background. What are these structures? What are these structures here? Very good. What are these types of rosettes? Pseudo rosettes or neurocytic. Excellent. So these are neurocytic rosettes, monomorphic cells. So the diagnosis is excellent. So this was a central neurocytoma. Okay. So then again, next case, 35-year-old conus cauda. Conus cauda, I don't think there are many differentials. Not great number of pathologies occur there. What is the commonest tumor that occurs in conus cauda? Very good. Myxopapillary ependymomas, nerve sheath tumors, and paragangliomas. That's it. That is all that happens in the conus cauda region. So you have your differentials in mind. Again, very cohesively packed structures. You can see a sort of papillary pattern here. Na? You can see those vessels running across and the cells arranged towards the periphery. If you use a toluidine blue stain, on the HND stain, actually seeing the matrix is not very easy because there is no differentiation. There are only two colors, pink and blue. But on toluidine blue, you can see that myxoid matrix very well. You can appreciate the center of the papilla, the myxoid matrix, and the rosette-like structure in this tumor. So what was this? Myxopapillary ependymoma. Very good. So toluidine, the benefit of toluidine blue, it's a metachromatic stain. So it brings out the matrix material very well. So for chordomas, for myxopapillary ependymomas, sometimes for adenoid cystic carcinomas, metastasis, you can use toluidine blue. Another benefit of toluidine blue is it picks up mast cells. So can you name one tumor where you will see mast cells on score smear? In fact, that's a very important clue. If you see, mast cells are nothing but tissue basophils. So you see those cells as having very dark blue granules in the cytoplasm on a smear. So posterior fossa or cerebellar hemangioblastomas. Now hemangioblastomas is basically a very vascular tumor. It doesn't spread. No, and even if you spread, once you put it in the alcohol, all the spread material gets washed off. So it's very tough to spread an hemangioblastoma. In such cases, if you just see the background, you can pick up mast cells, which are very well picked up with a toluidine blue stain, and that helps in giving a diagnosis of hemangioblastoma. So that is the utility of doing a toluidine blue instead of an HND. It's very easy. You just take a toluidine blue solution, dip the slide, your stain and the slide is ready within 2 minutes. So it's very easy to do the squash preparation. Okay, this is the case which I saw just a week back. These are not very common tumors that you get across. This was a 41-year-old female and it was sent to us as a cellular mass. This patient presented with hemianopia, visual loss, and they thought that it's a pituitary adenoma because the commonest tumor in the cellular region is pituitary adenoma. So this is nothing like pituitary adenoma because in the initial slides I have shown you that pituitary adenoma is a very matrix poor lesion and the cells are very discohesive. You may not see a pattern, papillary of course you can see, but majority of the cells are discohesive. Whereas at this magnification, you are able to see very cohesive structures. The cells are sticking to each other. And if you go to higher magnification, this is how the cells look like. So can someone describe these cells more? There's a lot of pink color there, no? What is that? Oncocytic. Excellent. So that's a oncocytic or a granular cytoplasm. Na? Lot of granular pinkish looking cytoplasm. The cells are very, the nucleus is very small. There is no nucleoli, no atypia, no stippled chromatin. Huh? So what does this look like? Any rare tumor that you can identify? Pituitrycytoma are called as gliomas of the posterior pituitary. So in pituitrycytoma, you get fibrillary network in the background. Here, there is no background. It's all comprised of cells. So this was actually a granular cell tumor of adenohypophysis. Huh? So those are big granular cells and granular cell tumors will have lot of cytoplasm and that cytoplasm is picked up by the pinkish granules on the past stain. We did TTF1, it was very brilliantly positive. So this was a rare example of a granular cell tumor of adenohypophysis. Okay. This is again a very recent squash that I have seen. So as I said, elderly males, multiple SOLs in the brain, and their diagnosis was either, all these are the differential diagnosis of multiple ring enhancing lesions in the brain. It's either a multifocal GBM or at this age you can have multiple metastatic lesions or even tuberculomas can be multiple. And that's how the smear looked like. Again, a very cellular smear. That's the higher magnification. What are you able to see? Very good. So there are histiocytes, no? And what is happening in the histiocytes? Okay, little more. Emperipolysis. Okay, and what about the rest? There are macrophages. You are seeing cells within the macrophages. It is either phagocytosis or emperipolysis. I am not sure. But other than that, what are you able to see? What are the rest of the cells? Large cells, na? And they are not forming any pattern. The cells are only touching each other, and there is lot of nucleus to those cells. The cytoplasm is barely visible. Yes, and you can see these structures in the background also. Can you see these structures? So those are cytoplasmic fragments which are called as lymphoglandular bodies. So what this macrophage is doing is it is phagocytosing. So if you remember those starry sky appearance of Burkitt's or a high-grade lymphoma, that is what it is. Huh? So that those are actually the stars, no? So those are macrophages which are engulfing the other cells. So, and those are large lymphoid cells. So this is neither glioblastoma nor metastasis nor tuberculoma. It's actually a lymphoma. And if you go back and look at those fragments, no, you can see that one peculiarity of the CNS lymphomas is they have a peritheliomatous or a perivascular pattern of arrangement. So if you see there is a vessel which is running in the center and the cells are almost hugging that vessel. So that pattern also is very important in lymphomas. The cells are very closely packed and they're always around the vessel. Peritheliomatous or an angiocentric pattern of arrangement is a very important clue to the diagnosis of lymphoma. So this was primary CNS lymphoma. This again is a very important diagnosis on squash cytology. For lymphoma, the choice of treatment is chemotherapy, na? Resection is not the choice of treatment. And lymphomas are very matrix poor tumors, so they tend to bleed very violently. So once you call something as a lymphoma, the neurosurgeon stops there. Whether it's a single lesion or a multiple lesion, the choice of treatment for lymphoma is chemotherapy. So you have already given them diagnosis on squash. At the most, you need little more tissue because you have to type the lymphoma and give the diagnosis, and that's where the surgeon stops. The surgeon is not aiming to do a maximal safe resection in these tumors, and that is why this diagnosis is very important. You should not mistake a diagnosis of lymphoma for anything else in squash diagnosis. The same holds true for germinomas also. So this tumor happened to be a diffuse large B-cell lymphoma on immunohistochemistry. The second such example of a similar scenario is germ cell tumors. Germ cell tumors in the brain occur most commonly in the pineal region, posterior third ventricular, in the suprasellar cellar region, and periventricular foci. The treatment of germ cell tumor also is chemotherapy. The surgeon should not do resection because instead of benefit, the patient lands up with neurologic deficits because of the surgery. So the diagnosis of germ cell tumor on intraoperative consultation also has to be given with complete accuracy. There are very 2 or 3 foci only where germ cell tumors should occur. You should be aware of those location. Young patient, any tumor which has cystic and solid appearance, calcified, don't forget to think about germ cell tumors. Germ cell tumors and lymphomas, you have to be 100% accurate. You cannot make mistakes. So this is again 5-year-old male cerebellum. We have seen one such case in the morning also. So that is again a very cellular tumor, blue round cells. They are forming some pattern also. You can identify, yes. So you can identify the neurocytic or the Homer-Wright type of rosettes on the squash. Again, monomorphic cells, more nucleus, less cytoplasm, rosettes. So this is a medulloblastoma. 46-year-old female, now with some spine case. This was an intradural extramedullary mass in the spine. Now here you can see that it is tough to spread the squash. The cells are not spreading very well. They are attaching themselves to create very tightly cohesive clusters, and looking at those clusters is very difficult actually. It looks like you are just looking at some masses of blue. It's a very uneasy feeling when you report squashes like this. So in such cases, avoid those areas which look very clumpy. Go towards the periphery of the smear where the cells are little bit spreading and look at those areas. Ignore the badly spread ones. So what are you able to see here? Yes, so there is calcification and you can see very nice whorls, no? Yeah, so this is a transitional meningioma. And as I said, sometimes you may not see the whorls so classically. You may not even find calcification. In such cases, look at the nuclei. Look at the nuclei very carefully, and at least one of them you will find this intranuclear inclusion. Very important clue to the diagnosis of meningioma. Routinely, you don't really get squash cytology for meningioma. They are dural base masses. The imaging is very characteristic. The neurosurgical feel also is very characteristic. But there are odd locations for meningiomas. Meningiomas can be sometimes intraventricular, sometimes they can be in CP angle. In such cases, the neurosurgeon likes to confirm that it is meningioma. So that's a cytologic clue to meningioma. This is something which I again saw just 4 or 5 days back, and this was very interesting. This sample was brought by the third year neurosurgery resident to our lab. And he came saying this is a 60-year-old male. This patient has been treated for carcinoma buccal mucosa in 2022, after which he was treated for carcinoma lung in 2023. And now there is a mass in cellular suprasellar region. Now, if you recollect, most likely, you are going to see a metastasis. There are no marks for guessing that this is going to turn out to be metastasis. But is cellular suprasellar region a very common site for metastasis? No. The common site for metastasis in brain are the watershed zones where there are end arteries, which is in the basal ganglia region, or little, at the junction of the cortex and the white matter. That is where metastasis is most common. Cellular metastasis are extraordinarily uncommon. But then this was in the cellular suprasellar region. So we tried to spread. It was not spreading. The cells were not spreading. The material was getting washed off. A little bit of material remained behind. And I was not able to understand. Now, with a history of a carcinoma in the buccal mucosa and a history of carcinoma lung, I thought that this would either be a squamous cell carcinoma or it would be an adenocarcinoma. And it's very rare for one patient to have two different types of. It can happen because in tertiary care center, we see double malignancies, sometimes triple malignancies. It's not uncommon for us. But then this morphology was neither looking like a squamous cell carcinoma nor was looking like an adenocarcinoma. So I was a little confused. I was not able to understand. And then we tried asking to the neurosurgery resident, what was it? What was it report? I don't know, madam. That was all that he told us, that he has no information of the previous diagnosis of these tumors, and that is how unknowledgeable, or what do you say, there is so much of lack of information that the neurosurgeons give us. But anyway, so we thought that we are not able to justify the squash diagnosis. I'm not able to go beyond the smear, so I thought we will freeze the tissue. So we froze a little bit of tissue, cut a frozen section, did an HND, and that's how this HND looked like. So what is this? Shantveer has just taken an entire slide seminar and a lecture for you. Yes. So there are tubular pattern. There is mucin within those tubules. So this was an adenoid cystic carcinoma. So this was actually an adenoid cystic carcinoma of the buccal mucosa of the hard palate. That adenoid cystic carcinoma metastasized to lung the next year, and now the same tumor is metastasizing to the sella. So it turned out to be a metastatic adenoid cystic carcinoma. If that resident had given us information, it was easy to report on the squash. It was not easy. So we did frozen, but we gave him a diagnosis. And then after 2 days, he sent me a report of that buccal mucosa, and it was reported as hard palate adenoid cystic. So these are very aggressive malignancies. They are prone for recurrence. They are prone for metastasis. And sometimes the metastatic site can also be unusual. So metastasis, again, they don't do much. If it is a solitary metastasis, they try to resect as much as they can. If it is multiple, there's nothing much that the neurosurgeon can do. He only gives you the tissue for diagnosis and he ends it there. Okay. Now, one more case, 45-year-old male. Again, he was immunocompetent. You can see the MRI scan. It's a beautiful ring enhancing lesion. Again, the differentials for ring enhancing lesion is tuberculosis, metastasis, toxoplasmosis. All those are the differentials. What are you able to see? Giant cells, very good. Foreign body type of giant cells, no, not Langerhans giant cells. Anything about the infiltrate with those giant cells? What are those cells you are able to see? Very good. So does that give you any clue? Eosinophils. No, this is an elderly patient. What was the age of this patient? 45, middle age. Langerhans cell histiocytosis usually is a pediatric diagnosis. I mean, we have seen adult cases, but then parasite, very good. So everybody associates eosinophils and granulomas with parasites. We all tend to forget that eosinophil is a very important infiltrate in fungal infections. Do not forget granulomas plus eosinophils is majority of the times a fungal infection. Parasites usually do not show so much of granulomatous response. There can be eosinophilic response, but not a pure granulomatous response to neurocysticercosis or hydrated. So please remember fungal infections, and we did more smears, and you really can see those fungal hyphae running through the cells. So otherwise, you can do a frozen section because the granulomas are spread, hard to spread, and you can see that fibrotic. One thing about aspergillus granulomas is aspergillus granulomas are more rich in foreign body. They are not true epithelioid cell granulomas, and they will be very fibrotic. So that's a fungal infection. Again, very important information for neurosurgeon. The neurosurgeons are not aware of how the samples are processed. For infections of any kind, there is a pathology, there is also a microbiology. So you need to prove the species of the fungi, which can only be done on microbiology. So the information that you have given to the surgeon is, one thing is it is infection, second thing it is fungal infection, third thing he is supposed to send some material for culture. So the whole material cannot be put up in formalin. He has to send it some in fungal culture bottles. Okay. So that's a SM stain which was proven to be aspergillus. Zygomycosis is very easy to be picked up on squash or frozen. The response is less and the hyphal structures are clearer. This is again a very recent squash that we saw, and it, as usual, it came only with this information that it's a spinal extradural mass in a 63 female. 63 female extradural mass can be meningioma, it can be nerve sheath tumor, it can be metastasis, but it was this. So what is this? Again, very monomorphic looking cells, no? Now, no neuropil in the background, not much background for that matter. So what is this? See here in this smear, you can identify. If you look at individual cells, can you see this cell? Eccentric nucleus, abundant cytoplasm. This was a plasmacytoma, plasma cell neoplasm, after which this patient was further investigated, and this was found to be one of the lesions of a multiple myeloma. 30-year-old female, lesion in the posterior third ventricular region. This is posterior third ventricular region is the region of the pineal gland. In pineal gland, you can get primary pineal parenchymal tumors, you can get germinomas, you can get gliomas, anything. Okay. So that's how the smear looked like. Very cellular smear. Again, you can see the vessels running through the cells, no neuropil in the background, very monomorphic looking cells. You can see some neurocytic rosettes here. Okay. So this is, we just end up calling it as primary pineal parenchymal tumors. Primary parenchymal tumors can be grade 1 to grade 4. We are not supposed to do that analysis on squash cytology. What is important for the surgeon to tell is one thing, it's a very difficult area to approach. So there are 2 or 3 information that the surgeon got through this through this report is he has reached the tumor. He is looking at a primary pineal parenchymal tumor. It's not a germinoma. So he can resect the tumor completely. Okay. So those are 2 very valid information that was conveyed to neurosurgeon through this report. I think this is the last case. This is a 26-year-old female who presented with seizures, and there is a definite mass lesion in the brain, which was thought to be glioma. But what we what we saw on the smear was there were a lot of histiocytes. Now, histiocytes, Dr. Nandish has shown you a very beautiful case of demyelination. Histiocyte is a very important part of demyelination or infection, or for that matter, infarct. In infarct, you see the jitter cells, no? They are nothing but histiocytes. So on squash, we cannot differentiate between these 3. You call it only histiocytic lesion, not a glioma. Sometimes you even have to give a negative report. You have to tell the neurosurgeon that this is not this. They very strongly think that it is a glioma. You have to stand on your foot and you tell him that no, this is not a tumor. You have to tell them, convince them. So a negative reporting also is very important in squash cytology. So this later on turned out to be a demyelinating pseudotumor. A pediatric patient, you can see a bony lesion there. There is a lytic lesion in the bone, and this was very strongly thought to be osteomyelitis. So the surgeon thought of curating out, give it for culture as well as have a pathology diagnosis, and that's how the smear looked like. So what is this? Yes, so we were just talking about eosinophils and LCH, and you can see those grooves also on a frozen or a squash. So this turned out to be Langerhans cell histiocytosis. So with that, it's a very rapid, cost-effective technique. There is a lot of information that you can give on squash cytology. You should know how to report them, what is a valid information, how to convey the information, and how the neurosurgeon should act on that information. Thank you.
Thank you, ma'am. We extend our sincere gratitude for the informative and captivating presentation.
I request Dr. Shri Mulimani ma'am to present Dr. Megha ma'am with a certificate and a bouquet. On. Thank you, ma'am.
Usually we do squash in CNS cytology, na, ma'am?
Yes, yes.
So you told about frozen section. So I
Yes.
just want your input for frozen section, like whether when to do and like whatever frozen section we are doing for routine other specimens, same temperature you have to maintain because they say freezing artifacts comes in the CNS tissue,
Huh.
so we should not do frozen.
Yeah, so for gliomas and all, we don't do frozen section. Actually, for all CNS intraoperative consultation, we routinely do smears. So in instances where there is the most common indication why we shift to frozen is the smears are not spreading. I think that's the only indication. Like in hard tissues, meningiomas, schwannomas, sometimes in plasmacytomas or granulomas, wherever it is not spreading, I take it to cryostat. It is the same. If you do frozen in gliomas, that danger of frozen artifacts is there. That doesn't happen in all these mesenchymal tumors. So that adenoid cystic also I showed you. So granular cell tumor. So there is no danger of any artifacts. And the same thing which we do for other frozen sections, we do it like that only. I give a very little tissue. As far as possible, I try to avoid frozen in brain lesions because the tissue is very less and we have so much to do on the tissue. So I don't freeze the tissue. I do only smears. I have seen that even in granulomas, even if it does not spread and the material gets washed off, no, you can find 1 or 2 clusters of epithelioid cells, enough for you to give the diagnosis. So as a preference, we don't prefer to do frozen section. There are institutes where frozen sections only are done, but it depends on their expertise and their preferences. We cannot really comment on that, but the frozen section situations are same as that you do in the rest. Thank you. Thank you.
Okay, very good afternoon. We'll complete the second part of this session. Just to revise, we at least at the end of this 2 sessions, this particular slide should be in your mind, because if this is there in your mind, suppose you are asked, or if you are dealing with any of the differential, of course, this is one of the topic to be asked also in theory exam. You can elaborate on these things, is it not? These examples, if you have. So this should be there. We did cover 2 aspects of it, 2 important causes, developmental and immunological. Of course, in that immunological is more relevant and more important. Okay. So I will just run through the slides fast so that it will give a recap of what we discussed. Of course, you cannot. So this slide, there is no separate slide session as such, because with the slides we'll learn. That was what I thought. So we stopped at these examples of immunological causes, right? Okay. Let's start with this new group. So 2 examples, major causes, and let's come with this. This patient had a lesion in the middle cranial fossa, presented with some localizing signs and seizure indicating that some amount of cortical irritation or cortical infiltration is there. And this was contrast enhancing with the dural sign, of course, extraaxial. This dural sign is an indication on radiology that it's a meningioma. Kind of it's extending along the dura. Dural attachment is there. And because of the infiltration of the brain, there is peritumoral edema. Now you can see very well. It's circumscribed. This is the dura, you can observe. And this is the circumscription of it. There was other aspect actually. I think this is the image which I had shared. So this is a parenchyma. So it is showing infiltration. If it was meningioma, it would have straight away gone into grade 2 because brain invasion is there. That is one of the criteria for grade 2. But you can definitely see that there is some activity here, cellular activity, perivascular lymphocytes, and here also within the lesion, you can see here. Now you can appreciate that it doesn't fit with meningioma, right? It has got so many heterogeneous components here, heterogeneous cells. That's most important. The most important which defines in general the challenge in recognizing or which confuses a tumor is the cells which participate. The more homogeneous it is, the more confusion towards a tumor. The more heterogeneous it is, the more towards reactive. That's what you do in a FNAC or aspirate of a lymph node. Homogeneous is more dangerous, monotonous. Mixture of cells, polymorphous population is more safer. But here, what happens is there are many tumors which show an inflammatory activity. Then the problem starts. Okay, so that's what Sir was also mentioning about the immunotherapy of it. So tumor has got a relationship with the immune response. Now, if you see this particular lesion, it's got components of, and these all look like histiocytes, right? The cells which are having aberrant cytoplasm, they do look like histiocytes. Along with that are these lymphoplasmacytic cells. Anything more you can appreciate in this? I've already given you the clue, so it stimulates the mind. Because this is the last lecture, you'll be tired with so many information. Phagocytosis, yes. Only difference between the phagocytosis and this is that there is some halo around this, right? There is some halo around. Maybe you can appreciate in the next field. So again, lymphocytes, histiocytes, plasma, some fibrosis you can appreciate. Now again, can you appreciate a halo around? This presence of halo in a phagocyte cell will indicate a specific phenomenon, emperipolysis, yes. So that's most important. One should be fortunate to pick up emperipolysis. It's not that easy to see. Here it's nice, we'll catch, but when we are seeing, it takes time in the sensation. It's not that classical across all the lesions. One peculiar thing about any lesions which mimic tumor or any other condition is that each of them will be mimic. If you consider a particular category of lesions, like whatever examples I'm giving, among that category itself, there will be a lot of variation. That is important. So all of you appreciate about this one over here. Okay. So this is classical. So if you want to summarize, another case came. This was this one, another recent one. Same similar picture. Only thing is the infiltrates are more deeper, more denser, and more foamy histiocytes. Here cellular activity is more. This is more likely to be get confused with an infiltrating to a lesion. Okay, so you can see foamy histiocytes. You have some kind of Crouton type of giant cells, inflammation, variety of cells. And now comes the most important. You can appreciate here. You can appreciate another one over here. And I think this is much more clearer, much more straightforward about the emperipolysis. Now, all these things I'm showing typical morphology, and we need to get used to this morphology because morphology is the main driving force. If the initial steps, our initial steps is not in the right direction, whatever additional sophisticated markers we do, we'll be more strongly going in that wrong direction because it confuses. Well, that's the reason why get used to the morphological differentials, then use IHC and other techniques only to equip yourself, complement yourself. Otherwise, it is never a replacement for any of those. If you replace, then you don't know where you're going, which direction you're going. Okay, it's like running in the dark. So this is most important. Of course, many times, many of these conditions, you don't need IHC to confirm that it is a pseudoneoplasm. It may be required to rule out the other differentials, especially neoplasm. To rule out that, you may have to do, not to confirm a pseudoneoplasm. Again, you can see here. I hope I'm clear in the concept. It's just a word of caution, that's all. So basically, to summarize, this is what we saw, right? A lesion abutting the dura with the diffuse lymphoplasmatic infiltrate. And of course, it was the histiocyte which was dominating. Then since histiocytes are there, we have to rule out granulomas, no necrosis, of course. Each of these are points to rule out the close differentials. The one which was very strongly indicating was the emperipolysis. Of course, you can do IHCs to confirm whether they are truly histiocytes by doing CD68, CD163 like that. S100 is another one which stains very strongly. Of course, since this is an histiocytic disorder, rule out other histiocytic disorders of this family, that is Langerhans cell histiocytosis by doing CD1A and like that. Of course, since anything in relation to brain, we always do GFAP because Glioblastoma or any of the some of the gliomas are there where cells can mimic other conditions, other cells. So that's the reason we do. BRAF V600 is one which can be positive in some of the histiocytic disorders, especially Langerhans cell histiocytosis. That's why we do BRAF. Otherwise, you know, BRAF V600 is same one which is positive in melanomas. Otherwise, in brain it is ganglioglioma, pleomorphic xanthosystem. The other one which are positive for BRAF. So this is a case of Rosette-Hoffmann disease, which is actually very difficult to say. Once you call histiocytic disorder, still it is not popular as a histiocytic neoplasm. It's still an histiocytic disorder because they belong to that family of histiocytosis. In that, you may ask, Langerhans cell histiocytosis is a kind of histiocytic neoplasm, but there is still controversy which fall to that or this side. But still, Langerhans cell histiocytosis can be considered as a histiocytic neoplasm, but this one not, because this is more like an pseudo-inflammatory or pseudo-neoplastic lymphoproliferative disorder. That's what the in general information is. And you know the other name is the sinus histiocytic lymphadenopathy, there where lymph nodes are involved, but really middle cranial fossa, retroperitoneal. These are some of the conditions where you can get this pathology, and this is some of the information. But what you need to remember is this unique histiocyte. That should be the clue. So whenever you're dealing with any histiocytic disorder, so there are these cells which are dominating it. In that, any unique feature, try to pick it up. And these histiocytes are unique compared to other histiocytes by having this some of this, not having this grooved or lobulated, which you will see in Langerhans cell histiocytosis, and the typical emperipolysis that is most important. One problem with this that it's not as common to see emperipolysis. We are lucky enough to get in few cases, but many times we do give a differential or proposal only that it is probably an histiocytic disorder because we wouldn't have appreciated that convincing emperipolysis and fibrosis which accompanies this. And these are supporting markers, not to confirm, but to rule out other mimickers. So this is the differential. It can mimic any of these conditions, not only to the clinician, to ourselves, to pathologists also. Any of these conditions can be mimicked based on which cell is predominating all those things. One thing in this you have to remember, meningioma. You know, one of the grade 1 varieties, morphology varieties is lymphoplasmacytic rich, where the meningothelial cells will be there, but this can dominate it. Some people even are controversial that whether it's truly a variant of meningioma. Now I'll tell you one important thing here. Anything which irritates the meninges is capable of causing meningeal hyperplasia. So if you see any meningeal based lesion, there can be additional meningothelial hyperplastic nodules, which can show whorls, which can show pseudomatosis. So that you should be very careful. So if the biopsy is very small, if some, and you know, there are institutes, no, I should not say institutes, there are some hospitals who divide the tissue. At least we get some of them like that. Some tissue is retained in that native place and the remaining comes here. So if you are lucky, the person or the center which has got the main lesion, it's fine. They will be successful. The other person, other center which gets the non-representative will be in danger. So we are fortunate that even if we, I should not say that, there are situations where we have not got the representative and we have failed in giving. We have given something. That problem, what happens is they want confirmation when the other center has given the proper diagnosis, but still they send that block to us to have an opinion. I don't know why this happens, but many times we have conveyed them to that. If you have to send it to the center only, then you send the block for second opinion, but still I don't know. This is the concept which has gone to the head of no surgeons now here. Okay, to the head of some of the clinicians who still continue that. Okay. This is one very recent case which came. You won't believe this. I could not take images because of the want of time. Just one image I took. This was actually came as cardia equina paraganglioma. That is cardia equina neuroendocrine tumor. That's the new terminology which was basically paraganglioma of the cardia equina. In the WHO, you can see that one. They suspected that another DD was myxopapillary epinema because the cardia equina was expanded. But this was actually xanthogranuloma of that region. Extremely rare. Very few cases reported. One of the referral case. So the patient had to take the side. That time I realized this. You can see the xanthoma cells, two-tone giant cells, some xanthoma cells were there, and lymphocytes. So everything, parenchyma, everything was fine. Only this was the lesion. So I just wanted to share. So now we have come to the previous group what I discussed, Rosette-Hoffmann history. All those are idiopathic, right? You don't know the exact cause. So three major categories done. In that, two are really difficult. That is the immunological or inflammatory response. Another one is the idiopathic cause. Okay. Now we'll go to the next category. Again, this was the case which was shared in the slide seminar, case number 7. This was a middle-aged man who noticed some visual disturbance in cognitive, short-lived with some weakness also. But this is very important because here the lesions were in the white matter. And we already discussed one lesion which was in the white matter, that is demyelinating pathology, that is tumor factor demyelination. And obviously the differential was in demyelinating pathology, but young patient, middle-aged patient with this kind of thing, lymphoma will be the closest differential. Any periventricular involvement and white matter involvement, they consider lymphomatosis or lymphoma because they run along the white matter tracts and gives this diffuse appearance. These are the radiological and clinical differential. They also have some kind of protocols based on if this is fulfilling, they will consider this as the diagnosis. You can see the same left side, it is somewhat similar to the image which I showed you in one of the earlier cases. That is foamy macrophages with some lymphocytes and all those things. So it fits with a demyelinating pathology. Same thing over here, but in addition to demyelinating, adjacent area was showing some activity. If you carefully look at this, there are a few cells which are prominent like this, rod-shaped cells, right? These are microglial cells. So microglial activation is something very important immunologically that has got real concern. Now start some of these cells. Can you appreciate these cells? See, I had showed you the somewhat similar cell in one of the earlier cases. Can you repeat that cell which I told? No, I won't test your memory or attention. Fluid cell, very good, excellent. These are special cells which I got granular multiple small nuclei which doesn't fit with a giant cell, and at the same time which doesn't fit with a mitosis also. Sometimes you get floret mitosis, right? Floral type. And these are the reactive glial cells. Some glial cells are looking almost atypical, is it not? With much larger thing. Now you see again demyelination with histocytes, but this comes peculiar. These are round cells looking like oligo, but the nucleus has become empty. Something filling it up here also. So this is unique. Again, you get these glial cells which are looking different. I hope I am clear about this here. Yeah. Whatever words I'm using are very important. These are clues for the diagnosis. Again, you see, this is a unique oligodendroglial cell, which is round. It has retained its shape, but the nucleus has become very dark, violaceous. Again here, this one inclusion. See, these are all dark ones looking. And exactly, very good. Perfect, very good diagnosis. Exactly. So you can see this is again a bizarre astrocyte. These are the special inclusions, as doctor mentioned, which fills the oligo, targets the oligo, and makes the daughter virions, which fills the nucleus and gives its unique color or inclusion. So I will come to the inclusion name terminology. Again, see, you can appreciate the typical nature of this cell, oligo-like, but the nucleus has become enlarged because the daughter virions are filling it and giving its a unique color. That is the violet or violaceous color. And then comes another type of inclusion like this. Very fine inclusions, which is amphiphilic here. And see the bizarre astrocyte here. This is the astrocyte which becomes. So this is, as Dr. mentioned, is a very special, unique viral infection. You can see these are the microglial cells. So when to suspect microglial infection, viral infection? When you get suppurative inflammation, you suspect pyogenic bacteria. When you get granulomatous inflammation, you suspect TB. When both are there, you suspect fungi, that is suppurative granulomatous. Now, when virus is there, it is a perivascular or diffuse lymphocytic infiltration. Perivascular, nodular or diffuse microglial infiltration. That's what you are seeing. This is a microglial infiltrate with some lymphocytes. An individual microglial cell you can see here, microglial cell. These are an indication that there may be either immunological activation or immunological response or a viral response to a viral infection. Now, this again additional clue for viral infection is the inclusion. You saw Shantri sir was showing with CME, typical owl site. That's the Cowdery type A. Cowdery type B is less specific, more viruses can show, and it's not unique. But this is a unique inclusion which doesn't fit with the Cowdery type A because it's not single and large. Doesn't fit with the Cowdery type B because it is not getting mixed with the chromatin. It is causing some kind of distinct inclusion. So it doesn't fit with those definitions, but a unique inclusion of its own. And this happens because oligodendroglial cell permits the proliferation of this virus and virion. That's why it is causing inclusion and forming daughter virions. Inclusion is nothing but packaging of daughter virions. But the astrocyte doesn't allow it non-permissible infection. That's why it becomes bizarre as a failed proliferation. So here comes the typical inclusion. Here comes the bizarre astrocyte and demyelination. These three findings are histological hallmark of the condition which doctor mentioned, that is progressive multifocal leukoencephalopathy caused by JC virus, which is the same family of virus to which BK virus belongs. And BK virus causes the typical transplant-associated nephropathy, where you get decoy cells. The cells, morphology of the urothelial cells becomes atypical. So see the inclusion here, see the bizarre astrocyte, and see the foamy histiocytes of demyelination. Same bizarre astrocyte in the inclusion. See so many microglial cells which are forming a loose aggregate. So this is the feature what you are seeing, and whatever I described, I put it across. Now suppose in this case, let's go back a bit. If you see too many of these, let's take. See, if you see this one itself, this looks like an hyperchromatic cell, right? With INC ratio. So in definition, we have seen general pathology. Any cell which is having INC ratio, darker nucleus, we suspect an atypical neoplastic cell. So we may confuse this for a, if it is round, we may confuse it for a lymphoma. If it is like this, we may confuse it for a any glial tumor. So that is the problem with this. So that's why this is very important to be aware of it. It can you can confuse this for glial or lymphoid. And these are the findings which I just discussed verbally. I've just put it across to summarize it. Now, once you suspect any tumor, what you do? You do Ka67. In this case, Ka67 will be more confusing to us, because these histiocytes which are having those inclusions will entrap the antibody. Okay, why it entraps, how it entraps, I am not sure about that. I don't know that. And so that is not reliable. So you have to resort to IHC or specific to the virus, that is anti-JC virus antigen. So it's not that easily available. Fortunately, what is easily available is the clone against SV40 virus, that is immune foul virus, which belongs to the same family of polymovirus. One side is BK virus, the other side is JC virus. Middle is FC40, very popular because easy to procure and laboratory grow and do that. So it is confirming that this is a progressive multifocal. That's why you got white matter lesions, leukoencephalopathy, and it's multifocal, which can coalesce to form a large lesion, and it's progressive if you don't recognize. Invariably, this is most of the times associated with immunocompromised state. But the problem with immunocompromised definition is we do only a few evaluation. We do for HIV, and if the patient is not on chemotherapy or not organ transplant, we presume that the patient is immunocompetent. It is not so. So there are so many things which can compromise our immunity. And the immune compromised state may not be always long-standing. It could be a temporary phenomenon also. So malnourishment, alcoholism, so many things comes into the picture. For people on chronic antibiotics, fungal will come. All those are risk factors. So we have to be extremely careful. And many of these patients who are supposed to be immunocompetent, when you diagnose toxo, we have diagnosed JC, PML, all those things, patient has been evaluated and they have found either some kind of disorder in there are situations where there has been isolated CD4 lymphocytopenia, which has been detected. Polyclonal gammopathies have been detected. So these are all comes in the way of natural defense immunity. Okay. So this is what I wanted to say. So immunocompromised, though it is associated with immunocompromised state, sometimes you may not detect that immunocompromised state. Some of them are immunocompetent also. One thing is that if the patient is immunocompetent, you get a very good tissue response. What you saw is microglia, all those things. If the patient is immunocompromised, that will change the old tissue picture itself. For example, even in tuberculosis, you may not get granuloma in immunocompromised state. In the same way, here you will not get proper inflammation at all. So that is what I wanted to convey. And with the, as sir was mentioning, now this is the era of a lot of monoclonal antibody therapy. That will also compromise the immunity, and you get so many cases. So we took an example for biologically infective. In this regard, I want to mention outside the purview of CNS. One has to be careful when you are dealing with a parapharyngeal or pharyngeal or lymph node. In those cases where there is EB virus infection, infectious mononucleosis, all those things, where the lymphocytes can be so atypical looking and reactive, it can be mimic. So this is one of the best example for infective cause that can cause a pseudoneoplastic condition or mimic that. So that is about this group. Next, we'll go to the next case. Again, I think this was the last case provided in that list online, but I continue. So this is lesion who was, patient who was diagnosed already, ependyma was diagnosed. And now the patient came with some symptoms and again some right temporal lesion. What happens? Anything which occupies space will start being symptomatic and patient will be evaluated. And the lesion again appeared in the region of the surgery. Okay. But patient had received radiation earlier. So these are the symptoms which patient came with. Obviously, again, patient was screened on imaging and the lesion was there in the same region where surgery was done. A lesion with edema, mass effect, everything. Obviously, what will you suspect? If something is occupying the same area where surgery was done, recurrence. Recurrence. So recurrence was thought and patient was subjected to surgery again. Very cheap. Absolutely. Yes, we have to see that. Many times it happens post-surgical spindle cell nodule, all those things are something like that only. Okay, even simple keloid, we have seen, no? Simple keloid also can trouble us. Fracture associated changes, healing changes, exactly that. We should be very careful. Therapy can take any form. Now you see, this is the lesion what you received. You're seeing necrosis, but this necrosis is unique. Neither it is fitting with caseous, neither it is fitting with a tumor cell, coagulative necrosis. You see the cell outline, right? It's not fitting with that coagulative necrosis of tumor. Palisading necrosis, definitely not. Among all the necrosis, what is specific for a tumor is a palisading necrosis, where necrosis is there and tumor cells rim that necrosis. Here you can see the difference between this. Nice granular necrosis which merges with some of these cells, right? And some of these cells are looking red and pink with not much. The nucleus as it has become very dull, is it not? Otherwise, nucleus will stand out. Here some inflammation has come, again a rarefied amorphous kind of necrosis, as if something has become a paste-like. No, I should not say cheese-like, something like a semi-solid, granular, amorphous necrosis. At the same time, you're seeing hyalinized blood vessels, sclerosed blood vessels, some calcification over here. Same, it doesn't fit with any known described necrosis, so you can call it as patternless necrosis, amorphous necrosis like that. See here again. MIB1 if you do, negative, absolutely zero. Now another case, this is what we saw, granular amorphous coagulative necrosis. See, this is how it will get. Sometimes you may get cells, but these cells will be smudged, not that dark looking. Okay, and these are the features which you can summarize as like this. Same thing, whatever I described. Granular amorphous, not coagulative typically, but some kind of vague spaces were there. It doesn't fit with any of the other things, some macrophage inflammation. And most important is this vascular changes in the form of hyalinization sclerosis. Sometimes some of the cells in the acute phase can show vacuolation and the cells may enlarge. That will be a problem. And you know, there are certain tumors, here I have not brought that, there are certain tumors which are capable of showing degenerative change. Like for example, schwannoma, you heard about ancient schwannoma. That also is something confusing. Similarly, pilocytic astrocytoma is there, which is capable of showing a lot of degenerative change. Why I'm not speaking about that is we are talking about pseudoneoplasm, not benign tumor mimicking high grade. Okay, so sometimes these cells can show nuclear enlargement as a sign of degeneration. So all these things put together, it is it's just a therapy associated change which is showing all those things. This is very important because many times if you don't do K67, in this case it's straightforward. There will be situations where the glial cells which are there in that area can show degenerative atypia, degenerative enlargement. That's not that easy, but I didn't get that case of, I didn't get that particular case. Old cases were there, I could not retrieve it. But you should be aware. Sorry. Exactly. So that one, in the late phase, that gliosis would have settled and become less cellular and would be gliotic. There will be a phase where glial cells will be more, and some of these glial cells can be degeneratively enlarged. That time it will be a real problem. But just to be aware that therapy-associated changes are one which can be of great problem. It can be a mimicker. And one thing about brain is that radiation necrosis doesn't have a time lag. You can get after a long time also, or the changes would have started and it is slowly it can allow because it will compromise on the other metabolic activity in the surrounding areas. And the dosage of radiation also varies. It depends on the individual. As such, high dose is, any patient is vulnerable for high dose therapy. But if by chance, what is supposed to be not capable of inducing radiation necrosis, there are some individuals who will be vulnerable for it. That can also happen. So this is what you should remember. I was telling you that, see the latency period, it can range across everything. That's the reason why the later the period, radiologists will not be able to suspect that it is radiation necrosis. They'll think that it's a recurrence. Acutely, they may suspect that. And second thing is, these days, what I've discussed is, there are many sophisticated sequences in on radiology, which will help them to actually rule out, especially DTI, diffusion, tensor images, all those sequences. But still, it's a challenge for them. They depend on us for the perfect diagnosis, accurate diagnosis. Hope this is clear. So if there is prior history of radiation, keep that in your mind and go with that. Of course, PET will help you, hypermetabolic or low metabolic one, the calcification, all those things. These are some of the supporting findings to support yourself. See whether you're in the right direction, all those things. In this regard, I want to tell you, then as Megha mentioned, surgeon also in the morning, he said, they won't go for gross total resection, means they won't go for complete resection. So many times they go for a near total or subtotal resection, where some tumor cells will be remaining. Some tumor cells will be remaining still. So after radiation, what happens? Radiation necrosis also will be there. Some residual tumor cells will be there. So they resect that. So based on the presence of few residual tumor cells, don't commit. We should not commit because that will be there. We should talk about activity, active proliferation. That means whether it's a true recurrence or just a presence of residual cells, new tumor cells with radiation necrosis. So that's the reason why I wanted to convey here. Identifying radiation necrosis is very important, and differentiating that from a recurrence is most important. Then. Okay, we'll go to the next case now. Now this is again very interesting. Skull base mass. This actually patient, I always share this because it's a very interesting one. This fascinated the surgeon and the ENT surgeon and the neurosurgeon both. So this what happened, I'll tell you. There was, oh yeah. I hope this is the same case. Yes, this is the same case. I got confused for a moment. This patient actually came with a nasal polyp around 6 months prior to coming to our hospital. What had 6 or 4 months, I think. Nasal polyp, and a patient had a lot of nasal symptoms. So he went to an ENT surgeon. Patient operated that polypectomy. He did that polypectomy. It came as inflammatory polyp, everything. So within 2 months, patient came with sinonasal, inflammation, sinonasal symptoms, plus some kind of intracranial extension and symptoms related to intracranial involvement. So obviously, whenever it comes to the intracranial compartment, ENT surgeon will refer it to a neurosurgeon. And because of the time difference of 2 months, it has regrown. So they obviously will suspect a carcinoma or sarcoma. So with that, but radiological signs are not typical of this sarcoma or anything, but it did look like an high grade. But not to rule out a dural lesion, that is meningothelial, but basically they suspected sarcoma versus a carcinoma. This was the picture. Or is it inflammatory? Because what they were telling that the changes in the stroma were so heterogeneous, so they cannot rule out an inflammatory lesion also. This is the muscle, all those things. And here you can definitely make out that it's inflammation. And now what are you seeing here? Giant cells and dense inflammation. Very good. Any comment on this structure? This structure? Now can you make out here? Neurocystic sarcosis, the thing is that it will not be of this kind. The cell wall will be having tegumentum cellular layer. It's a smaller cyst. This is actually irritated cyst. Wall of the irritated cyst, yes. You can see lamellated, yes, exactly. Lamellated ectocyst. Okay, these are all fragments of that. So whatever polyp was there, probably it was silent. I mean, it was there that time, but the surgical polypectomy has caused the disturbance for it, ruptured, and it caused all the second response. Okay. So this is luckily patient didn't elicit any anaphylactic phenomenon. Otherwise, it would have been difficult. Now you can appreciate. So this may not be difficult for a pathologist, but definitely to be careful about that because you have to show, convince, and the tissue response may be very florid. It could be lymphoid rich, and you may mistake it for a lymphoma if these elements are not that much. Cystic sarcosis can also show this one. We were fortunate that these elements are there. Cystic sarcosis will not show these large elements. Then the lymphoid cells will be very much more. Now you can appreciate, right? This is a typical case, giant cell. But we may not get like that typical case all the time. That's the reason why. So basically what I want to convey here is that, again, a massive tissue response here. And here the diagnosis is very straightforward, not to worry. But this is a ruptured cyst with extensive inflammation, granulomatous response. And this is typical what came over here. So another example, so two examples I'm giving of iatrogenic, okay, both are iatrogenic, but second one is actually biological, but complicated by an iatrogenic phenomenon. So this was actually an operated case for right parasynovium 2 years back. Now, obviously they will suspect recurrence, is it not? Because there was a lesion in the same region. And what you are seeing here again, dense inflammation. This is a classical florid case, you may not get like this, but you started seeing some structure here. Actually, these are all nothing but foreign body elements, right? These are all we call it as hemostatic material there. Okay, gel foam is the name. And this is the florid foreign body response here. Very straightforward here, not to worry much. You can get suture material, all those things. So this can also form a very big mass. Again, the recurrence with high grade transformation, that is what was suspected, but this is actually a foreign body response. Generally, foreign body response will not happen to these gel foam because every patient will be subject to hemostasis. Only some patients respond to this, means they are allergic to that material. So this is also a kind of example of where exaggerated tissue response happen to the material that was used as a hemostatic agent. So here I'm showing classical cases, but when the biopsy is small or the response is more, that can confuse us. So variety of material, these are the different names are given to these kind of masses, textiloma, gossipoma, all the gossipy bioma, all those things are there. Yes, that is there. Yeah, that's the name given actually. So these are the hemostatic materials. Many names are there, but problem is already a tumor is removed. So mass is occurred in the same region. So you need strong evidence to indicate that it's not a recurrence or anything, but there are many other lesions which can come in the area. You have to convince the patient, convince the clinician also, and like that. So basically, we are dealing with this second group. This is the fifth group iatrogenic, right? So iatrogenic causes, and this in that I would say radiation associated necrosis or therapy associated changes are the one which you should be most careful and aware of it. Now comes the last category, miscellaneous category. We'll put everything together. Now I am not going to the individual cases as such. You know, cellular mass, it was suspected craniopharyngioma. This is what? Craniopharyngioma, you know, two types, adamantinomatous, and another one is this papillary. Adamantinomatous is straightforward because you have wet keratin and you have that palisading, then stellate reticulum. That is not there. But papillary is one which will not show any of these findings. It will not show wet keratin. It will not show the palisading. It will not show stellate reticulum, none of this. It will show papillae, but lined by multiple non-keratinizing squamous epithelium. And this is a cyst where you are seeing multi-layered squamous epithelium. Okay, and here you can see, but no papillae, all those things, only epithelium there. So obviously here craniopharyngioma was suspected, but this is actually, if you carefully look at this, here cilia has come. Can you see it? Ciliated columnar, some columnar, here also ciliated columnar. Basically, this was a Rathke's cleft cyst, which has got secondly inflamed and showing squamous metaplasia. So if the inflammation is more florid, then the metaplasia will also be more florid. Then you may call it as a cystic craniopharyngioma like that. Okay, that is also a risk factor. Now, this is one recent case where it came with a lesion in the spine, suspected to be an osteochondroma. Okay, because there was some growth also, bony spicules also were there. But this is actually a spotter for a pathologist. What is this? Okay, basically, yeah, a vascular lesion, and you know, variety of vascular proliferation will come. You know, variety of hemangiomatous lesion will come. So this is actually an hemangioma of the spine. Sometimes this is again another cavernous hemangioma in the same skull base. A lot of fibrin deposition was there, all those things. It had in cranium, you know, meningioma causes a special unique bone change. Can anybody answer? It impinges on the bone and stimulates bone formation. It's called as hyperostosis. You are aware of that, right? Hyperostosis. Similarly, this was causing the opposite. It was causing bone erosion, and it had extended into the bone diploid skull, and bone lysis was there. It has a dumbbell-shaped phenomenon. So they suspected a bony lesion. So aneurysmal bone cyst versus giant cell tumor versus osteosarcoma, all differential was given. But this turned out to be a vascular lesion, actually with a lot of fibrin deposition. So that completes this post-traumatic, I told, vascular included, idiopathic, all these things comes under this. So basically, in this region of all those things, one word I want to talk about pachymeningitis. See, pachymeninges, leptomeninges, your word. Leptomeninges is pia and arachnoid. In that, arachnoid takes the major role. Dura is also called as pachymeninges. Now, dura uniqueness is, I like to talk about that because there is a lot of importance because similarities are there outside the brain also, outside the cranium. Leptomeninges is highly vascular. That's why any hematogenous infection goes to meninges easily. You get meningitis, meningism in all viral infections, all those things because it's very vascular. Opposite is for dura. Dura is least vascular. Okay. So infections hardly reach there. By chance, if it reaches, very difficult to treat because your antibiotics will not reach in adequate dosage there. Okay. So this one, suppose you have inflammation, let's take some infection will reach there. How does it respond? It responds in the form of irritation. Let's take simple example. You have heard about hemarthrosis. Typical hemophilia case, hemarthrosis there. And that goes to hemarthritis and you get capsule being thickened and you get thickening of the capsule, compromising this. Similarly, you have blood in the pleura, pleuritis, all those things happen. Same blood, our own blood, can cause irritation to the dura. It won't accept that one. What is supposed to be intravascular has come here irritation. So imagine an organism goes there. That will also cause similar tissue response, inflammation, irritation. So what happens? The dura goes on adding layer by layer fibrosis. So this creates a thickened dura. Thickened dura, if it is vascular, when the inflammation will create vascularity, you know that neovascularization, will give rise to a contrast enhancement on radiology. So this is called as hypertrophic pachymeningitis. Now the differential diagnosis for this thickened, abnormally enhancing dura are all these things. So dural pathology, you have differentials ranging from infection to autoimmune to neoplasm. You can easily appreciate that in all these things, the common thing is mass formation, compressing on the brain. Neoplasm as such is a new growth. It causes a new compression, no doubt about it. But the other two, mass effect is mainly because of exaggerated tissue response, proliferation of fibroblasts. So both infection and immune, we discussed both causes in relation to other aspects of the brain and dura. But here I'm talking purely about dura. So all these causes thickening of the dura, which could be diffuse or it could be localized, compressing the brain, causing mass effect, enhancing on contrast. So it will look like a mass effect. All these are examples for pseudoneoplastic conditions. Now, many times you will not be able to find out the exact, you will be telling that it is inflamed. You know that it is hypertrophic, that dura is thickened, but you are not able to find out the exact cause. Then what do you call idiopathic? Idiopathic means we have failed to find out the cause, not that it is unknown. Okay. So idiopathic hypertrophic meningitis. This is very important because in this, the most challenging is, of course, you can identify these easily. The problem is infection immunological. Infection, until unless you demonstrate the organism, you don't know what is causing that. Immunological as such is a enigma, right? It's very difficult. It's a mystery to pick up the exact pathology or exact etiology for autoimmune disorders, all those things. So this, I want to convey that it's extremely difficult. These are the challenging cases which you will see and trouble you. But the same principle what applies for dura is applicable for many other membranes in our body. You can take the joint capsule, you can take pleura, pericardium, peritoneum, same situations. Okay, and you can get same situation where you will be suspecting deposits in the pleura, deposits in the joint, all those things will happen. So in short, the ultimate pathogenesis reason for all these pseudoneoplastic mimic is because of an exaggerated host response, is it not? And this could be basically reactive, but it will involve a lot of infiltration by accompanying cells, and which causes architectural disruption of the parenchyma or the tissue in question. And in addition to, there are cells which have its own cytomorphological differences, giving rise to a very strong stromal response and confusing clinically, radiologically, and pathologically. So this summarizes the full neoplasm. And one example I will give you, this just 2 days old when I was arranging this came. This is a typical case of ANCA positive vasculitis. Okay. You can see granulomatous angiitis here, these lymphocytes here. You can see vague granuloma. Of course, see P-ANCA came positive in this case. Sorry, not P-ANCA, C-ANCA. P-ANCA was weak actually. You can see this here. What I'm telling you is you can see the activity here in the rest of the parenchyma. Extreme gliotic and microglial and histiocytic activity. So this can cause a lot of problem. The differential diagnosis can range from an viral encephalitis versus a lymphoma. All those things will come up on radiology. And similarly, if the cells are too much, too much lymphocytes are there, it will bother the pathologist also whether you're dealing with a lymphoproliferative condition. So just wanted to mention that it's basically an inappropriate or exaggerated tissue response, which gives rise to the most difficult kind of picture, which confuses the not only the clinician radiologist, but also the pathologist. In CNS, it's very important because though there are no fibroblasts in the brain, but the gliotic is extremely erratic. Gliotic response is extremely erratic, which can take any form, any degree, any extent. And not to forget, please apply this principle to the rest of the body. Like for example, traumatic neuroma, it's not a true proliferation, it's trauma. Trauma doesn't mean here that you have to cut the nerve, even a compression. There are many situations where people are using slings and all those things that also, has caused neural proliferation. Okay, ruptured cyst, variety of places has caused extreme degree of confusion. If you go on, there are big lists under each organ, okay, which can mimic that pseudoneoplastic condition. So one word of summary is that any expansive intracranial lesion will look like a tumor, but they are not. Many causes are there for this pseudotumoral appearance. Each of them one has to be aware of it and use it. Of course, the challenge is added by the kind of biopsy we are receiving these days. Small size with artifacts. Always keep this in mind that when you're dealing with a case which is not, which is in the gray zone, of course, typical case of benign malignant are easy, but very few occasions that we get typical cases. Most of the times either the disease itself modifies or our handling will modify. So you have to be careful and keep that in the differential diagnosis. It's just that awareness. As madam in the morning we were mentioning, many situations we will come to that decision, but how to, like, in a sense, convince the clinician radiologist like that. It's always correlation. One or the other way we have to communicate each other. It's not that easy, as said, but see that one or the other way, one of them will be out of the box, either clinical decision or radiological. But many times they will be, if they are persisting that they are indicating that it is like it is, maybe we also may be in the wrong direction. That also you should be aware, not be too overconfident. So go back to the slide, take deep pulse, evaluate more. You may see small areas of neoplasm also, because neoplasms are not free of inflammation. There are tumors which can show extreme degree of inflammation, including abscess kind of picture, everything. And when in doubt, please take help of your seniors, colleagues, peers, juniors also, students also, because young mind will come with new thoughts. And of course, then you can evaluate with additional testing, additional markers, may not to confirm pseudoneoplasm, but to rule out the mimics. And you know, in our diagnosis, accurate diagnosis, there is no doubt and no second thought about accurate diagnosis. But problem what happens here, as long as we are junior, we don't know the privileges of a junior, because you are allowed to do big mistakes also. As you grow, the same small mistake, which is negligible, can be very costly, can be extremely powerful, can be very damaging to your future, like that, after a certain level of it. But nobody is immune from mistakes, but how you learn and handle it is most important. Thank you.
Come to know that it is a pseudoneoplasm. Like clinicians are suspecting malignancy and they'll say there is tumor. When we are seeing the slides, there is no tumor. Morphologically, many times we cannot give the diagnosis.
Correct,
only after doing panel of ISC to rule out malignancy, only that time will come to know diagnosis is a pseudoneoplasm.
That's true.
Correct, sir?
No, yeah, very correctly said. See, many times we may be confident that it is not a tumor, everything, but somehow one small element of doubt will be there, or you need one more evidence. See, many times actually you would have made a diagnosis, but still you feel like asking one more person. Just that if they support us, it will be so good. In the same way, IHC also plays a complementary role. And these days, since they are also aware of it and they are persisting that it is, they're insisting that it is so, it's not like that, please have a look, then you feel like one more evidence will be there. Somehow IHC has taken over now. We are totally dependent on, at least in the neuropathology point of view, 90% we have to depend on IHC. It has become so much that except schwannoma, everything we do, including meningioma, we do K60. That is the time these things happen. I don't think you should record this. Okay. Yeah, yes. Okay.
So thank you so much, sir. It was
Yeah.
very good talk.
Okay.
So thank you.
Thank you.
Thank you.